Okay. Review and consideration approval of the minutes of March 23rd. Do I hear a motion?
So moved. Is that a second? Oh, you weren't here.
I'll
so
second.
I have to abstain.
to abstain.
I'll second it.
Second.
All in favor?
Aye.
All right, with one abstention.
Minutes passed with one abstention.
Dr. Erbstrasser.
Oops, lost.
All right. Committee B.
Committee B. Any action on?
2 cases on
Let's
there.
get back to Committee B agenda. Call to order.
Did that?
Roll call.
You did that? You've already done that, so you're
Yeah,
good.
we're
So all we need to do is just the consent agenda. That's what
Consent
you did.
agenda for consideration of executive director dismissals. Any objections to these dismissals?
Have a motion?
Motion for approval.
So moved.
Second. All in
Second.
favor? Aye.
Aye.
So moved.
Motion for adjournment?
A motion for adjournment.
So moved.
Second. Committee adjourned.
Great. Committee A, Dr. Maiden.
Committee A, call
Oops.
to order, 0802 hours. Roll call, Dr. Speakerman.
Aye.
Mr. Landau is absent, and Dr. Maytem, I am present. Item 3 is a review, consideration, and approval of minutes. Did you have a chance to review the minutes, Dr. Speakerman?
Oh, yeah.
I don't think you
Apparently I
were
wasn't here, though.
Oh, he wasn't here. He has
Oh.
to recuse himself.
We'll have to
recuse
table
myself.
that for another time.
I'll have
So we
to,
can't do this. We can't do the minutes,
Can't
correct?
do the minutes.
Correct.
Okay. All right. So we'll hold the minutes.
Okay, I do not have a quorum for the approval of the minutes, so on to item number 4, consent agenda for consideration of executive director dismissals. Do I have a motion?
So moved.
I'll second that. All in favor?
Aye.
We uphold the executive dismissals. Item number 5 for adjournment. Do I have a motion?
So moved.
I'll second that. We're adjourned.
Okay, good. So we got committee A and B. I think we have to. Oops, there we go. Give me 1 second here. I got knocked off. We have to wait till 8:05, Gene.
Yes.
2 more minutes. Be patient, everyone. 2 more minutes.
Yes, I've
2 minutes.
somebody to reset. You're working right now? Okay, thank you so much. Do this. I want to go to fishing where you want. That's what I'm thinking about right now. No, I don't know what I'm thinking. I need somebody down the street and wanted to get in the building.
Great, thanks.
We have to move you to electronic, Dr. Mann.
There we go.
So how'd your daughter do?
Well,
I'd have to talk to my...
Can I have a roll call and a review of the agenda, Justin?
Dr. Speakerman.
Here.
Dr. Erbstrasser.
Present.
Dr. Madem.
Present.
Mr. Berg. Present. Dr. Reese.
Present.
Dr. Cunningham.
Here.
And Mr. Landau is absent.
Okay. We have a quorum then. I'm going to do the call to the public. Do we have any medical students here today? Any medical students? I think we're at that time when they've all graduated, when the new class doesn't start till July, so we'll skip A then, and we'll move on to B. If any member of the public who is not a respondent/licensee or applicant or complainant wishes to address the board on a matter that appears on the agenda, you will be asked to speak during the call to the public. If you want to address the board on an issue not on the agenda, you will also be asked to speak during the call to the public. All those wishing to speak should fill out a speaker form and give it to a staff member. The mission of the board is to protect the public by setting educational and training standards for licensure and by reviewing made against osteopathic physicians, interns, and residents to ensure that their conduct meets the standards and the profession as defined by law. I think we're going to, is there anybody here for the call to the public now? No? Okay. So let's move on. We have a busy agenda today. We're going to move on to 5, which is review and discussion and action on case reviews and allegations of unprofessional conduct.
I'm going to do 4 first.
Oh, I'm sorry. Excuse me. I'm rushing things already. So let's do review and consideration or approval of minutes. The first is A, March 23, 2019, open session. Has everyone had a chance to do that? Does Dr. Speakerman have to recuse himself?
I was there.
You were there, okay.
I was on there. Yeah, I was there
Okay,
March 23rd.
okay, I couldn't remember.
Earthstrasser is not.
Earthstrasser, so he has to recuse himself, okay, or abstain. Can I have a motion?
Motion to approve the minutes from
Second.
March 23.
Motion by Dr. Madem, a second by Dr. Reese. All in favor signify by saying aye.
Aye.
All opposed, same sign. All right, we'll go down to B, March 23, 2019, executive session. Again, Dr. Erbstrasser will have to abstain.
Do we have to approve the executive?
They're not available.
Oh, they're not available?
Just C, right?
Do we have to approve it or no?
Actually, you don't have to. They're just not available on your.
So would you prefer that we just move on then to C?
Yes.
Okay, we'll move on to C then, okay? And then we don't have to do then D, is that correct?
Correct.
All right. So then moving on to C, April 13, 2019, open session. Has everyone had a chance to review?
Yeah, motion to approve.
Motion to approve it by Dr. Madem.
Second.
Second by Dr. Reese. Any discussion?
Two recusals,
two
Speakerman and
yeah.
Earthstrasser.
Two recusals or abstentions is Dr. Erbstrasser and Dr. Speakerman. All in favor signify by saying aye.
Aye.
All opposed, same sign. We're done with the approval of the minutes, correct?
Yes.
Jumping the schedule here, I'm sorry about that. All right, so here we go to 5. This is review and discussion and action on case reviews of allegations of unprofessional conduct. These are just case reviews. This is where we're looking forward, looking at these cases, see if they should be moved forward to an investigative hearing, or should we just, or have some other sort of action. The first is DO-18-0066A, Michael James Tuttle, DO, license number 005688. Is Dr. Tuttle here?
Dr. Tuttle is not here, but the complainant in the case
Complainant is here. All right. Can the complainant come forward, please? Go ahead and have a seat right up there. And I'm trying to look. Thank you for coming, and please have a seat right there. This is where this is not an investigative hearing. We're just looking to see if we're going to move this more, if we have more information to move this forward to a full investigative hearing. And so I think that this is, who was it that had the cases here?
I had it.
You had the case.
And can they identify themselves?
Okay. Would you mind, and just use your initials, and if you're the complainant, can I identify who you are?
Okay, my name is TM.
And you were the complainant in this case?
Yes.
Okay. And who's with you?
Go ahead.
Kevin Chapman, I'm her attorney.
Oh, okay.
Yeah, an attorney. Okay.
Okay. Good. Welcome. Welcome. All right.
I have this written on my phone, so I want to go ahead and share it with you guys.
Hang on just a second. I'll let you touch speak here in just a minute. All right. First of all, the doctors that reviewed this case, do they have any questions here of what were the questions they had here?
I did not have a question.
Yeah, I didn't either. But I'd like to hear what she has to say. Maybe
Okay.
we'll generate
All
some.
right. Anybody want any questions on those? Go right ahead. Thank you.
I have had my fair share of surgeries and procedures. Not one has ever compared to this before. I feel compelled to address you guys. I suffered new compression fractures in my lower back in a car accident of December of 2016. After receiving a few opinions, I thought Dr. Terrence Crowder had the best idea. It was kind of like a trying before buying. I was able to put the spinal cord stimulator in my back without having a full-out surgery. It would be a trial stimulator, and it would be very minor. I wasn't even going to be completely under, and I would be awake to tell them the location of the leads. Then, if it was successful, I would have the full-out surgery. Since the procedure was so minor, I decided to take my daughters with me. We got to the surgical center of Tempe, and I was a little anxious but reassured I'd be fine, talking and being awake throughout the whole thing. That was not the case. When I woke up, staff seemed very stressed. They were working around me, and something felt disconnected. I didn't remember any part of the procedure. As I was starting to wake more up, I felt extremely weak and very disoriented. As I was gaining more consciousness, a nurse told me surgery had been canceled. That doesn't make sense. Why did I feel so drugged? But nothing happened and I would be fine. And I needed to not be concerned. My throat hurt so bad, and I was achy everywhere. I was told I would also had an asthma attack and needed to reschedule my procedure. I was sent home with no further questions, no further information. After arriving home, I could not sleep anymore due to the pain in my throat, and I was struggling to breathe. I couldn't stop coughing. My sister realized something was off and something bad had happened. She had realized that I was incubated or trached by the sound of my voice. She got my daughters to rush me to the emergency room. I could have died that night, and I truly believe that. To my surprise, at Mercy Gilbert Hospital, I found out I was in fact trached. My lungs were suctioned, and I ultimately coded. I was admitted and stayed almost a week at Gilbert Mercy Hospital. I was diagnosed with severe throat trauma, throat lacerations, aspiration pneumonitis, asthma exacerbation, if that's how you say it, I apologize, bronchospasms, and I lost my voice for a little over 3 months, not to mention the nightmares. The strangest part was the phone calls. The surgeon called me when I was in the emergency room to tell me that I should go to the emergency room because I might have had a fever. The very next day, the anesthesiologist called me, and I remember him telling me that he needed to speak to me. I did not feel good, and I did not feel strong enough to speak without my husband. He said, "That's fine. All I had to do was listen." He called me almost daily until I was released from the hospital. He actually called me several times once I was home. He reassured me that his record was clean and he had never had any issues before. The last time I spoke to Dr. Tuttle, I had these questions for him. If he did nothing wrong, and if I had complications, why didn't you send me to the hospital? Why didn't somebody call 911? He said everything would be okay and my voice would be back and my breathing would subside. It wasn't a big deal. However, since I canceled surgery, I have to take 2 inhalers a day. I wake up every day wondering why I'm still here. Things are not okay, and I still have the same questions for this doctor.
Thank you. Questions from board members?
I'm trying to put together the timeline here. So I'm a little bit confused on your surgery was when? Like it was on a Tuesday, and then kind of give me the timeline.
Very early in the morning. I think we got there about 6 a.m.
And the procedure that you understood that they were doing was what?
I was basically going to stay awake. I was supposed to be lightly medicated, but I was supposed to explain to them where the leads were going to go in the right places of my back. This is not the first break in my back that I've had.
So you, to your knowledge, you were not supposed to be put under. But if there was a complication, that was something that they would that would be, because obviously with a medical procedure, if you go a little too far under, intubating somebody is a known complication of it. Were you informed of that, to your knowledge?
Not at all. I wasn't informed of anything. I was literally just sent home.
Okay, no. That's not what I'm asking. So any sort of procedure that we do, that even if you're under light sedation, when you sign typically those consents, in it says if you have problems with breathing or respiration or things like that, it will say, or you code, we need to do emergency procedures. Part of that emergency procedure would be intubation. Okay. And I would imagine that when you sign those consents, I realize that most people don't read them. Okay. That would be what I would want to know is when they consented you, did they say that there is a possibility that you would need to be put under? Did they mention that to you at all?
No.
Okay.
I was to remain awake because I had to tell them exactly where they were going.
Oh, I understand.
Okay.
Totally.
Sorry.
No, you're doing fine. But what happens is, so for example, when I do a circumcision, I say, there's risks and benefits and stuff like that. If I do this and this happens, then I'm going to stop the circumcision and I'm going to send you to a urologist. Okay. So there's implied if something goes wrong, this is what I'm going to have to do. Because,
right.
And if they're using propofol or light sedation on you, so Versed, Valium, one of those common things.
Right.
Part of the side effect of those medications is respiratory suppression. You follow me, right?
Absolutely.
Okay, perfect. So in those procedures, when an anesthesiologist then says to you, we're going to be putting you under light sedation, if for some reason you get respiratory issues or aspiration or any of those, and we have to intubate you, that's a known complication of anesthetic. Did they say anything like that to you?
No.
Okay, that's what I needed.
No, and you just said something, too, that reminded me, if you don't mind me saying that, if
Please.
You had a problem, you would send them to another doctor. I had a complication and I wasn't sent
No.
for anything.
This is... you're confused one for the other. No,
Okay.
You're confusing one thing for the other.
I'm going to tell you that right now I think there's enough questions here that I'm going to move it forward to investigation. I'm going to make a motion that we move this to an investigative hearing. Can I have a second? Second by Dr. Maiden. Motion was by myself. All in favor? And I'm sorry, Dr. Reese. I'm sorry, Dr. Reese is a second. All in favor signify by saying aye.
Aye.
So we will move this case forward to an investigative hearing. Staff will be in contact with you when we will put this on the agenda for a full investigation. You were very informative. Thank you for taking your time out of your day and coming to talk to us. Thank you.
Thank you.
Let's then, the second one is DO-18-0105A, Ayad Agaga, I can never say that, Aga, license number 4341. Is the doctor here?
Doctor signed in to speak.
Hi, doctor. Welcome. Thank you for coming. I'm so sorry I didn't say your name correctly. I apologize. What was there were three people that had questions here. Who were there? I'm going to look here real quick. Speakerman. Dr. Maiden had a question.
Correct. Yeah, the outside medical consultant had enough information that I felt it needed to be brought forward for the investigative hearing.
What was your like I said, I don't think there wasn't a bad outcome. I think the question was about how aggressive everything was done. We could spend a lot of time here and go through it now, but I don't want to do it at this level. And how do other board members feel? Do they feel we should move this forward to an investigative hearing? Or
it requires that there were several points that were brought up.
I would agree with that. Yeah. Dr. Herbstrom, do you feel the same? So, and I'm sorry, Doctor, I'm glad you're here. And I understand that you took time out of your day on a Saturday, but is there anything that you would like to say briefly to us that would make us seem differently than why we'd want to move this not forward?
Thank you for giving me the opportunity.
Oh, sure.
I actually brought some 7 articles that she was printing
to
the front since from June 2018. If I can raise something up, I treat a lot of thromboembolic disease.
Talk right into to the microphone there for everybody. Thank you.
I treat a lot of DVTs, and I want to bring something up. These articles, I treat them aggressively, not because that's the other option. And the 7 articles, actually, there's more. The most common death is DVT, pulmonary embolus, in adults in this country. In this situation itself, I'll just review it and I'll be very fast. I received a call at 5 o'clock in the afternoon from her physician that he had a patient that had a little bit short of breath, but mainly it was positive DVT that was read by another radiologist. So I said to him, I was at a father-in-law burial. I said, I can't come now, but she needs to go to the ER. He asked if there's a way we can schedule. I said, well, if she's refusing the ER, then that's up to you. It did get scheduled. She didn't go to the ER. She called the following day wanting to come in. We started on Xarelto like we always do. When she came in, I did a venogram, and we found thrombus in her leg and some in the high iliac. We also did a pulmonary angiogram at the same time, and I placed a prophylactic filter. The following day, because I was in an outpatient center, by the way, which I am not at that place anymore. I was at Simon Med. I'm no longer at Simon Med because of a lot of times I had issues with the imaging, and I had left the practice since. The following day, she had some soreness in her neck where we went in the interjugular vein and her leg. She went to the ER at 6 o'clock in the morning or 5 o'clock when the doctor was calling the ER. Even if they have my cell phone, she was calling to the Simon Med. It didn't forward to anybody else. So she got frustrated, went to the ER. The doctor got frustrated. She called me. I've known her for a long time from before. I used to work with the same group. The second time that group has sent for turf war or something, whenever, she said to me, well, Dr. Medina thought it should have been done in the hospital anyway. And I know Dr. Medina very well, who's an IR guy. Then she claimed that the doctor that sent the order is a quack because he's not a real doctor, she said. But either way, I said, look, when I went in, I found clots, and I placed the prophylactic filter. Nothing went. The patient didn't have any issues. The ordering physician didn't have any issues. There were no complications. There were no problems. That's how it's treated. The problem I had is this physician had it out. She's known me from before. She didn't like the fact that we're competing across the street, literally across the street from Chandler Hospital.
Did you see our consultant's report, though? You don't have any relationship with him, though, do you? Our consultant's report.
I don't know who. I never saw any of that. I don't know who the consultant is. I'm sorry.
So I'm going to stop you right there. And I understand that you felt this patient needed to be treated aggressively and so forth. Our consultant gave us that he thought that this was an aggressive treatment. What I'd like to do is I'd like to direct staff and please don't think that this is something that's punitive against you. I think we just want to get a flavor of your practice, doctor, and see how you're practicing. I'd like to direct staff to review 10 charts before we have him come forward and move this to investigative. First, let's move it to investigative hearing. So I'll make a motion to do that. Can I have a second? Second. Who was that? Dr. Matum. All in favor signify by saying aye.
Aye.
All opposed, same sign. And then I want to direct staff to then have 10 charts reviewed at the doctor's office, and then we'll come back forward. And Dr. Pra, when do you think you want to try and set this for? You want to try and do it in August or September? What do you think? Or just let you decide?
Either one.
September gives a little more time.
Here's
the thing. There was no harm identified. I mean,
no. So I think
not dangerous.
Yeah. So let's do it September.
We just have to. Essentially, I dismissed it, but the reason that we're looking at is we just want to make sure that when these things come forward, it's okay to be aggressive. It's okay, as long as you're doing good at what you're doing, you're not going to have a problem. So.
Okay, may I say something?
Please.
I'm sorry. It's not about I'm not any more aggressive. Again, I'm treating. So just since then, and I hope you guys can get these articles and look at them. Boston Scientific, the largest, $11 billion company. I was picked to be their just for IVC filter placements and removals. They're using me as an expert, and I actually placed the first filter in the world that's biodegradable filter just less than 6 months ago. We did the first 100. None of my patients have had any serious complications.
And I'm glad to hear that.
1,200
I'm really glad to
patients
hear that.
I've done.
I'm glad to hear that.
It's not about being too aggressive. I only am. The idea is the filter is a prophylactic filter, but at the same time, if you have a clot, and the lady had a PE. She created shortness of breath. And the clot was, when you do these images, basically you get a negative image when there's a thrombus. If it looks like it's a floating thrombus, where the ultrasound tech said it is, then my images show that there's a floating thrombus. If I don't, I'll be here telling me, why did you not protect this lady?
I get it. We honestly get it. We're just being overly cautious. That's all we're doing, doctor. Okay?
But I feel like...
So we'll
say it the way it is, that someone said you were overly aggressive. You're saying you're not, and we have to be sure that you're not.
Okay. So we'll see in September. Okay, doctor? All right.
It's the same group, though. That's what they did the last time.
But this is, I don't believe this doctor is...
No, not the same doctor.
It's a consultant.
It's the same, yeah.
So we'll be happy to see you then in September, okay? Thank you for coming down here, though.
Thank you.
Thank you.
And Dr. Cunningham, we do have the articles that he provided, and you will be given those prior to the investigation.
And we will review those.
We'll review the articles.
Promise.
Thank you for bringing them, okay?
Thank you very much.
Yes.
What would you like me to concentrate on in the chart reviews?
I would same type of cases like this particular one was. Okay. Thank you for coming. Thank you. All right. Next case is case review is DO-18-0113A. Bryman David Friedman, DO, license number 006111. Is Dr. Friedman here?
Dr.
Friedman, please come forward.
As well as the complainant in the case.
The complainant's here as well? Okay. All right. You can have a seat right there. And the complainant is here as well?
Yes.
Can the complainant have a seat right over on that side? Thank you. All right. Thank you for coming. Have a seat right there. Thank you. So, I'm trying to remember who the people were that reviewed this again.
I did. I thought it was within the standard of care, but there were two others who had... No, I didn't read this one.
Dr.
Look at that.
Sorry, this is Dr. Erbstrasser.
Yes.
And Mr. Landau. And Dr. Reese. Did you have any questions? You wrote dismissals. Any questions?
Well, yeah,
What were the questions
I
you
got
had,
some
Dr.
questions.
Erbstrasser?
Okay, so, Dr. Friedman, you did surgery on this gentleman for sinusitis, chronic pansinusitis, correct?
Yes, doctor.
And what kind of complications after the surgery did he develop?
This gentleman developed radiographical findings of pneumocephalus and CSF rhinorrhea from a defect in the right fovea ethmoidalis.
Have you ever had that complication before?
This is not a complication I've had before.
And you referred the patient to Dr. Reel.
Yes.
And Dr. Reel did what?
Dr. Reel took a nasal floor mucosal graft, patched a 1 centimeter deficit in the fovea ethmoidalis, and then used Tacil, followed by surgical packing to facilitate healing of what he felt was a ball valve defect.
Are you unable to do those kind of procedures?
Doctor, this is a procedure I'm comfortable with. When I had spoke to Dr. Reel about it, we were going to do bed rest, head-to-bed elevation to see if radiographically it improved. It had. This gentleman had returned back with a little bit of symptom progression, recurrence of pain. I spoke with Dr. Reel. We had set up from his hospital discharge an evaluation with Dr. Reel. Dr. Reel said this is a surgery that he wanted to do. Do I feel comfortable in doing it? I did, but I wanted to give the benefit of the radiographical evidence and clinical improvement a chance. And then when there was further pain or discomfort, I wanted an expert who specialized in it to give this patient the optimalist of care.
How big was the defect?
1 centimeter.
It seems pretty big.
1 centimeter. He used. I don't know if that would be a very big defect with respects to. This is not that big. 1 centimeter.
Well, I think trying to let that heal over time it wasn't going to heal.
Doctor, it was healing. The cisternogram fluid showed a diminishment in its leak, as did the pneumocephalus. Radiographical imaging showed significant improvement in it, more than 75%. It was going in the right direction. But because of his symptomatology, you can say, okay, listen, he's on prophylactic antibiotics, he's getting better. Or because of his pain or discomforts, we can go in there and intervene. So the decision was made to intervene on his symptomatology and discomforts.
So we can assume that the defect was larger at the time after surgery?
No, this is what Dr. Reel had said. It was a 1 centimeter defect in the fovea ethmoidalis.
It was just healing.
It
had to have been bigger.
The imaging that showed it was a very narrow area, the defect that it was leaking out of, and my feedback from Ryan Reel was it was 1 centimeter. Could it have healed while it was going? Yes, it could have.
Okay. And then I have one more question.
Sure, doctor.
The reviewer, Dr. Baldry, on this case, commented on the fact that there was an extensive amount of surgery done for what he would describe maybe not be warranted based on the CT scan. Okay? And I was looking at the CT scan, and I'm just going to read the impression.
Sure.
Okay? Impression, mucosal thickening in the left maxillary antrums and the anterior right ethmoid air cells. Intrinsically narrowed but patent osteometal units, narrowing and probable obstruction of the right frontal sinus outflow tract. The left frontal sinus outflow tract appears to be patent. Mild sigmoid deviation of the nasal septum, and that was the 4 impressions that were on it. And then I look at your operative report and the procedures performed. I'm going to read them. There were 7 of them. And I think some of these are warranted, and then I questioned some of the other ones. Submucosal resection of the inferior turbinates without fracture bilateral, septoplasty, maxillary antrostomies with removal of tissue bilateral, frontal sinusotomies or sinuectomies with removal of tissue bilateral, total ethmoidectomies bilateral with removal of tissue, sphenoid sinuectomies bilateral, contrabalusa resection of the middle turbinate bilateral. So, boy, I was looking at the CT. So what made you do all of those?
Dr. Erbstrasser, would you mind just a second? Because this is just a case review.
Oh, okay.
So, not investigative hearing. I appreciate all your questions. I think that it's certainly in my mind made me want to move this forward. So I want to hold just a minute and just let the complainant speak for just a couple of minutes here and see what he has to say, okay?
Okay, so when I went into surgery, when I woke up, initially I felt pretty good. And then just this wave of pain came over me when I was in recovery. The staff at Greenbaum basically just, I know this isn't about them, but they gave me a couple doses of morphine, then fentanyl, then Percocet just to get me to the point, and Zofran to where I could barely manage to walk out. Well, I didn't walk out, wheelchaired out. 5 days later, when I went back to the hospital, I went to Osborne, obviously found the leak. I was there for 7 days, out for a week, went back for another 8 days due to all the pain that I was in. According to my medical records that I have, I don't have it with me, but I can absolutely get it to you. It says that there was a 10-millimeter hole, which is, to me, I mean, I know what 10 millimeters is. That seems pretty monstrous for.
So you're speaking about
for being in the brain lining. Some of my main issues are with one thing. My second stay in the hospital, I had a couple CT cysternograms, and the second one, the radiologist said there's still a leak. Not as bad as it was, but it's still there. I believe it was Dr. Friedman that asked for a second opinion. Another person looked at it, and they said they didn't think there was a leak anymore. I expressed concern that I could still feel this like wetness coming into the right side on my nose. And it was kind of, I felt like it was somewhat dismissed. Dr. Friedman said, if you still feel like you need to go see Dr. Reel, that's up to you. And I said I wanted to do that, and he did agree that it was probably a good idea to follow up with him. I followed up, and he said there's absolutely still a leak. He said as soon as you're off antibiotics, you're at a huge risk for meningitis. He said injuries of this size do not heal on their own. Dr. Friedman had told me that I was better off not having surgery, and that even as much as a year down the road, something as simple as a sneeze could pop the patch out. Dr. Reel, I asked him about that prior to the surgery, and he said it's completely untrue. He said that once that patch, once the brain lining heals back over it, he said it's going to be as if it never happened. Once it fully heals, he went so far as to say you could go join combat sports and get kicked in the head, and you'll be fine. And he was very adamant about the fact that something like this is just never going to heal on its own.
I appreciate you bringing the information to the board here. Can I have a motion from a board member?
Dr. Cunningham, may I interject one?
Wait a second.
Okay.
No, you want to
move for executive hearing? I'd like to move this for an investigative hearing.
Move for investigative. Do I have a second?
I'll second.
All in favor signify by saying aye.
Aye.
All opposed, saying aye. Dr. Friedman, you can say more when we go to investigative hearing. We've got to move forward, okay? We have a lot of cases today. Thank you both for being here, Dr. Friedman, and also thank you as well.
Thank you.
Thank you for coming. Thank you for your time. Are we ready to move into investigative hearings?
Yeah.
Okay, so I'm going to recuse myself from the first case here. I'm going to have Dr. Reese. He will then take charge here, and we'll hear this case. He has been a past board chair. We don't have Mr. Landau here, the vice chair, so Dr. Reese will take care of this. And I'm going to go next door. Thank you.
This is case number 6, review, discussion, and action on investigative hearings. And case AZDO 180-196A, Dr. Don Cunningham.
The doctor and his attorney are signed in to speak, as well as the complainant. If you'd all come forward, please.
Dr. Cunningham, will you take this side? Do you want to swear them?
Do you solemnly swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Dr. Cunningham, do you wish to introduce your attorney to the court? He may not be familiar with
My attorney is Steve Myers.
And Dr. Reese, at times Dr. Cunningham speaks very softly, so if you can't hear him, I'll try to get him as close as possible to the microphone, and after the staff presentation, he would like to make a presentation to the board, and I have a very brief presentation.
Do you want to give us the content of it?
On August 27th, 2018.
First of all, is the complainant here?
I think so. We should bring them forward. Yeah.
Complaint.
I apologize, I misspoke. The complainant is
not here.
He's not here.
There is no complainant. It was self-report.
Yep, I'm looking at it right here.
Dr. Don Cunningham self-reported that he mistakenly authorized a prescription for a controlled substance for his wife, patient LC, under the name of another provider. The physician's assistant, who he was supervising, had been treating Dr. Cunningham's wife and advised him she no longer wished to do so. Believing that the PA would provide LC with 30 days of coverage, Dr. Cunningham approved a prescription for his wife, LC, assigned to the PA when he was called by his office and asked for a permission to call it in. The PA did not approve the prescription and resigned over the incident. Dr. Cunningham subsequently canceled the refill. Dr. Cunningham provided an additional board response that noted that he's taken CME with regard to prescribing controlled substances, and he also his wife has been transferred to the care of a physician who is not part of their practice, and they've adopted a policy in their practice such that family members of health professionals employed by the practice will not be treated under any circumstances.
You want to give us your response, Dr. Cunningham? What you prepared? I understand this is self-reported, and you've made all of the proper amendments, whatever you can. So, just give us a small.
I thank the board for taking time to see me this morning. I wish to apologize to the members of the board for my terrible misjudgment in directing an MA in our practice to refill a prescription for Xanax for my wife, LC. My wife, LC, had been in the care of P.A. Legros of our practice for 2 years. I wrongly assumed that Miss Legros, who had told me earlier that day that she would no longer wish to prescribe Xanax to my wife, would continue to treat and prescribe for LC for the next 30 days. I should not have assumed that P.A. Legros would continue to prescribe for LC for a period after that, as she told me that she would no longer do so. Under the circumstances, the prescription for Xanax was refilled wrongly under P.A. Legros, which was authorized by me. To the board members, I again apologize. When making a mistake such as this one, which cannot be undone, I believe that all that I can do is candidly acknowledge that I did so. I have made changes to try to assure that the same or similar circumstances do not reoccur. The most important step that I have undertaken is to change our practice policies so that family members of the healthcare professionals employed by our practice are not treated by our practice. I have discovered that other physician groups have implemented the same policy. I believe that this is a wise policy, and if this has been previously implemented by our practice, these and other potential concerning practices would not have occurred. In connection with this policy, my wife's care was transferred to a physician not associated with our practice. This decision has assured greater objectivity in the care of LC and has resulted in her being successfully weaned off Xanax. The other steps that I have taken as a result of my error in judgment has been to undertake continuing medical education I have completed courses in prescribing, medical records keeping, and medical ethics. The certificates of the compliance of these courses have been provided to the board. In closing, I acknowledge my terrible mistake in ordering the prescription to be refilled. I apologize to this board again, and I thank you for your consideration.
I had about 30 seconds, but I'll cut it to 5 seconds, and that is he's had a very, very long, unblemished career with this board.
And if I understand, Dr. Cunningham, this was a single episode, and it was in a situation where you were fairly certain that your MA or PA, your PA prescribed this medication, and it was just you backing up the fact that this was prescribed but didn't get through somehow, if I've got it correctly.
Yes, and we were planning on leaving town. It was on a Friday, and it caught me in a lurch, and so I did it, and I should not have.
Okay.
And you self-reported as soon as you figured it out, and then, I mean...
Yes, sir, I
You
did.
made a mistake, and you self-reported, and...
There's an old German expression, einmal is keinmal, which means that one time is no time. I don't know what else you could do to atone and expiate for this event. I commend you for doing all that you did. You've taken it beyond what we would have suggested you do. So.
Well, I've been through the PACE course, the medical ethics, and the medical records.
You made a mistake and you called yourself on it.
Called myself.
Okay.
I
think you've beat yourself up enough. And, there's also another old adage that because you worry about it, we don't have to worry about it.
Okay. Can we move to dismiss this?
I'll second it.
Thank you.
Any further discussion?
Yeah. All in favor of dismissal?
All in favor?
Aye.
Thank you so much.
Thank you. Mr. Meyer, good to see you.
Yeah, it is the problem. Crazy about prescription. It's just, but it's ridiculous. It's just,
no, I know.
All of it's just too far.
Good deal.
Justin, I think we have, you said, a couple applicants that need to, we're going to hold on the agenda here just for a minute, just take an interim pit stop here. We have two applicants, I guess, that we need to do here very quickly here. The first one you said was?
Dr. Park, case number 2018-0178.
Jae Sung Park, DO, DO license 18-0178A. Dr. Park, can you come forward? Thank you, Dr. Park. All right. And was this yours, John? Oh, you're doing. John isn't here today. I just noticed.
Right.
That. You're much better looking than John. I'll just tell you that. Okay. Go ahead.
Okay. Dr. Park is coming before the board as an applicant because he failed to disclose that he had been placed on probation during his training years. When he came before the board last time, he stated that that this occurred because he used an application service that failed to report the probation. He stated that he had actually disclosed this on every other license that he had in every other state. And he's licensed in California, Florida, Ohio, and Texas at this current time. And he also has expired licenses in several states. The board had concerns, and they asked him to provide the board with a copy of his license. And he stated that he had actually disclosed this on every other license that he had in every other state. And he also has expired licenses in several states. The board had concerns, and they asked him to provide the board with a copy of his license. And he stated that he had actually disclosed this on every other license that he had in every other state. And he also has expired licenses in several states. The board had concerns, and they asked him to provide the board with those licenses from the other states or the applications from the other states so that they could see that he indeed had disclosed it on those applications. So our staff attempted to help him get those applications there, and apparently it's very difficult to obtain the actual application from another state. They just don't readily give those out. Even we couldn't get them. We were able to obtain one, I think 3 though. And
I think so.
And in all 3 of those, Dr. Park had disclosed that he had been on probation previously.
Yeah. So. Any questions from board members? I think that's all we were looking for was some verification that this wasn't.
So this is a clarity.
That's all it was.
That's all I care about.
Can I have a motion?
Dismiss. I just have to tell them.
Approve. Hang on one second.
Just have to emphasize first that clerical errors are not okay. It's still your responsibility.
Can I say something?
That's why you're sitting here today.
Yeah, this is
so this is why you get to sit here.
Yeah, thanks very much for your time.
To approve his.
Yeah, hang on, let him just talk for a second.
I just want to say something. Thanks very much for everyone's time today, and this has been a learning lesson for myself. Having a medical license is not something automatic; it's a privilege, and it should be taken very seriously. And from now on, believe me, I'm going to be taking this time to make sure this never happens again.
So can I have a motion, would you say,
approve, please.
Dr. Speakerman for unrestricted license? Can I have a second? Second, Dr. Madem. Any discussion? All signify by saying aye.
Aye.
All opposed, same sign. Good luck. I hope you catch your flight.
Sir. Thank you.
You catch your flight back, sir.
Where are you going to be working, covering, Dr. Park?
My group covers a lot of the centers in Arizona, and
he's a radiologist.
No, that's what I want to know.
Yeah.
I don't know if I'm going to hear your voice at some point.
He's an ER doc, so you might be hearing him.
You might.
It's pleasure.
Who's the next case, Justin, you were saying?
It's Dr. Christopher Negrum, case number 2019-0073. Please go forward.
Which letter is that one?
It is G.
G?
8G.
Okay, DO-19-0073A, Christopher TFL Negra. Welcome. Welcome. This is this yours again too, Dr. Pra?
Go ahead. Sorry.
I'm going to need to hold.
Or is this yours, Justin? I don't know.
Either way.
I'm happy to if the board's ready. Dr. Negrum, is that how you?
Yeah, close enough.
Okay. Disclosed a yes answer on his application. The board requested to speak with him directly about the incident.
You want to review that incident just briefly for the board members?
Sure. So Dr. Negrum disclosed that he was pulled over in 2010 for a broken windshield that resulted at a DUI checkpoint. During the screening, the results of the urine analysis were negative for drugs or alcohol, but then resulted in a medical marijuana. I apologize. I'm trying to summarize this. We were negative for alcohol, but resulted in a positive screening for THC.
This was back in 2010,
correct.
Is that correct?
So actually it occurred in 2009, but it took about a year of going back and forth the courts to resolve the case, and it was 2010.
Now, that's a long time ago. Did you have a medical marijuana card or not?
No. I just consumed marijuana recreationally. I was in college, and then I was pulled over in a recreational area for a broken windshield, and I had blood and urine testing. My blood test showed negative for marijuana or alcohol, but the urine did show positive for metabolites from like maybe two weeks before that incident.
Okay. Do you use marijuana now?
No.
Okay.
And I haven't since.
Do you drink alcohol?
I do occasionally, yeah.
What do you usually drink?
I like Bud Light.
Okay. Just like on the weekend, like 1 or 2 years? Or?
Yeah.
Okay. Questions, Dr. Reese? No. Any questions from board members?
No.
All right. So What are you going to be doing here in Arizona? I'm curious.
So I'm a nocturnist in Florida, and I'll be doing some PRN work up at...
You're an internist, you said?
Nocturnist. Yeah, internist. Yeah.
I don't know what a nocturnist is.
So I work strictly at night.
Oh,
You're a vampire.
Trying to figure that one out.
I got it. I'm like, he's a vampire. I get it.
I think you need lots of caffeine. That's right. All right.
But things happen.
I was going to say,
what do you do at night?
well, I mostly supervise residents and do admissions.
Okay. Where are you going to be working here?
So Western Arizona Regional up by Kingman.
Okay. All right, good. And you might run into some of our people that we know in Lake Havasu then, too. All right.
Any motion to approve a full license?
Second. And I have so a motion to approve Dr. Madem for an unrestricted license. Second was Dr. Speakerman. Any discussion? All signify by saying aye.
Aye.
All opposed, same sign. Thank you for coming. Good luck to you, Doctor. Welcome to Arizona. All right. Any of the other applicants that we need to do quickly beforehand? Okay. Do we need to take a break, a biologic break? Is everybody okay? Sure. All right, let's take a 5-minute biologic break, you guys, okay? We'll be right back.
He would like to make a brief introduction, if it's okay with the board.
Okay. Hang on. We're going to go. I'll let you in just a minute, okay? Go ahead. This is your case to review also for us, Dr. Prawn. Thank you.
Dr. Lee self-reported that an action had been taken against him by the Washington State Department of Health, and this occurred after Dr. Lee was already licensed in Arizona. Dr. Lee responded that this action was originated when he was finishing the last 4 months of an interventional pain management fellowship while working under Dr. Frank. Is it Lee also?
It's
Lee?
No.
Spelled incorrectly, or spelled differently. The board began an investigation into 18 deaths of Dr. Lee's patients, meaning the elder Dr. Lee.
The other Dr. Lee.
The other Dr. Lee, with no involvement by Dr. Lee. As a result, everyone who worked with Dr. Lee had actions filed on their licenses. The allegations against Dr. Lee were later dismissed with an agreement that he applied to become board certified in addiction medicine by July of 2018. Dr. Lee reported he was not told that the practice was under medical investigation until nearly 6 months after he started working for Dr. Lee. At that time, he learned that the investigation centered on Dr. Lee's prescribing, which may have caused or contributed to the deaths of 18 patients. The board in Washington conducted a chart review of 10 of Dr. Lee's current
first
Dr.
names
Lee.
and last names.
Okay. Yeah. Your first name is? Jason. Dr. Jason Lee. Yeah, that would have been a good way to do it. Dr. Jason Lee, and reported that the allegations were. He reported the allegations were filed without asking him any specific questions regarding those 10 patients. The Washington State Board did have several concerns when they did this chart review. However, they noted that Dr. Jason Lee failed to perform independent, thorough medical evaluations. They reported that he defaulted to opiate-centric treatment plans. They've reported that he failed to conduct risk assessments in order to mitigate patient harm and drug abuse, diversion, and addiction. He failed to consider comorbidities. He failed to consider that people may be at serious risk for respiratory depression, overdose, or addiction and death because of comorbidities. He failed to define a treatment plan. They felt that he, despite repeated evidence of inconsistent drug screens, requests for early medication refills, inconsistent pill counts, and admitted drug misuse and abuse, he failed to enforce treatment compliance. Compliance was monitored with urine drug screens, and results were infrequently reviewed with patients. These aberrant findings of noncompliance, yet there was inconsistent enforcement with whether or not the medications were withheld or the patients were discharged from the practice. However, with all those findings, they simply asked him to become board certified. And so our board was very confused about how incongruent those two things were. We attempted to get a hold of Washington and try to find out what happened, what really happened. And they gave us bits and pieces. You see they're included in your board materials. They gave us bits and pieces that weren't really that helpful. They weren't anything that we didn't already have. I called myself and tried to speak to the investigator. The investigator told me, well, you can get all the information you need if you just do a public records request. So I tried to do a public records request, but they told me it would take until October to get anything and that we'd have to pay for it. So then I asked the AGs to call the Attorney General up in Washington, and they did, and they've never called them back. So we're really in this place where we really, can't at this point get any more information unless we wanted to wait until we could get public records, which will take several months.
That's what I was asking for. I wanted there was just kind of incomplete information, as I was thinking. But okay.
So we did everything we could.
Yeah. My first question is: did you get your board certification?
When I applied for the addiction medicine certification, I was deemed not eligible because I had a general pain practice, and the qualification is for somebody who has a broader practice in addiction medicine. So I report that to the Washington board, and they're in the process of trying to come up with a different board certification or different qualifications that I can do.
Okay. Go ahead. Well, let's go ahead and let his attorney make a statement.
Thank you, and we appreciate the extensive inquiry and the efforts.
Before you go on, I just didn't quite understand what you were trying to tell us the last time, that you are not qualified.
Yes, sir.
But you have is it because you don't have a license? Or?
No, it's because I don't have a broad practice in addiction medicine. So I deal with a lot of opioid pain medication, and the Board of Preventative Medicine, who oversees the addiction medicine certification, deemed that I'm not qualified because I don't have a broad enough practice in addiction medicine to sit for the exam.
Broad enough practice in addiction medicine to get a certification
in addiction medicine. Yes.
So what is what board certifications do you have right now?
Physical medicine and rehab.
Okay, and what is your scope of? So I can get an idea of what is your scope of practice right now.
It's interventional spine, pretty much. Okay. So I do interventional procedures in spine care, diagnosis and treatment. And then back when I was at Seattle Pain Center, it was a pain clinic, so we did a lot of opioid management. My current practice, I'm not doing a lot of opioid management at all, usually for acute pain, so fractures and stuff like that. But I do mainly just interventional procedures.
So how, on average, then, do you see a spine patient, you do a procedure on them, how long do you write for the opioids now?
I actually don't. So I usually start them off with non-opioid medication, so usually a steroid taper, gabapentin if they have radicular pain, some muscle relaxers, and then NSAIDs after the steroid taper. Usually I start them off with some conservative treatment first, depending on what their physical exam is like, usually physical therapy or chiropractic care, and then if they fail all of that, and if they don't have an MRI, I usually order an MRI and then recommend interventional procedures. If they have weakness, if they have red flag signs, I usually send them to have a surgical consult with one of our surgeons.
So, in other words, you don't prescribe any opioids at all?
I only for acute pain, sir.
For acute pain?
Yes. But
you don't do any maintenance with opioids?
So, As of this point, I'm currently covering for physicians that's leaving our office, so I have 3 patients on 3 or 4 on chronic pain management. In terms of my patient count, there's only one. She's about 88. She has multiple severe stenosis in her lumbar spine. She's not a surgical candidate. She's taking about a half of a Percocet 5 twice a day.
And you're able to manage without prescribing?
Yes. So this journey has been it's been educating for me. My understanding on pain medicine has evolved. Whereas back when I was at Seattle Pain, I thought that this was necessary, but now it's really not, because my interventional procedures has helped quite a few patients, and the ones that don't, they tend to get better with some surgical intervention. However, I do run into these patients here and there that are not a surgical candidate due to their comorbidities, their age, the severity of their pathology, and I feel that in those patients, certain small doses of opioid might be beneficial to sort of maintain their quality of life, especially as they're aging. But I really don't prescribe them often anymore, not really for chronic pain.
So your scope of practice here, what you're describing, is totally different than what you were doing there.
Yes.
So Gene, I have a legal question for you. If what he's doing here in the state is under our standards of care, hold on one second. Sorry. If under our standards of care, do we care what Washington says? Does that matter?
Well, yeah, because there was some.
Okay, because that's what I'm not understanding.
So that's what the issue is.
Okay.
But I can see he's wanting to speak. Let's give him 2 minutes. Let him speak, and then we can ask more questions.
Shed some light.
Yeah.
Okay. Actually, Jason's doing very well without me, so I'll make this very, very brief. One point of clarification: he is currently practicing in Pennsylvania. His parents are here. He has a lot of Arizona ties, and so he is interested in maintaining his Arizona license, but his current practice is in Pennsylvania.
Okay. Were you ever practicing here in Arizona or not?
All I did was my fellowship here, the 6 months of my fellowship here.
Where was that done at?
It was done at Sonoran Spine.
Okay. Go ahead.
So we had a lot of the same questions when we looked into the Washington file as the board had, and we did make some inquiries with Washington, had Washington Counsel help us take a look into it, and it really does look like Mr. Lee just had the misfortune of getting a job at the wrong place at the wrong time. Had he known that there was an active investigation of Seattle pain centers, he clearly would not have taken that position. He was very, very young in the practice. And then he, unfortunately, afterwards was just caught in the slipstream. They necessarily, as part of their ongoing investigation into Frank Lee's practices of opioid prescriptions, they necessarily looked into the practices of all of the other doctors who worked for him at any of the Seattle pain centers by a 10-chart review from each of the doctors. And it's very, very important to know that none of those patients identified as A through J in the Washington investigation records ever complained about Dr. Jason Lee's practices. In fact, I suspect they would be very surprised to know that anything about their care was ever even called into question. But that didn't stop Dr. Jason Lee here from cooperating fully with the Washington investigation. He agreed to the consent order, making very clear that he did not admit to any of the findings of fact in that consent order. He felt that was appropriate. But he agreed to that consent order that in his mind essentially was, well, I followed the protocols of Seattle Pain Center. And the protocols of Seattle Pain Center were the things that the Washington folks, the Washington board, was so concerned about. And so it really is unfortunate that he got the job at the wrong time up in Seattle. But in terms of his absolute compliance with everything the Washington board has asked for, it has been stellar. In fact, he's got an open dialogue with them right now to try to find a substitute certification program that he does qualify to sit for, so he can complete that, and the Washington board will recognize that as a satisfaction of its order. No suspension of license, no revocation, no probation, no other restrictions were placed. And so I think that sort of explains the incongruities that some of us saw when we looked into the papers, is they were really attacking the protocols of Seattle Pain Center.
Questions? Well, I just don't have any questions, but I just want to talk to Dr. Lee. So you're in pain management, you do procedures, all right, you're going to have chronic pain patients. It's inevitable.
Yes, sir.
Okay? So going back to what Dr. Prowl was saying about documentation is where you need to make sure you're clean and dry with that, okay? Because, you know, more eyes are going to be on you than me, right? I'm a family practitioner. So just make sure your ducks in a row. You do pain management agreements, periodically do urine drug screens, and just document. So that's something you should take when you go back to Pennsylvania, okay? I lived there too for 4 years.
Where'd you live?
I was up by the Pecan, Philadelphia, Osteopathic School.
I'm in Allentown.
Oh, yeah, sure. Yeah. Okay, so I recommend a dismissal.
Any question before? Dr. Mato?
Well, I still have concerns from what you were able to pull up. We still have the inconsistencies with the UDS screening, early refills. There's still several other layers of concern here. And although practice patterns might be changed, I don't think we can simply do an executive dismissal on this one. I think we need at least a letter of concern.
Dr. Reese, what do you feel?
I would go along with the dismissal. I don't know that he's young. He's trying hard to correct mistakes. I think what you're trying to get at is, what would be your recommendation? What would you want him to do differently?
I think he's already taken the actions he needs to take. However, I think it's our obligation to recognize that the practice was not correct. There were certainly some deficiencies there. However, I agree with you. I think he's taking the appropriate actions. I don't think we need to do anything punitive.
I just feel he's been through enough. I'm going to give him the pass and just go with dismissal.
I agree. I mean, it's one of those deals where my concern, like you said, it's a lot of times when you get hooked up into the system, it's like, so did the Nazis. You know what I mean? This is not that situation, but going with the flow is not always the best thing in the world. So, we went from one. I know. My point is I'm going to give you a pass on this one, but it is important that, like Dr. Madam says, is just because everybody else is doing it doesn't mean you should be doing it either. So,
and that's why I prefer my practice now. Is that it's more individualized to me. So,
I go dismiss.
Okay. I can see where Dr. Madam's coming from, and I'm going to tell you I was leaning that direction because I do think that there was violations of substandard care. I do understand that you're a young guy and that this was your first job out, unfortunately, with a practitioner that had egregious practice behaviors. And I think that clearly this was a learning experience for you, and I see that it seems to me, we haven't verified, we haven't done any chart reviews or things like that, but you're in Pennsylvania now, but you say that you are not doing opioid prescribing. And do you see the errors, as I was saying, I say that occurred with the other Dr. Lee?
Yes, sir, I did. Okay. I do.
Because my concern was they didn't give you a clean, that you were non-attributable to any of those other deaths. That was my concern. Oh. And they didn't give you just say that there were obviously issues. So that was my concern. So I was leaning more toward a letter of concern. That being said, I'll entertain a motion. That's just where I'm coming from. So I have a motion from
dismiss.
That was from. Did you make the motion?
Yeah, it was
Dr. Madam.
Yeah.
I'm sorry, Dr. Erbstrasser.
Which Dr. Mayton?
I am sorry, Dr. Erbstrasser. And then, and do I have a second then from Dr. Speakerman? Do I have any discussion before we vote?
No further.
Do we need a roll call?
We need a roll call. Absolutely.
Okay. Mr. Berg.
Aye.
Dr. Speakerman.
Aye.
Dr. Reese.
Yes.
Dr. Madam.
Nay.
Dr. Erbstrasser.
Yes.
Dr. Cunningham.
No. And I explained that reason why. Motion passes, though. Good luck to you, Doctor.
Thank you.
Hopefully this has been a learning experience to you and you can understand our concerns, okay?
Thank you so much
very much for your inclusion. Thank you. Fantastic.
Have a good.
Dr. Cunningham, the remaining individuals for Dr. Stiegler's case have arrived. If you'd like to.
Okay.
Return.
Let me get. I got knocked off here. Give me 2 seconds. I'm having difficulty again.
Did you get knocked off again?
Yeah, I don't know what the deal is. It's probably the operator. Okay. Let me get back up here. All right. So this is the next case is BDO-18-0144A. Travis Clark Stiegler, DO, license number 005512. Dr. Stiegler, please come forward.
Dr. Cunningham, we also have the complainants in the case,
okay,
as well as other individuals wishing to speak on behalf of both the complainant and the doctor.
Dr. Stiegler, just have a seat there, and you have your. Go ahead and swear in, Dr. Stiegler, please.
Could you raise your right hand, please? You solemnly swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God.
Yes, I do.
Okay, and would you introduce your counsel, please?
Lauren Weinsberg.
Welcome.
Weinsweig.
Welcome.
It's okay.
Welcome.
Weinsworth?
Weinsweig. It's a hard one.
Welcome. Dr. Prawn, I believe this is yours.
The complainant states that she was seen by Dr. Stiegler for OMT beginning in May of 2018. She alleges that while he was treating her for TMJ problems, he told her that massaging the muscles inside her mouth was erotic. She states that Dr. Stiegler often removed her shoes and boots and socks while she was lying on her stomach. She alleges he unhooked her bra twice. She states on at least 3 visits she heard him say, "Take off all your clothes." She alleges on her last visit with Dr. Stiegler, he massaged her hip bones, pelvic floor, and upper left thigh next to the vagina, then began to massage her pubis and vagina. The complainant alleges Dr. Stiegler asked her if she wanted him to come on the aqua bed with her. When I looked at medical records regarding this patient, she began treating with him in May of 2018. She asked him what he thought of EMDR because of her psychiatrist had recommended it. Dr. Stiegler recommended she discuss this with her mental health professionals. It was noted the patient was laughing inappropriately, moving around the table, and making odd noises and behaved childlike during OMT. In June of 2018, there was an incident in which Dr. Stiegler documented the patient had jumped out from behind the door doing karate punches as he entered the room. And after OMT, apparently the patient stated, "You're like a magician. It's amazing. I feel so much better." In June 29th, 2018, the patient noted she was having terrible anxiety and nightmares, which were making her unable to sleep. And she wanted help from him because she could not get in to see her psychiatrist. She stated, "I'm going to decompensate if I can't get some sleep," and she was crying when Dr. Stiegler entered the room. In July of 2018, Dr. Stiegler documented that the patient was loud, boisterous, and disruptive during treatment. Later, he documented after the treatment, the patient was excited about feeling better and said, "Oh my God, you fixed me, you're amazing." He stated she surprisingly jumped up, threw her arms around his neck in gratitude, and he noted it was actually mildly painful and he was uncomfortable with the gesture, and he informed the patient of such, which seemed to be really upsetting for her. He noted the patient appeared embarrassed and left somewhat disgruntled. He stated in his board response that he did not tell the patient that it was erotic to massage her TMJ muscles. He instead says that he said it was an exotic treatment. Dr. Stiegler admits he did joke with the patient one time about taking off all her clothes, but states he immediately told her he was joking. He noted that he did check for trigger points in the muscle groups in the pelvic girdle over her clothing, He states he also checked in areas in the lower abdominal muscles, the proximal thigh muscles, near the insertion of the ASIS, as well as muscle groups attached to the sacrum. He states the area was tender and he was performed muscle energy techniques to realign the pelvis. There were multiple letters from the patient's staff documenting that the patient often would leave the office laughing hysterically. Sometimes she was found crying hysterically and rocking on the floor in the treatment room. My concern with this case was that I felt that Dr. Stiegler should be using a chaperone while he's performing OMT, especially with female patients, especially if there's a psychiatric history.
Okay. Dr. Stiegler, would you care to comment on the case?
Yes, thank you.
Talk directly into the microphone because some of us are hard of hearing.
Okay. Thank you, Chairman and members of the board. I appreciate the opportunity to sit before you today and answer your questions. First, I'd like to give you some information about me and my recollections of my interactions with...
Could you just use initials?
Use initials, LT.
Sorry. I've been working at Munderloh Integrated Medical since April of 2016, where I'm the clinic medical director. I work to offer the community a comprehensive, multimodal approach to acute and chronic pain, minus opioid pain medications and controlled substances. I recall this patient very well. I saw her over 9 visits with initial complaints of jaw pain and subsequent complaints of neck, back, and sacroiliac pain. She exhibited very odd behavior at each visit, which I documented in the record. Twice on separate visits, I had to admonish her due to unpredictable, inappropriate behaviors, and in an effort to reinforce professional boundaries, as I also documented in my progress notes. The first incident occurred after an appointment when I encouraged her to attend a Krav Maga class. I encouraged her to attend such a class after she confided in me feelings of vulnerability, fear, and helplessness after spending an evening with her father. The following appointment, after the first class she attended, she jumped out from behind the door as I entered the room, performing what must have been a Krav Maga move toward me, which nearly hit me. It was very shocking at the time, and so I established a boundary with her, letting her know that was inappropriate behavior. That simple statement led to her being very worried and somber, to the point that she immediately questioned if I was still going to be her doctor, which I thought to be odd. The next incident, which required my reinforcing of a professional boundary, was actually during her last appointment. We were exiting the treatment room and entering the hallway. She was very excited that her pain was resolved with the adjustments performed, that she jumped up and threw her arms around my neck, saying something like, "You're amazing." I was uncomfortable with the gesture of appreciation, and it actually tweaked my head and neck down towards my chest, which I found to be painful. I told her something like, "If this kind of thing continues, I'm not going to be able to be your doctor anymore." She was very taken aback by that, and she appeared embarrassed and ashamed as she shifted her gaze down towards the ground. I could tell that my words were really upsetting for her. At that time, my assistant, Trent, who witnessed the incident, invited her into the Aquabed treatment room to spend 10 minutes lying on the massage bed where she normally ended her visits. When in the Aquabed room with the door closed, she could always be heard down the hall and into the other rooms laughing loudly and making noises. And that day was no different. After her time in the aquabed room, she left without further incident. Then I received this complaint about 2 months later. To say the least, it was very upsetting having to disclose this complaint to my employer and staff members was embarrassing and humbling. Having to inform my wife of the complaint was anxiety-provoking and disheartening. Some of the things that I have been accused of are appalling and simply not accurate. I am worried about my reputation in the community and with my colleagues, as well as with possible consequences of such a complaint with malpractice coverage and insurance companies. I'm terrified of any one of my children finding out about this and having to explain this situation to them. Just the thought of any one of my 3 daughters thinking about me in this way that this complaint implies is loathsome. My having to present before you today is embarrassing and very uncomfortable for me. I only tried to help this patient with her musculoskeletal complaints and with her emotional state when she presented one day in a desperate, upset state. She was definitely a challenging patient, as you can see from my notes and the statements that have been submitted by the other staff members who had interactions with her. I would discuss her behavior in our weekly clinic meetings so the other providers and employees were aware and we could manage her visits appropriately and with little effect on the other patients as possible. Even though I considered her behavior odd, unpredictable, and personally challenging, I perceived it as innocent and repeatedly encouraged her to establish healthy coping skills and recommended she discuss her issues with her psychologist and psychiatrist. I never dreamt that I would be accused of inappropriate conduct and can only presume that her psychiatric condition is contributing to her perception. Even now, I do not believe LT to be a malicious person. She has a good heart, and I enjoyed working with her despite the idiosyncrasies. I want to state emphatically that I did not touch this patient in an inappropriate way. In our interactions, I acted professionally as I do with all my patients, and she only ever expressed gratitude for the care that I provided. As I stated in my letter to the board, I'm a very dedicated Christian, husband, father to 4 children, and physician. I would never dishonor those aspects of who I am. Furthermore, I am in successful long-term recovery from addiction, which requires rigorous honesty and a daily personal inventory. My commitment to sober living is of the utmost importance, from which I will never deviate. Thank you for listening. I'm happy to answer any questions you may have.
Do you have a statement you'd like to make, your attorney? Do you want to make it at the end or whatever you'd like to do?
I actually think he covered it very well, but I will note the one item on the use of the chaperones, that is something that the clinic, and I think you'll hear that from the clinic owner, has been implemented.
Great. Questions from board members? Okay. Dr. Reese?
Why do you think this happened?
I think she was very upset the second time that I had to set the professional boundary with her, and for whatever reason, that led to this.
She was offended by it, or
yes, I believe
you were
so.
abandoning her? Or?
Yes, sir.
During the course of your interaction with your patient, did you ever think that there's something quirky about it, or that that you should be on your guard, or that you should be very careful about boundaries?
Yes, sir, absolutely. I felt over the course of our visits that I had established a certain amount of trust with her to the point where she was comfortable letting me adjust her. Very relaxed, very kind of carefree. However, I felt that her behaviors were always somewhat of a concern.
So what did you do? For example, funnies aren't funnies to certain people. And I noticed in the report that there was a bit of a repartee with her. Did you watch that? Was there something? I get the feeling that you were on guard, and then you let your guard down, and.
I see between like 10 and 14 patients a day on average, and I like to keep things relaxed and light and jovial. It helps the time go by and keeps people feeling comfortable. I certainly feel as though I made an error in judgment with this particular patient.
What was your error in judgment?
Making that joke about shaving your head and removing your clothing to, make the palpation easier. It was kind of a knee-jerk reaction when I heard that statement.
If students were here, I'd say, beware, be careful of the funnies, because the funnies aren't funny.
Yes, sir.
Dr. Erbstrasser, Dr. Speakerman.
One question. So do you do pelvic floor therapy on this patient? Or
No, absolutely not.
Okay, so how close, when you say the vagina stuff, how close, when these types of patients, I think pelvic floor therapy is wonderful. If you have a chaperone in there, there's a lot of women there was a hysterectomy, I guess, here, and those are very important procedures. So I don't want you to shy away from that if you do it, but the chaperone issues, obviously, were you ever with this patient, to your knowledge, in an area, the pubic bone or anything like that? I mean, any of the areas that she's claiming?
The pubic symphysis, yes.
Okay.
Yeah, right. On the last visit, that was her third visit with the same complaint, with the sacroiliac pain and the pelvic dysfunction, and that was when I decided to check the pubic symphysis to make sure that I was addressing everything that could be
which is but with a psychiatric patient or a female, obviously, that you see where we're kind of going with this.
Yes, sir. Absolutely.
Okay, that's my major concern, is that you have a patient that's psychiatric issues, and anytime you're putting yourself at risk at that point, right? And you're making the patient, then also the patient can be uncomfortable. And sometimes patients won't say that they're uncomfortable because we're the doctors, right? Okay. And nothing further from me.
Kind of walk me through how you treat a female patient, not specifically her, when you're examining them. And I'm very curious about the statements about clothing being removed or bras being unsnapped, those types of things. Talk to me about that.
So it's very common when a patient, when we begin treatment, if there's something related to the back, to have them lay prone on the table. In treating the low back specifically, I use the legs as anchors for muscle energy, and also with working out the paraspinal muscles. If there's hypertonicity, you need to address that if you're going to have a successful treatment. So applying a heating cream or a gel like a Sombra or a Biofreeze to the paraspinals, rather than go over the bra strap and get it on their clothing, I ask them if they mind if I can clip it for them and then do the work and then clip it back while they've just been lying there on their stomach. So I do these.
Are they in
things.
a gown, or are they just in their regular street clothing when you do this? Or
I ask the patients to be in like gym clothing.
Okay.
So it's like just raising up the shirt to expose the back, and then using
not exposing the breasts or anything like that?
No, sir.
Okay.
And when I'm working with their legs, when I first started doing this, I didn't remove the shoes, and I would have their shoes up on my clothing and get what I was wearing dirty. So then I started having our assistant, if the patients were being treated for low back pain, to remove their shoes before the treatment started. And sometimes he would do that and sometimes he doesn't. So if he doesn't, then while they're laying there prone, I'll just ask them if they mind I remove their shoes. 100% of the time, no one has ever minded. Remove their shoes quickly and move on.
So do you have a female chaperone in the room with you now when you're doing these procedures now?
We previously had only one assistant. His name was Trent. And recently, in the last maybe 6 months, we've hired another assistant. Her name is Mallory, and she is going to be assisting me chaperoning.
Okay, so you said you didn't answer my question. Do you have a female chaperone in the room now?
Yes, now.
Okay. How long? That's been going on for how long? How long have you been having this female chaperone in the room with you?
Since I received.
Does she have the? If we would pull your charts, you would have documentation that she is in the room with you.
No, I have not documented that.
Okay. So we have no verification then, Doctor, right?
Only my word.
Okay. You need to have their documentation on the chart. Okay. You really do. All right.
I will.
Okay. So I want to hear the complainant come forward. If you guys want to step back, that's okay. And you want to
actually before the complainant comes forward.
Okay.
I wonder if we could have an executive session to go into some medical history.
Okay. So do you want to make a motion?
Yes.
I have a motion to go into executive session for medical history with the physician. Do I have a second? Second. All in favor signify by saying aye.
Aye.
So what I'm going to ask you to do is have everyone step out of the room, okay, except for the doctor and his attorney. And
Please
then
take your belongings
for
with
medical
you.
information, okay? Okay. All right, we're all good. You got the recording on? We're back on? Okay. We're back at an executive session for medical information from the doctor. Do you want to ask any more questions from the doctor, or are we ready to have the complainant come forward?
I would.
Anybody? Okay. Go ahead and step back if you guys want. You just have a seat right back there.
And if I could just note, there are also 2 individuals here from the public who would be willing to speak.
I'll be happy to do that. All right. Can the complainant come forward, please? Elsie?
I don't have an attorney. Can I please bring my husband?
Sure. Absolutely. We can have a seat right there. This one right there? Yeah, that's perfect.
Thank you for being here.
And just have a seat right there. Just a second here. Thank you for coming here. Could you swear in LC, please?
LT, I believe.
LT, I'm sorry, LT. Thank you very much for correcting me.
Raise your right hand. Do you solemnly swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
Yes.
Okay. LT, you've heard what we've talked about here briefly, and if you can just maybe if there's something that is not you would like to enlighten us about, I'm going to give you a few minutes to talk about it as well. So go ahead and speak to the board and tell us what you want to share.
Hi. Thank you for being here.
And if you talk loud into the speaker, because some of us are hard of hearing. Thank you.
Can you hear me? If you can't hear me, just let me know, because I can't tell.
I can hear you perfect just like that.
I'm short, so I have to lean over. Thank you for being here. Thank you for doing what you do. I appreciate that. Megan was right. You seem like you're very nice people. She said, "Don't worry, they're really nice people," and you seem like that. Thank you. Okay. So you have my original complaint, and I stand by that. I have no reason to be here. I don't want anything from him. I just want it to never happen again to anyone else, because I wish someone would have done it before I walked in the office. So, first let me say that, yes, I have a diagnosis. I have PTSD, but I'm just saying it is not an excuse for bad behavior on someone else's part. And it doesn't mean that I didn't hear what I heard or experience what I experienced. Thank you for letting me say that. And sorry to alarm you with the admitting of the diagnosis. Okay. I want to say that some of the things I heard just now I would like to explain. There was... he said that I was crying and rocking on the floor and the staff had to come in. I'll tell you why I was crying and why I was on the floor. When I went in the first time to see him, he couldn't get this side of my jaw muscle to release. So he injected me in here, and the injection medication spread up my face, and I lost control of my eye. It wouldn't focus, it wouldn't close. I couldn't do anything. So I was laying on the floor because the whole room spun to the right as the medicine went up my face, and I was afraid I was going to fall down. When you lose control of your eyeball suddenly, it is a freaky experience, so yes, I was crying. But there was a reason for it. The karate move. The karate move. Am I allowed to show you?
No, you can just tell us about it, okay?
Well, it's...
Go ahead. Go ahead and stand up and show us.
Was the karate move.
Okay.
Which is not forward and aggressive. It was down here.
Okay.
And I did not touch him.
Okay.
When I'm a person who laughs a lot, and laughter therapy is good for me too. And that would come anyway. But getting adjusted gives you a woo, and I laughed. And when I was on the aqua bed, it had the same effect. And I was laughing. I want to make that clear. The making noises sounds a little off and weird, and it was laughter.
Okay.
I want to also be very clear that no one in that office ever admonished my behavior. Ever. No one told me not to hug a doctor and thank him. No one told me that I needed to be more professional. No one corrected my behavior or told me that it was odd. I laughed.
Okay.
I also want to say that there were a few things that I left out of the complaint. And just as a fluke, and I need to say them now. Well, wait. If a doctor is treating a person and they say, stop, that's not the place, I took his hands in my hands and put them back on my hips, and he moved them back down without explanation. So if I moved his hands and put them back on my hips and said, that is the spot, if he needed to go somewhere else to treat me with his hands and come back down to that spot, why not explain that to me? There was no explanation. There was a time when he said to me, I was thinking about you last week, like in my ear. And I waited for like, what? And there was nothing that followed. And so I said, oh, yeah, well, I was thinking of you too. Your advice. You gave me really good advice, and this helped, and that helped, and thank you for helping me. There was another time where he told me that he knew, because he went to medical school, he knows how to pleasure a woman. I'm sorry that I joked around with him. My behavior in doctors' offices have changed also. My husband comes with me every time. I'm happy that the practices in that office have changed, because I don't want this to happen to anybody else. I have no reason to be here. I am suffering for being here.
Thank you.
Thank you.
Thank you. Thank you. Thank you. If you don't mind, just go ahead and step back. Thank you for your statement.
Thank you for your time.
Thank you. You want to come back forward, doctor, and your attorney? You've heard some of the statements that were here. Would you care to comment about any of those things that she discussed?
I'm Ashley, and we spoke last week, and I couldn't talk to you because I had to have a dental appointment.
Sorry.
That's okay.
I didn't know it was an audio.
Okay. You want to make some statements though about what was just said, Doctor? I remind you, you're still under oath.
It's just very upsetting to hear that. I think the employees have written in their letters what they've witnessed and experienced with her. Some of the things that she's saying just simply are not true. It did not happen.
Okay. You want to ask a question?
Yeah, just one last question. And it's somewhat of an obtuse question, but do the best you can.
Talk a little louder.
Do the best you can with this question. What kind of faith did this patient have in you that you think was overdrawn or over-exaggerated?
What kind of faith?
Yeah, it seems though she had extraordinary faith in your ability and
well, I mean,
and somehow was disappointed in your behavior.
I mean, several times after visits, she would use words like miraculous, amazing, unbelievable, and I feel like that had a lot to do with when I kind of confronted her in a what can be conceived as a negative way, really damaged that
So
view.
what did you do when you realized that faith was becoming blasphemy? What did you do to stop that?
I informed her if those behaviors continue, that I was not going to continue to be her doctor.
Okay, and you set that boundary very clearly.
Yes, sir.
Okay.
Question?
Yeah,
I've got a
couple. Did you inject her jaw?
Yes, sir. The lateral pterygoid.
Right. Did she have a reaction to it?
She said that the side of her face was numb.
Got it. The karate move that she did, was that the one that you saw?
No, there was more to it than that.
Good. Hands moving. Do you recall any time that you had your hands on her hips? Did that?
Yes, when I was palpating the muscles in her thigh and her rectus, is that sore? Is that sore? No, this is the spot. Okay, thank you.
So there could have been a misunderstanding there. The pleasure woman, was that?
I never said that.
Okay. So the issue here that I have is she felt that you crossed a boundary, and you're saying you didn't cross a boundary. So, I think Dr. Reese makes a really good point here. It's like somewhere as a physician, okay, especially when we're dealing with a young lady with issues, we have to kind of figure out where their boundaries are, not where ours are. And for some patients, and I know women that have to undergo pelvic therapy, and females take care of them. You're actually doing intrarectal, intravaginal, very appropriate therapy. May not be appropriate for all women if they had been abused, or you know what I'm saying. So, and that's kind of the art of medicine. And to me, it sounds like you maybe missed that little part on this patient. Would that be something that? I mean, I'm not saying that you felt like you went over the boundaries. Obviously, as an attorney, I get, but have you thought about maybe doing this differently next time?
Absolutely. I plan on having a chaperone present anytime there's any question whatsoever with a female patient.
And what about being a little, she also complained that if he would have said or he would have talked more, I mean, you sound like a talkative guy, but especially when we're in those areas, right, it's probably really important to explain what's going on. Okay. Have you been doing more of that recently?
I explained it at the time as well, but I always try to be cognizant if I'm, in a sensitive area to be, explaining exactly what I'm doing and why I'm doing it.
Okay. So you can understand there was a major, if not misunderstanding between you and your patient here. I mean, I'm not saying boundary issues, but would you agree with that statement? This could be a major misunderstanding.
At the time, I did not think so. Okay. But in hindsight, I think it's obvious.
Okay.
Go ahead, Dr. Reese.
Considering everything that's gone on and hearing from the patient and recognizing her sensitivity and previous experiences and having great faith in the doctor and then being disappointed. But I find, to me, the doctor didn't do anything that rises to a level of any kind of limitation. So I'm going to suggest dismissal from my part.
Could I just ask one more question? I'm not disagreeing with that, but I just have to clarify one other thing. It might have just been your choice of words, but you've said you plan on, but also that you have hired a chaperone. Is the chaperone, I'm sorry, did you say your name is Melanie?
Mallory,
sorry. Is she already working with you, or is she planned?
She is.
And how long has she been hired?
Approximately 6 months.
And does she come in with all female OMT, or just when requested?
Just when requested.
I know you have two assistants now. Is Melanie there every day, or are you splitting shifts so they only have a female chaperone some days?
She's there most days.
Most days?
Yeah.
Questions? I'm sorry.
I go ahead. Do you have anything, Dr. Erbshaw?
Yeah, I just want to comment on, Dr. Cunningham has a great point that you need to document that an MA or a person is in the room. I do that with every woman exam. I do it with the breast exam. I do it if I feel that the patient is going to be exposed in any way that's harming in their interpretation. Okay, so that's imperative that you do that. if you do OMT and you work on somebody's shoulder, I'm not sure you need a chaperone for that. I mean, it gets kind of crazy, right? So that's where your judgment has to come into play going through this experience. Like, okay, this could be interpreted in a different way. And that's where you've got to have the common sense and make sure somebody is there. But, I mean, to say you have to have a chaperone there all the time, I think with the females, you have to have that judgment.
I would say, if you're working in the chest area or the pelvic girdle, I would absolutely.
Yes.
I mean, a bit like I said, head and neck. That's one of those things. That's a judgment.
Prior to this experience, I used to think that a chaperone was for the patient's comfort.
Yeah.
And now I understand that
it's both.
Both. It's for my protection as well as the patient's comfort.
Yeah.
Dr. Matum?
I second the motion on the floor.
Okay. Before we vote, I'm going to just tell you, I really think you could have done a better job, doctor.
Mm-hmm.
Communicate. I think that the communication with this particular patient could have been much, much better. I think I think you should have had, when there was issues about her disagreeing with, I want to say that there's different interpretations of what happened in those visits, okay, that you should have had a chaperone immediately there. And so I think for her protection, your protection, all those things, I think you could have done a better job. That's my opinion. And so I'm going to tell you, I can't support I think with what is happening with women in today's society and how women need to be more protected. And I'm not saying that, and you as well, doctor, I think that you could have done a better job in this particular case. So I can't support a dismissal. I would support a letter of concern. And I would also recommend that he have a chaperone in the room any time that there's manipulation, especially in the pelvic region and those areas and that they have documentation for that too. I'm not saying that this is a punitive thing. I'm just saying, or disciplinary, but that would be my recommendation. I'm going to tell you, in my office, when I don't have a chaperone in the room with me at all times, but in any time that I feel that there is inappropriate behavior. For example, I had a patient that was a new patient to me, and at the end of the visit he said, "I'm very attracted to you." Okay? So you know what I'm going to have next time that patient sees me next time? I'm going to have a chaperone in the room, okay? All right? So the thing is that you have to recognize those things, doctor. You're not a new student coming out. You had lots of experience, so I'm surprised we're here. I'm just going to tell you that, okay? So that being said, that's where I'm at.
Chair Cunningham, can we hear from the two people who
Sure.
turned up to...
But just a second. What did you got to say?
I would not support that because
Okay.
I do not want this doctor to leave with an allegation that he did something that was...
I agree.
Because
I agree to disagree.
That would stay with him, and regardless whether it was...
It would be just... Yeah. Okay. I hear you, Dr. Reese. I hear you. All right. You had two people that wanted to talk just briefly?
Yes.
Okay. If they got 2 minutes each, if they want to come forward,
Should we stay here and have them sit there?
They can sit right over there. You guys can just stay right there. If you just identify who you are, and then each of you have 2 minutes each.
My name is Siobhan Love. Sorry. My name is Siobhan Love, and I'm the clinic operations manager. I've known Dr. Stigler Travis for about 3 years, as well as his family. I know him to be extremely professional with his patients. I'm also the one who conducted the interviews for the staff members after this incident or the alleged complaint came forward. I spoke with all the staff members who had interactions with this particular patient. All of them concurred that there was erratic behavior. So that was all very well documented, also at our weekly meetings as well. It was brought up at that time. I do feel like this entire experience has opened our eyes. I have 4 male practitioners within this clinic, and I'm well aware of the Me Too movement, and I do think that this opened up our eyes as to what we need to do to not only protect patients but also to protect our male practitioners. So we do actually have 3 MAs on staff now. One of the our front office manager is also an MA as well. So if there is ever a need for an MA to step forward when our other 2 are not available, she is also available for that as well. So I would say that going forward, we are acutely aware of what this can do for a patient, what this can do for a doctor, for his standing in the community as well, to ensure that this allegation or this nature of this allegation never comes up again. So,
thank you.
Thank you.
My name is Dr. Tim Munderloh. I'm a chiropractic physician. I've been in practice for 20 years. I've been working with Dr. Stigler for 3 years. We sit right next to each other. We discuss and co-treat patients on a daily basis. My experience with Travis is he's always practiced with integrity and honesty. And I was shocked to hear this board complaint. And immediately we investigated and implemented some procedures to make it so that this wouldn't happen again.
Okay. Thank you. All right. We have a motion on the table. We have a second. Any discussion before we vote? Let's have a roll call, please.
Yes. Mr. Berg.
Aye.
Dr. Speakerman. Dr. Reese.
Yes.
Dr. Madem.
Aye.
Dr. Erbstrasser.
Yes.
Dr. Cunningham.
No. Motion passes. Good luck to you, doctor. And please take those things that we've talked about, what we talked about earlier, okay? All right. We hope safe travels back. And thank you, complainant, also for coming as well. Thank you. Do we need a 5-minute break?
Yeah.
All right. We're going to take a 5-minute break. We'll be right back. We're back in session. Next case is DL-18-0012A, Michael Leroy Nowak, DO license number 4575. Dr. Nowak, could you please come forward, please? Welcome, Dr. Nowak. Have a seat right there. Thank you, sir. Could you go ahead and swear in Dr. Nowak?
Would you raise your right hand, please? Do you solemnly swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
I do. And I have been neglectful, but doing this, I'm going to do it now. Dr. Nowak, could you tell us the type of training you have and the type of practice that you have now?
I trained at Michigan State University. That's where I went to medical school and undergraduate, a BS degree in microbiology. And from Michigan State, I went to Columbus, Ohio, Doctors Hospital, which is now part of Ohio Health. And that's where I did my internship and residency. Then I practiced there for...
Internship and residency in? Because not everybody... Internship and residency in...
at Doctors Hospital in Columbus, Ohio.
You're board certified?
Yes, sir.
Okay. Great.
Practiced for 25 years there. I was department chair for 2-3-year stints with a 5-year being a program director there for the residency program. And trained residents from various parts of the country and students from Ohio University, College of Osteopathic Medicine, Kirksville, when I first started in the late 70s, early 80s. And Des Moines, and some people from Philadelphia and Chicago. Great. And, of course, Michigan State, but I was the only one down there from Michigan State. Ohio and Michigan are kind of, in the sports world, a little bit.
Where are you currently practicing?
I left Ohio in 2007 after my last daughter graduated high school, and one of my daughters moved out of the state. She ended up staying there because she got married and stayed there. But I left there and did locums for, probably about 2 or 3 years, and then ended up in Roswell, New Mexico, where I've been practicing now for 8 years.
Wow.
And I got sent there by the locums company that I was working for because both of their obstetricians left within a month of each other, and they were in kind of a crisis situation. I said, if I'm going to be the only one there, I mean, I think I'm going to be in a crisis situation. So they said, no, we'll get you some help on the weekends and that sort of thing.
Good.
And that worked out. I was there by myself about 4 months. They hired someone. We got together. We worked well together, so I stayed there. And he left in 2016, I believe. He was about my age, but he decided he was going to retire. And there I had been teaching family practice residents from the University of New Mexico. They had a program there, and they all rotated through obstetrics. They had 6 residents there at a time. And then that program got shut down. I guess it lost funding about 2 or 3 years ago. And now we have the students from Burrell College of Osteopathic Medicine in Las Cruces. Yeah. And they're just graduating their first class, and so we have the third and fourth year students there.
Great. Thank you.
And I work for a corporation. It is community health systems. They have hospitals all across the southern part of the United States, and then all the way up into Alaska through Oregon, Utah, that sort of thing.
Thank you very much. Dr. Prowl, is this yours?
This case was opened due to a yes answer on a renewal for his license regarding a malpractice settlement. This involved a premature infant at 35 weeks that was born with microcephaly and immature oropharynx that later expired. We had this case reviewed by a board-certified OBGYN physician, and the physician felt that from a gynecological and surgical point of view, well, I guess I should back up and say that this patient had a Bartholin cyst and had it actually removed, and post-operatively she developed acute blood loss, and which required transfusion of 3 units of PEC cells and a documented hemoglobin of 4.9, and post-op resulted in hypotension, and it may have been responsible for the premature birth. And anyway, so the physician felt that from a gynecological and surgical point of view, there was no deviation from the standard of care in that the patient had multiple recurrences of a partially treated abscess that was uncomfortable, and she demanded definitive care. Surgical excision was an appropriate step when prior conservative management had failed. He noted that in pregnant patients there was a higher risk of complications, specifically bleeding and hemorrhage. Therefore, when possible, it's best to postpone excision and try conservative management at first, such as incision and drainage, antibiotics, or marsupialization. When conservative management fails, it's appropriate to proceed with surgical management, even when patients are pregnant. He said from an obstetrical point of view, though, he felt that there was poor documentation of antenatal testing performed at the time of the procedure, immediately post-operative period, and during the hypertensive episode. He stated that the only fetal heart tracing that was available was the one that was dated on March 6, 2011, which was the day prior to surgery. He noted that there was a mention of a fetal heart rate between 110 and 118 during the hypotensive episode of the mother, but no follow-up non-stress test to ensure fetal well-being was performed after the hypotensive episode. He noted again that she needed 3 units of packed red blood cells and her hemoglobin was only 4.9. The hypotension may have led to placental hyperperfusion and consequently fetal hypoxia. Prolonged episodes of hypoxia can lead to fetal acidosis, which can potentially result in severe damage. The standard of care is to initiate fetal testing in the form of non-stress tests or possibly contraction stress tests to ensure that the baby is tolerating the intrauterine environment. Although this may have been performed during this event, it was not documented. Furthermore, during the patient's hospitalizations, the records indicate periods of continuous fetal monitoring, and discharge summary indicates fetal heart rate baseline was in the 140 range. However, there is no description of the accelerations, long-term or short-term variability, which is essential in determining fetal well-being. The absence of tachycardia or bradycardia do not necessarily imply fetal well-being. He felt that it was difficult to ascertain if there was direct causation of fetal distress and eventually death without the fetal heart tracings surrounding the episode of hypotension. The fetal heart tracing the day prior indicated a reactive non-stress test with accelerations with good short and long-term variability. The fetal hemoglobin prior to surgery was 12, indicating a significant amount of blood loss during the procedure.
No, the maternal.
Yeah.
You said fetal. You said fetal.
Oh, I meant maternal.
It's okay. It just matters.
Then he felt that that he followed the standard of care in counseling her on possible treatment options regarding the Bartholin cyst abscess, but multiple failed conservative treatment attempts. Unfortunately, the operative report lacks detail regarding surgical approach and technique. Also, there was an immediate response to hypotensive episodes with fluid resuscitation, blood transfusion, and monitoring. However, documentation lacks detail on fetal well-being, including parameters such as heart rate acceleration, short and long-term variability.
Doctor, you heard that review of this case. Would you care to comment, please?
Well, first of all, the patient I encountered on my, I believe, second full day in practice there. When I arrived, I had a couple days of orientation, and then I was between the office and the hospital based taking care of patients. That patient had been managed by the previous physicians who left since July of 2010. And she had 3 episodes of a Bartholin gland abscess. The first one was about 7 or 8 weeks of gestation. That's when she found out she was pregnant. Went to the emergency room for this Bartholin gland treatment. They put her on antibiotics. It was incised and drained, and a ward catheter was placed. That's what you usually do, right off the bat. And that occurred on another occasion, and then a third occasion when she went to another hospital where it ruptured as she presented there. So there wasn't really too much they could do. In between, she had infections that were documented as urinary tract in origin, but the cultures from these gland abscesses all cultured E. coli. The E. coli was in the urine. It's kind of hard for me to understand whether that was perhaps contamination from an active abscess or whether that was a true urinary tract infection. She had only been seen. I had not seen her at all for prenatal care, and the office called me when I was not in the office. I was actually covering the hospital, and they said, we have a patient here that's had problems for her entire pregnancy with this infected gland on her vagina, and she's really in a lot of pain. She wants something done about it. You want me to send her over to the hospital? Or I said, no, I'll come over and see her in the office. And she was there with her spouse, the baby's father, and they weren't angry, but they were very disappointed that nothing definitive had taken place, that everybody's poking holes in the thing and it's rupturing. Now, she was not being seen on a regular basis. She had several no-shows, and it was documented in there that she really didn't continue with her antibiotic therapy when she was discharged from these drainage things. So they asked, what else can be done? Can't something be done to fix this? I knew that I was looking at the notes that the previous physician wrote in the prenatal chart. This was all on paper before we had computers. But it was mentioned that after she drained it the first time, the patient came back in the office and she could still palpate something in that gland. So it wasn't really resolved from the drainage, and she put her on the antibiotics, and then she disappeared for a while and didn't come back again until the abscess recurred. And so that was kind of the treatment as far as the antenatal testing and all of that. I didn't have any opportunity to do that. She came in. She was very uncomfortable. They really insisted if there was something to do to resolve this thing that they would want to do that. I gave them the options. I said, now you've already had it drained and a catheter put in it on 2 separate occasions. When it ruptures, there's not too much we can do. I said, the only way you're going to get rid of this is to excise it, remove the gland. And if we can't do that easily because there's too much scarring from the previous failed attempts to resolve the issue, we may have to just open it and leave it open, and it have to heal from the inside out. But removing the gland, then you close all the tissue, of course, and everything's pretty much resolved. And that's the way I was trained to manage those things, and that's basically how I did it. Now, as far as the procedure itself went, I prepared to take this case to trial, and in doing so, I found out from the expert witnesses who are doing, they all mentioned the anesthesia part, and the patient had a hypotensive episode when she received her spinal anesthetic. I mean, at that point in time, I was never notified of anything until the end of the surgery. I was taking off my gown, and the anesthesia said, she's getting a little hypotensive. We might have to give her some blood. I said, that's fine. What's been going on so far? She had 5,000 cc's of fluid, and nobody told me that she had the hypotensive episode before I even started the surgery, and then she had another one in between and one at the end. So there were 3 episodes. And there's an expert opinion from the plaintiff, from an anesthesiologist who found all that and got it out of the chart. I'm not very good at reading paper charts for anesthesia. And he also criticized the fact that she got ephedrine and pseudoephedrine, and that the pseudoephedrine will decrease the blood flow to the uterus. He thought that was inappropriate to use in a pregnant patient, even though the anesthesia people were, using this to help with keeping the blood pressure up. And like I say, I really didn't know anything about it until the end of the surgery, and then took it from there.
What about the fetal heart tones, though? Checking for fetal heart tones. That's my concern.
Mm-hmm. During the surgery, or
during and after?
Well, they do before we even start the surgery. I mean, anesthesia insists that they do a strip just to get a heart rate. Now, they don't do a non-stress test or anything like that.
I don't think there was any documentation. That was the problem, wasn't it? There was no documentation that there were any fetal heart tones checked afterwards.
There was a strip in the chart. I mean, that's all in the chart to take the surgery.
After or during?
It was before, and that's down in ACU before they bring the patient up to surgery.
Afterwards.
Afterwards, she went down. I kept her there and took her down to labor and delivery and put her on a monitor, and she was on that for continuously for 24 hours
for fetal heart tones and all that.
Correct.
Yeah.
Okay. And when she went down there, basically the strip looked like it did when they did the pre-surgery strip. And it had good variability. It had, moderate to fair variability, and I mean that's what we watched. It wasn't until later that evening. I mean, she was on pain medications, which will decrease the variability of the heart tones. She was on. She was getting like 2 milligrams of morphine every 2 or 4 hours for breakthrough bleeding, and she was on orals, Lortab, I believe she was getting.
For breakthrough pain, yeah.
For pain, because these things are not very comfortable. And actually, there was a pack in there also from where the cyst was up against that area, so there's a lot of pressure there to keep that area consolidated and free from bleeding.
Yeah. So timeline here, because I'm trying to get an idea of what really kind of happened to the baby. So 8 weeks.
Dr. Speakerman's a
pediatrician.
Okay.
Nice to see you. Mm-hmm. So 8 weeks, she's got a cyst. Okay, a Bartholin cyst. She gets it treated with the antibiotics. And kind of throughout the pregnancy, she's having this reoccurring E. coli deal whole time. And you have documentation that says she may or may not be taking her medication.
Correct.
Okay, the antibiotics. Thank you. So I count with UTIs, E. coli, recurrent things. It was 35 weeks when you did the febrile heart rate at 3.6, the baby delivered at 3.24. So I count between that and about 32 weeks, she probably had an off and on infection from 8 weeks all the way till 32 weeks. Would that be a reasonable statement? Or was she treated, and you didn't do the treatment until the end, but you could argue that there could have been ongoing inflammation with E. coli in that area.
Yes.
That would be a reasonable assessment. Okay, perfect. It is standard of care to get that heart rate, obviously, before. You're doing a relatively minor procedure with that. Is it standard now to have a fetal heart monitor now during any procedure, or is that still standard of care? I don't know what that standard is. Because, you obviously appropriately followed her afterwards.
Right.
Yeah, which is fine. So intrapartum, is that the anesthesia's problem is to monitor mom and baby, or is that your deal?
Well, anesthesia monitors all that. Mostly a surgeon is focused on the surgery that he's doing.
So is his job to monitor the fetal heart rate as well?
The mother, is important. Now, I have not been in a situation where continuous monitoring has been. In fact, that's why we use regional anesthesia, so we don't have to put the person under a general anesthetic.
Okay, so that wasn't a deviation. I just wanted to make sure that there was no deviation there was here. And then when you brought the baby down brought the mother to postpartum recovery, is that when the hemorrhage occurred, or was it at?
Oh no, that was during the course of the surgery.
Okay, so when did you? How long afterwards did you get blood and things like that in order to? Hemoglobin to figure out when she was much hemorrhage she had?
When I finished the surgery, and I was told, patient's blood pressure is a little unstable. It's kind of hypotensive. We're keeping it up, but she might need some blood. Okay, she got a unit of blood before she left the OR.
Okay,
and then I believe she got another 3 units of blood in the post-anesthesia unit, PACU is what we call it, and then another couple units over the course of the 24 hours that she was down in labor and delivery.
Okay, so bleeding is a known complication, and unfortunately there is risk to the fetus when that happens. Okay, I get that. That's perfect. When the baby was born, did you ask for an autopsy? And was there a genetic report done on the baby?
The baby delivered at UNM.
Okay.
Because at the hospital where I'm at, it's a policy. The pediatricians have made it the policy that they don't want babies under 36 weeks admitted there. A lot of them that just come in and deliver end up getting transferred, fly out on a helicopter, that sort of thing, to UNM, which is 200 miles away. So the baby was delivered there, and you asked something about the time?
I just wanted to know, at 35 weeks, did they do an autopsy?
Oh, yeah.
Was it autopsy
Yes.
or a genetics performed?
They did not do any genetics, but they did do an autopsy, and that's, actually the neonatologist that was taking care of the baby noted that it had microcephaly and
some dysmorphic fever.
And there was a very difficult time they had had the child when it was born.
Interesting.
Because they went through 3 episodes to get the baby intubated. They had to get a 3.0 endotracheal tube. They had a bore and a 3.5, and they tried twice.
I completely understand.
So,
I was wondering if the neonatologist indicated any dysmorphic features, which it indicated genetic abnormality. The reason I say that is if you have an ongoing, as you know as an OB, inflammation from 8 weeks forward with E. coli going in and out of your system, that's not real conducive to a healthy baby.
No, I've seen people actually go into preterm labor. And
you understand my point. So at your point, when you picked up the management of this child, one could argue that this child had been under some mild extremis for a period of time, even though the fetal heart rate was reassuring. That if an ongoing, you're treating the infection, you were trying to solve the problem, is what I'm asking.
Yes.
Got it.
And at 20 weeks, they even saw calcifications in the umbilical cord.
Oh, they did?
Yeah.
Okay.
At 20 weeks. And there was a CDC report from the studies of the brain tissue, and the pathologist, the forensic pathologist that looked at that, said that this damage probably occurred at least 3 weeks before delivery, and up to 5 months before delivery.
I would argue that. I would argue that is true as well. And so, in the procedure that you did for her, obviously she was frustrated and angry. You advised her the risk to the baby, the bleeding risk, hypotension, all of those things. And since it had been done so many times, it had an increased risk.
Correct. And actually, she wasn't very angry. She was just very disappointed.
Oh, not with you. No, I'm just saying she was frustrated, and you felt at this point that it wasn't going to get better and it was going to continue to be a problem for her and the baby.
Correct.
Okay, I'm good.
Questions from other board members? I'm going to make any other questions from other board members?
I just want to know, how much blood did she lose when you were operating?
Well, I went by what anesthesia was telling me, and it said, you lost about 800 cc's of blood. I mean, I would expect, I've had, and really these people are some of the best anesthesia group I worked with. I mean, they're very good with obstetrical patients, whereas a lot of times you go places and somebody just really doesn't want to come down there and take care, other than the fact that they're on call. But the thing is that I would have expected to be told right from the beginning that this patient got hypotensive when she got her regional anesthetic, and that they were already working on keeping the blood pressure up. I mean, I may have delayed the case, done it later on in the day or the next day, whatever, and I don't recall her hemoglobin being as high as 12. I think it was, when we started, it was more like around 10, and then she got 5,000 cc's of fluid.
Yeah, that's a lot of dilution, right?
Yeah. I have to believe there was more blood loss than that, but quite honestly, I'm focused on this thing.
No, I mean, but from a surgeon standpoint, I mean, if someone's hemorrhaging, right, in terms of the surgical site.
Well, again, this surgery, and I'm going to get to remove the whole thing. I think it's multiloculated. I'm trying to get everything out of there so it doesn't recur, and I'm really clamping every vessel that I can't cauterize. And it did probably take longer than I expected. I think probably about an hour and a half. And to me, it felt like it was about 45 minutes because I'm focused on this cyst and getting it out, or I'm going to have to stop. If they would have said, your patient's getting hypotensive, okay, let's give her some blood, I would have opened the thing and marsupialized it, and that would have been it.
Those surgeries are, any obstetrical surgery, and I agree with you. If you think you're doing it for 45 minutes and it's an hour and a half, the anesthesiologist is responsible for telling you, they're hypotensive, you got to be getting it, and you have no grasp of time, and they always bleed. The uterus is another one. When you have scar tissue in the uterus, the belly fills up, and nobody knows how much is in there. I mean, I've been in a million of those things.
Yeah. My question is that I know she was unhappy, and you're walking into this not being prepared with what had been done before. But in hindsight now, do you think that maybe she should have just, again, I know she would have just been miserable, but I'm just, say, hey, you got the drain, we've got to get through this pregnancy. There's a high risk that there could be other issues, complications that occur, and we should hold off a few more weeks until you get past the delivery of the baby. That's why I wanted to ask the question.
Well, I've been trained, to honor the fact that you try to avoid surgery before 20 weeks. 20 weeks is when all the organ systems are developed, so forth and so on. So if you're going to do a surgery, I mean, you can't delay things like an appendix or things like that, and they're pretty uncommon. This is pretty uncommon. But when you see something that's been managed, and I don't want to say inappropriately, but managed in a way that it's not completely taken care of, whether it should have been marsupialized at the very beginning or when she came back for the first visit and it's still there. I mean, the doctor documented the thing is still present. And rather than take her to surgery and deal with it, that they just kept with the antibiotics. I think maybe there was a little bit of participation by the patient that was less than what she needed to do to get rid of it. But, under the circumstances, when you're past 20 weeks and 32 weeks, all I was worried about is she's going into labor, okay? And she may have gone into labor if I didn't do anything with this thing.
Okay. And,
So
I'm telling you, it's like, remember, then they get E. coli sepsis, and it gets into the baby. I mean, frankly, I think it was outstanding that you tried to help this in this situation. You did everything appropriately. I mean, and bleeding happens, and it happens. So,
okay. You want to make a motion?
I would like to make a motion for executive dismissal.
Second.
I saw a motion for dismissal by Dr. Madem, second by Dr. Speakerman. Any discussion before we vote? Can we just do we don't need a roll call, do we? I'll signify by saying aye.
Aye.
Aye. All opposed, same sign. Case is dismissed. Thank you, Doctor.
Thank you so much.
Thanks for walking that through us with us, okay?
Yeah. And Doctor,
good luck to you. Thank
on
you for
your
your
defense,
work.
by the way, have them talk to the neonatologist and see if there's any dysmorphic features that could get identified for something like a DeGeorge's syndrome. Because with micrognathy and microcephaly, wouldn't be a trisomy 18 or something like that. But if there could be a genetic cause for then it's a non-starter.
Yeah, I think she missed those tests at the beginning.
Yeah, I mean, it would have been nice to have, really nice to have genes tested.
Thank you so much. Appreciate it.
Good luck.
Thank you.
Next case is E, DO-17-02948, Chris Pachuri, DO, license number 4737. Dr. Pachuri?
Yeah, you're right. It's already malpractice.
Welcome, Doctor. If you can just have a seat there. And would you swear in Dr. Pachuri for us, please?
Would you raise your right hand? Do you solemnly swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
Yes.
Hi, Dr. Pachuri. If you can just tell us about briefly your training and the type of practice that you have now.
Sure. I graduated from the Kansas City University of Medicine Osteopathic School in 2002. I completed a rotating internship followed by a residency in orthopedic surgery at Oklahoma State Medical Center in Tulsa. I then completed a one-year spine fellowship at the Texas Back Institute, and I began practicing in Phoenix for about 18 months. My wife didn't like it here, so we relocated back to Tulsa in 2010 and have been in private practice there since. My practice is
Tornado Alley. She didn't like the heat. She likes tornadoes.
Actually, tornado warnings there right now, yes.
I won't hold it against you that you went to Kansas City, the same school I went to. A little bit earlier, though. Okay. Dr. Pra, is this yours?
This case came to us as a malpractice case for a failure to diagnose and treat. This was a cervical abscess that resulted in quadriplegia in a 29-year-old female. This patient was originally seen or involved in a motor vehicle accident in February of 2011. She saw Dr. Pachuri in April of 2011, and he performed a laminectomy and discectomy at L45 and L5S1, and that was completely uncomplicated and no problem. She then saw him again in February of 2012. Saying that her lower extremity pain had resolved, but complained now of neck pain and upper extremity pain. He repeated an MRI of the cervical spine. He saw her again in March of 2012, reevaluated her, and noted that she had tenderness in the neck and diagnosed her with bilateral C5 paresthesias. He referred her to a pain management specialist. In April of 2012, he performed a C7T1 epidural steroid injection. In May of 2012, he saw the patient in follow-up, and she stated that the epidural steroid injection had not helped very much. She continued to have bilateral C5 paresthesia. He referred her for a C4 through 7 discogram. This was performed by assuming an interventional radiologist, and post-discogram CT scan was done, which showed a C4-5 annular tear with a dye leak at C4-5. There was no leak at C5 through 7. In May 18th, 2012, the patient went to the emergency department with increased anterior and posterior neck pain 3 days after her cervical discogram. The physical exam showed the pain was worse with extension, and a neurologic exam at that time was normal. CT scan report on May 18, 2012, which was the same day from the ER, showed a C3-4 anterior phlegmon with no abscess. Dr. Pachuri was phoned and recommended IV and oral ketorolac and follow-up in 5 days. We had this reviewed by a board-certified spine specialist who noted that on his review of the images, he did not appreciate the phlegmon, but he did feel that there was a C4-5 right anterior mass with some evidence of enhancement. He stated there does not appear to be evidence of an epidural abscess, but this was not the ideal study to visualize for an abscess. This finding was not seen in the report, the radiology report. Then on May 23rd, so the emergency department visit was May 18th. On May 23rd, the patient saw Dr. Pachuri. She was still complaining of neck pain. He felt that she had a C5 through 7 disc derangement. She was placed on hydrocodone and Xanaflex. He did not document the images of the CT scan done on May 18, 2012, so we weren't sure if he saw it or not. Then on May 26th, the patient went back to the emergency room. She complained again of neck pain and left upper extremity pain. She was ambulatory. Her temperature was 36.4 with a heart rate of 94. She was hypertensive with a blood pressure of 184/88. Then, these are a little backwards. Actually, 2 days before that, before the emergency department visit, she was seen by a chiropractor on March 24th. And she felt that she was worse after that appointment. She went to the emergency room on the 26th. Then on the 29th, she went back to the hospital complaining of neck, back, and shoulder pain with bilateral numbness and tingling. Hydrocodone was not resolving the pain. She was having difficulty ambulating, but she had driven herself to the emergency room. She was told to follow up with her primary care physician, and she was given ketorolac. On May 30th, the very next day, Dr. Pachuri ordered a new MRI scan. There was a note that stated the patient cannot function on the right side, lost feeling in limbs due to chiropractic adjustment. So it's unclear if, so the patient was evaluated at the Hillcrest Medical Center Emergency Department on May 30th. She complained of right-sided weakness. She presented in a wheelchair. She had a 3-day history of burning numbness in the right side and was unable to ambulate. She had a temperature and an elevated heart rate. White count was 11.1. A neurosurgery consult was requested. An MRI scan was completed and showed an epidural abscess. The neurosurgery consultation was done at 1900, and the neurosurgeon performed an anterior cervical discectomy with evacuation of the abscess on the 31st of May. Unfortunately, the patient still developed quadriplegia.
Doctor, you heard this brief report. You want to comment, please?
Sure. So the patient was well known to me for about 15 months prior to the incident of the infection occurring. She had been complaining of neck pain along with the back pain since I'd been seeing her. That was nothing new. The back pain took precedence, which is why we took her to surgery about 6 months or so after, and that symptoms of back and leg pain resolved with surgery. She'd come back to me with follow-up after, for post-surgical care and could continue to complain of neck pain. So, we tried some conservative care with the injections. What that didn't work, I ordered a discogram to make sure that there was nothing else that could be causing her symptoms. The discogram was completed on May 15th or 16th. I don't remember the exact date. And by design, that's a pain-provoking test. So it's not uncommon for people to complain of pain, and that's essentially what she was doing after the test was done when she went to the emergency room 2 or 3 days later. When the ER doctor called me, I explained to him, listen, that's a pretty normal response. She's always had neck pain. Let me go ahead and see her in the office, and I'll evaluate her. I didn't think there's anything significant enough on the CT scan to warrant an admission and to do all the full workup at that point. But it was on my mind that she could have an infection. I saw her in the office. I felt she was neurologically intact, nothing acute, and I said, okay, let's just go ahead and continue to keep an eye on your neck pain. I was never notified when she went to the ER the second time, 3 days later. I was never notified when she went to the ER again the third time a few days after that. It wasn't until the chiropractor told me, hey, she's having a lot of neck pain. At that point, I ordered an emergent MRI. That still wasn't done. Then she went to a hospital that I had privileges at. The hospital records state when she was admitted that a CT scan was completed, an MRI was ordered for the next morning, and they were to notify me. The hospital that I'm on staff at didn't notify me. Instead, they notified the neurosurgeon on call. I mean, I wasn't allowed to participate in this patient's care that could have prevented this outcome. And, I mean, it was just a sequence of events that I think if I would have been called on the second ER visit or the third ER visit, or even when she was admitted to the other hospital, I could have ordered the workup and prevented this from happening.
Because you saw under the consultant, he says they thought that he... did you read the consultant's report?
I did, yes.
Okay, so did you see at the very bottom... So you didn't get called from the ER even on the first one, because he was saying he thought that the things that were directly under your control were the following: requesting an SED rate, CRP, during the patient's first emergency department evaluation. This would have given you more data for possible infections. So were you called on that first one?
I was, yes.
Okay. Did you think about doing that?
Well, it was on my mind that she could be having an infection, but I mean, I had been known this patient for 15 months. Her complaints of neck pain had been persistent since the very first visits. So it was nothing new. Yes, I mean, I was thinking about infection, but it just wasn't something at that point that I felt when I was examining her in the office that she was exhibiting signs of an abscess.
Okay, then reviewing the CT scan, imaging was difficult to evaluate and could have increased his index of suspicion to do further workup, such as the lab that we mentioned, and also an MRI sooner. What are your comments?
I think if I would have known that she was, she went back to the same emergency room 3 days after she saw me in the office. If I would have been notified of that visit, absolutely, I would have done a full gauntlet workup, MRI, lab work, all that stuff. Because at that point, the symptoms were changing. Her symptoms were, hey, it's not just the neck pain she was complaining of. Now she's been to the ER twice.
Tell me what you're doing differently if you had the same case now. What would you do differently now?
Well, there's a very low threshold at this point now for anyone that's complaining of postoperative pain, whether it's concern for a hematoma or infection. I mean, from a legal perspective, I mean, I'm ordering imaging studies right away. I mean, I've learned a lot from this case, unfortunately. It was early in my career. The standards say don't give people antibiotics afterwards. That was a big deal that came up in the defense, like why did you not put the patient on antibiotics? We give patients antibiotics now 5 days after surgery. Not because it makes sense, but because it looks good.
Okay. Question, Dr. Matum? You have any question?
No, I definitely think you should have been more aggressive on your evaluation at that time. There was a delay between discogram and presentation for the neck pain. I understand that you're not going to do an aggressive abscess evaluation in every patient. That would also be inappropriate. It's just an index of suspicion. You had somebody with chronic pain problems, but it seems like their management was reasonable before this cascade started to happen, and there was definitely a snowballing cascade with multiple presentations, including a reevaluation by yourself that seemed to be at a reasonable time frame. My primary care cohorts can tell me better on the follow-up, but that seemed reasonable. So I think you might have missed the boat on that, but at the same time it was not that clear-cut, so I absolutely understand that.
How many cases have you seen like this since you've been in practice?
The only one.
Yeah. It's a rarity. Mm-hmm. I was telling Dr. Praw, we've been doing this for a long time together. I think we've seen 3 cases in 11 years I've been on the board. But it does happen. So my concern is that have you educated yourself, and do you have a different threshold now? Because clearly, I mean, this woman's a quadriplegic now, unfortunately. So, other questions from other board members?
Nope.
Can I have a motion?
I make a motion for dismissal.
I have a motion for dismissal. Do I have a second? Second with Dr. Speakerman. The motion was made by Dr. Erbstrasser. Any discussion before we vote?
Again, I have to question if this is something that raises the level of at least
a letter of concern.
Letter of concern.
Yeah, I'm going to tell you, you and I are on the same page. I think that a letter of concern would be appropriate for this, and so I can't support a dismissal. But I'm only one vote, so I would support a letter of concern for failure to diagnose abscess, small abscess. So
2 votes.
I'm sorry, two votes.
Marty?
All right.
I'm going to support dismissal. I think, not that I have great experience in this, but there were no changes in the presentation until the third visit, so I'm going to support dismissal.
But there was the change was medication therapy was not effective.
Mr. Berg?
Dismissal seems like the appropriate course of action.
Okay. So, can I have a roll call, please?
Yeah. Mr. Berg.
A.
Okay.
Dr. Spiekerman.
Aye.
Dr. Reese.
Yes.
Dr. Madem.
No.
Dr. Erbstrasser.
Yes.
Dr. Cunningham.
No. Our motion passes. Thank you for coming, and I do appreciate you traveling all this way to explain this to us, because it did enlighten us a lot. And so I'm glad to see that you're doing things differently now. We hope to see you back maybe in Arizona again.
Yeah, I was
okay?
gonna say,
Good luck to you, okay?
I can tell it hurts. I mean, that's obviously a
I can see it in your
difficult
face, too.
Thank you. Keep doing good work.
All right. Next case is DO-19-005A, Anthony Christopher Posen, DO, license number 3684. Dr. Posen, can you come forward, please? Welcome. Can you swear in Dr. Posen, please?
Raise your right hand, please. Do you solemnly swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
And can you introduce your counsel? I know Mr. Myers.
Steve Myers.
Steve Myers, great. Dr. Posen, can you tell us just briefly again about your training and the type of practice you have now?
And then if I can just interject, Mr. Chairman, after the staff presentation, he has a presentation that he'd like to make, and I also do. Thank you.
Absolutely.
I graduated from Midwestern University Chicago College of Osteopathic Medicine in 1999. I was accepted into University of Arizona Good Samaritan residency program in Central Phoenix, and after 3 years of residency, was accepted into a 3-year cardiology fellowship program, highly competitive program, and then I did my final interventional year, so I was there for 7 years total. Graduated that program in 2006, and I've been in private practice since 2006. I practiced in the Northwest Valley in Glendale, predominantly Sun City West, and I am in a large cardiology group of about 30 providers. And I'm currently half clinic, half hospital rounds and cath lab.
Okay. Thank you, Doctor. Dr. Pra.
This case was opened when the board was notified by the chief medical officer at Banner Thunderbird Medical Center that Dr. Posen had agreed to refrain from practicing medicine at the hospital after having a positive urine drug screen, and here too. Our board asked him to go for an evaluation, and we can talk about that in executive session if we need to.
Okay. Would you like us all to go into the executive session and talk about that, Dr. Reese?
No.
All right. Okay. Go ahead and make your statement, Doctor.
I would like to start by sincerely apologizing for using poor judgment as an osteopathic physician in the use of recreational substances. I have been arrogant and untrue to myself, and I have not exhibited strong moral character. I deeply regret having used these substances in the past, and I've made a full commitment to completely refrain from all substance use in the future. Between 1999 and 2006, I was involved in over 100,000 patient encounters, either face-to-face or over the phone, with numerous nurses, techs, ER physicians, fellow residents, hospital administrators, other fellow cardiologists. Not once in the 7-year time frame was there ever a question about my work performance, my decision-making, my medical ethics, my quality of patient care, or caring for patients under the influence of drugs or alcohol as a medical resident, as a cardiology fellow, or as an interventional cardiology fellow. In 2006, I joined a private practice in Sun City, and I've been caring for patients now for 13 years. In the Northwest Valley, I've worked as a board-certified interventional cardiologist at over 10 different hospitals, and in this time, I've experienced no concerns regarding my quality of care, my decision-making capabilities, or my ethical character. In the cardiac catheterization laboratory, I have performed over 5,000 procedures in the presence of nurses and radiology techs. Not one of these healthcare professionals had been nor currently is employed by myself. In the office setting, I've had over 47,000 patient encounters. In the inpatient setting, I've rounded on over 40,000 patients in close contact with nurses, hospitalists, and other healthcare professionals. With regards to patients in the ER, I've had over 30,000 patient encounters, either in person or with ER physicians and ER nurses on the telephone. I am proud of the reputation I've obtained as a respected interventional cardiologist in the West Valley where I practice. Not once has anyone in any of these settings ever even suggested the possibility of me ever being impaired, nor has a patient ever suggested that I might be practicing under the influence. Additionally, I've never been named in a malpractice claim in the 20 years of possessing an osteopathic medical license. I take tremendous pride in my work as a cardiologist, and I truly believe my purpose in life is to keep patients alive with the utmost dignity and compassion. I also realize that practicing medicine and living through personal struggles, such as the divorce of a marriage of 20 years, can produce tremendous strain on your health and your psyche. I will admit I've not made the best choices in the past concerning my time spent outside of work, especially with regards to recreational use of marijuana, but I am also human. I have been accused by my wife of driving to work with drug apparatus in my passenger seat, and this is false accusation. Not once have I ever driven my car with open alcohol containers or contraband as depicted in set-up photographs by my estranged wife. I am not proud of the fact that I had certain items in my possession, but these had been securely locked away. Images have surfaced depicting these items out in clear daylight, and these were staged pictures. I again apologize to the board. I deeply regret having used these substances in the past. On occasion, I've made a full commitment to completely refrain from all substance use in the future. Since January, I've been submitting weekly urine samples through TASK. The judge assigned to our divorce case ordered these random drug screens for use of substances. These have all been negative, and my attorneys have provided the board with the results of these drug screens. My estranged wife has accused me of using cocaine. During my training years ago, I used cocaine on one occasion. In September 2018, while out of town, I tried cocaine again. I did not like it, have not used since, and I will not use it again. I have never used marijuana on the day before being on duty or on a day in which I'm on duty. I have not used marijuana since January. I again apologize for my conduct in using marijuana and cocaine on one occasion while not on duty, but my conduct has not been such that I've never been remotely close to having been impaired while on duty.
Okay. Thank you. Mr. Chairman, members of the board, I believe, for personal reasons also, I believe that we need to be extremely cautious about complaints filed with professional licensing agencies, excuse me, by estranged spouses, ex-spouses, or significant others. I am very empathetic to Dr. Posen's circumstances. In my own case, after an entry of decree of divorce 26 years ago, my ex-wife filed many complaints against me with the Arizona State Bar, all of which were groundless and promptly dismissed. I assume the board members have reviewed the photographs submitted to the board by Dr. Posen's wife. It is not credible to me that a physician would have what appears to be illicit drugs or drug paraphernalia openly exposed in his automobile, while he would be subject to being pulled over by the police while he traveled from home to clinic, to hospital, to another hospital, back to clinic, and then home day after day after day. I do not condone the use of substances, particularly by a physician or an attorney. However, for purposes of professional licensure, I also do not believe that a physician should be subject to adverse action by the board for use of substances any differently than for the use of alcohol, even though substances are illegal and alcohol is legal. Both can be very dangerous, but as long as neither are in the physician's system when he or she is on duty or about to be on duty, there should not be discipline. In my own case, I have never used substances, but I do often consume more alcohol after work hours than I should, but I do not do so later than a great many hours before I will again be on duty. I am certainly not proud of consuming more alcohol than I should. I believe that the test for discipline should be whether the physician was impaired in any one of several circumstances. First, while treating a patient. Second, when the physician is about to treat a patient. Third, when the physician is on call. Fourth, the physician is traveling to practice medicine. Fifth is traveling while having very recently concluded practicing medicine and is impaired on a given day. These latter circumstances are often evidenced by a charge of DUI. I have represented physicians in all of these circumstances when the surgeon is observed to be impaired while performing surgery, when the anesthesiologist has accessed the pyxis and observed with slurred speech or difficulty walking, when the physician who is on call is impaired or impaired while traveling to or from the practice of medicine, again evidenced often by a DUI. Dr. Posen's wife anonymously alleges that in one circumstance, quote, cocaine was found on an on-call weekend, end quote. She has provided no information as to the dates of this weekend, and therefore neither Dr. Posen nor this board can compare this allegation with his group's records as to when he actually was on call. More importantly, we only have a statement that cocaine was, quote, found, quote, on an on-call weekend, but there is no statement whatsoever to the effect that the cocaine was used on such a weekend. I spent a fair amount of time reviewing the anonymous photographs of the interior of his automobile, and I did sense the great possibility that on a single occasion or during a single setting, items appearing to be drugs or drug paraphernalia may well have been artificially placed in the car's interior, including his wallet, photographed, then removed, and then replaced with other items and photographed again, and so on, as to simulate multiple different occasions that these items were present in his automobile. The anonymous photographs are intended to suggest that they were taken on several occasions, but I am highly suspicious that this was not the case. There is interestingly no allegation as to the date or dates these photographs were taken. Here we do not have credible evidence that Dr. Posen was ever impaired in any circumstances in connection with the practice of medicine, and certainly not proof by a preponderance of evidence. The board's addictionologist has recommended that Dr. Posen be abstinent and be monitored, which is certainly appropriate and to which Dr. Posen is very agreeable. In conclusion, I am respectfully requesting that Dr. Posen be monitored, not disciplined, and that there be no findings in connection with the board's order based upon his wife's allegations. I ask that the findings be limited to the simple recommendations of the board's addictionologist. Thank you.
Thank you. Did you want to ask any questions, Dr.? Go ahead. Mr. Pra.
We did not open the case when we got anonymous complaints from someone that might have been related to your ex-wife. We didn't open the complaint then. We only opened it once we received something from Banner.
Yeah, and I should have addressed that. Thank you, Doctor. It's my understanding that the anonymous complainant to the board is also the same person that made the complaint to Banner. I should have clarified that.
Okay.
Well, I'm curious then. My understanding is that Banner observed the doctor impaired.
They got a complaint.
I'm sorry?
Banner received a complaint.
Anonymous complaint. And they couldn't tell me who it was, but it was likely either my estranged wife or...
Did they ever observe you impaired? Or?
Not at all. No, in fact, the medical exec committee, just the CMO asked me to just refrain for about a week. Just that's pretty much standard. And they met in the med exec committee sessions, and they unanimously decided that because it has nothing to do or no bearing on patient care, that they immediately just let me work fully unrestricted at this point. So, it's been like that since January.
Okay. But he had a positive THC in his urine and hair. The Banner.
It was in my hair.
It was in your hair.
And in your urine. That's what I have here. This is the letter from Banner, dated on January 14, 2019, that you had a positive of THC in your urine and hair samples. And that's from Dr. Sullivan, Chief Medical Officer.
That may have been the case, yes.
Okay.
Also, just to set the record straight, you're comparing apples and oranges, and that alcohol is legal. That doesn't justify, in my mind, THC being in the same category. Alcohol is out of your body in 12 hours. THC stays there and accumulates for days and weeks and months, and it's very difficult to judge your impairment because it becomes a chronic condition. So it's very hard to tell whether you've used it one time or using it every day. So I think you're comparing the use of alcohol as a justification is not a healthy understanding of the problem. That if they've indeed found THC in the urine and hair, I think there's something amiss here. You know, when did you use, and how much are you using, and you know, what's the real issue here? Do you have a drug problem?
I don't. No.
How do you know?
An executive session for that?
Well, we're not.
No, because he has a medical question.
How do you know you don't have a drug problem?
How do you feel, Gene? Do you want to go into medical?
I think that's preferred.
Well, then, Dr. Bader,
I would like
correct.
to make a motion to go into executive session. Let me rephrase that.
Okay, I have a motion. Do I have a second? Do I have a second from Dr. Speakerman to all in favor signify by saying aye.
Aye.
And so if all of you can just step out, please. We're back at our executive session for legal advice. Steve, I just don't see how that we can do that. Go have a confidential agreement for this, the way it was reported and so forth. So,
my feeling has been that it's always been the policy of the boards, but it's not a regulation or anything like that.
I don't think you'll convince the board on this particular case. I don't think you'll convince the board on this particular case to do that. Okay. That being said. Any other discussion with this? Dr. Reese, anything like that? Okay. Can I have a motion then for this particular case? Or do you want me to go ahead and do it? All right. So I was going to make a motion that we put him into the monitoring program and have the standard protocol, the standard of what we have always done before, and staff will take care of that for a 2-year monitoring program. To make sure everything is good with him. The other thing I think also that we need to talk about too is I think that it would be very good for you to see a psychologist. I wish you would see a psychiatrist as well, but I don't know.
I would recommend that you see a psychologist and that the psychologist recommend a psychiatrist for possible medication management.
So I'm seeing a psychologist now, and she's referring me to a psychiatrist through the Mayo. So I'm calling on.
But it has to be a psychologist approved by the board. Okay. So get that name to us. We'll see what we find out. We may approve it. We may not approve it. Okay.
Can I give you her name?
So
now, or?
you can give it to them. Just do it on Monday. Okay.
Okay.
Just do it on Monday. Okay. And that what we'd like to do is then have quarterly reports then from their psychologist sent to the board then too.
Okay.
Okay. And then if you're seeing a psychiatrist, same thing as well. We'd like to have quarterly reports from them. That's my motion. Is there anything else that I need, Gene?
The monitoring program. You did say that. Thank you.
The meetings for should he attend meetings?
I would. Oh yeah. And that's the standard for. I'd like you to be in the caduceus meetings as well for follow up as well for support groups. Okay. On a regular basis. Okay.
Okay.
All right.
These are all terms of probation under the monitoring program.
Under the monitoring program. Yes, ma'am. Anything else that I left out? I made that motion. Can I have a second? Go ahead.
No, there's no work restriction.
There's no work restriction now. How many hours a week are you working, doctor?
Anywhere from 45 to 80, just depends.
That's a lot.
Well, I mean, I can tell you my schedule. I have a 7 o'clock case in the lab. I have clinic from 8 to 12, and then I'm in the cath lab from 12:30 to 5. And that's 5 days a week, and I'm on call one weekend.
That's a lot.
But that's the life of an interventional cardiologist.
I get it, but you're under a lot of stress, doctor. So, and you have a lot of things going on.
Work actually, I know, but work is actually what gets me through a lot of this.
I'm very similar minded as you are, but again,
we want you to step back.
What's your obligation at the hospital? Do you work for a hospital? You work?
I have the afternoons. I'm obligated to do procedures on my patients that need procedures done.
Okay.
And so I typically take a call once a week from home. But during the afternoons, I'm cath lab coverage. So I'm covering STEMIs, non-STEMIs, any acute cardiac situations. I need to take them to the cath lab. So I'm coverage for the afternoon along with my partner.
How about we compromise? How about we do this, Steve? How about we put no restrictions right now? Let's just get an evaluation from the psychologist and see what they feel, of a board that's chosen by the board, it's approved by the board, see what they recommend for his work. I'm very similar to you. When I'm stressed, I'd rather see 1,000 patients and deal with it, okay? But that's not a healthy thing either, okay? All right? So I'll tell you that. So let's see what the psychologist has to say, okay? And if they feel there should be any limitations or not. Does that sound okay to you?
I do. We have no evidence that he is ever deviant.
I agree.
And then my other comment again would be, I would hope that the findings just simply reference that the findings not include these horrible allegations by this anonymous person.
No. We're just going by what was sent to us by...
The findings could be simply a phone call from Banner or something like that.
The letter that we got from Banner, okay? I think that's fine. Yes, go ahead.
I was just going to want to make absolutely sure that you understand that this would mean that you would have to abstain from all mind-altering things, including alcohol.
Okay.
For 2 years.
Yes.
Yeah. Except if you're prescribed something by the psychiatrist, okay?
Or an internist.
Or internist or something like that.
I went over that with him.
Okay.
Just want to make sure.
And the evaluation, the psychologist isn't going to do an evaluation, but the psychologist will just look at his work and talk to the board if they think that there needs to be modifications. Not a full-blown evaluation.
Absolutely, that's not.
If they call us and say he needs to be working 50 hours a week, then we'll bring that back up. But if they said he's doing fine,
could we? What I would like though is specifically for us to ask the psychologist that question. Okay.
It'll be in the order.
Okay. All right. Anything else? Anything else, Steve?
I'm done.
Okay. All right. Any discussion before we vote? Can I have a roll call, please?
Yes. Mr. Berg?
Yes.
Dr. Speakerman?
Yes.
Dr. Reese?
Yes.
Dr. Madem?
Aye.
Dr. Erbstrasser?
Yes.
Dr. Cunningham?
Yes.
I want you to do well. We're here to help you. We're here to help you succeed, okay? I want you to know that. This is not punitive in any way. Please don't look at it that way, okay? We're here to help you, okay?
Yeah.
And we look forward to seeing you. Should we say we want to see you back in like 6 months? Can we do that?
See how he's doing?
Or 3 months? 6 months? See how he's doing?
Yeah,
Let's do 6. So
6 months. Let's see you back in 6 months. Come back and check in with us, okay? Let's see how things are going with you, okay? All right.
Thank you. Appreciate it.
Thank you.
Thank you.
All right.
Mr. Myers, always good to see you.
Yeah.
We'll see you before that, Mr. Myers.
I'm sure we will.
How does the board feel? We've got another case that has 2 cases.
Let's do one more in the next. Yeah.
Well, the thing is, we got 2 cases though.
Let's whatever you want.
Do you want to break early for lunch and then be back here at 12:30? Would that be appropriate? Would everybody feel? Because the food is here.
Yeah,
everybody's okay. Mm-hmm. So what we're going to do is we're going to break for lunch and we're going to start promptly back here at 12:30. Okay? We'll be right back. All right. Thank you.
I don't got it. Oh my gosh.
Start with the 2 cases that we have here, and I'm going to call them both together. It's DO-17-0268A, Brian Samuel Page, DO license number 3416. Also HDO-170269A, Brian Samuel Page, DO license number 3416. Dr. Page, can you come forward, please?
And Dr. Cunningham, for the record, Dr. Speakerman is no longer part of the meeting.
And Dr. Speakerman is no longer with us this afternoon. We still have a quorum, though.
And Dr. Cunningham, to let you know, the complainant is available on the phone.
Okay.
So when you're ready
Wonderful.
for questions.
Thank you.
Which complainant?
The complainant in the second case. SC.
In the second case.
S. Okay, thank you.
In the second case. So, would you swear in Dr. Page for me, please?
Please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
All right, and Dr. Page, welcome. Would you introduce your counsel with you, too?
Good afternoon. It's Teresita Mercado.
Welcome. Dr. Page, can you tell us about your training and the type of practice that you have now before we get started?
I did my training at Oklahoma State University, so I went to osteopathic school and did my anesthesia and pain training at the University of Kansas in Wichita, Kansas.
Okay, great. And Dr. Parr, these two cases are your cases.
Yeah. I just want to make sure that I've got the right number.
Are you reading your report or the consultant report?
Kind of both, a little
kind
bit.
Of both.
We're starting with 268, correct?
Thank you. This case came to us from a CRNA and former employee of Advanced Pain Management. She stated that the offices were very unsafe, that there's a high volume of patients, somewhere between 40 to 60 people per day, which creates an extremely fast-paced environment and a hazardous one with unqualified staff. She stated there are no licensed providers with the patients in either the pre-op or post-op areas. She states they use medical assistants to start IVs and recover patients in the post-op areas. She states the medical assistants operate and position the C-arm during cases. She states many of the medical assistants are resistant to supervision from the CRNAs and have even moved medical supplies and equipment from their reach without their knowledge or consent. She states up until a few weeks ago, the MAs were pushing IV medications such as Benadryl and Zofran. She states there are no crash carts in any room, only crash boxes. She states there are no CPR boards or stretchers to put patients on. She states she also believes that there's no backup ancillary power to any of these facilities. She states she suggested changes such as safety straps on all patients positioned on the procedure table and timeout procedures, which were never implemented. She also states Dr. Page has his MAs take a quasi-ACLS course. She states these MAs do not have the knowledge base to be ACLS certified. She states it has been a struggle to get the MAs to count the narcotics with the provider versus counting them alone or with each other. We had this case reviewed by a board-certified pain management specialist, and he had several areas in which he felt Dr. Page had fallen below the standard of care. He felt that Dr. Page may have directed unqualified staff to administer IV medications and insert the IV catheters. He felt Dr. Page may have directed unqualified staff to monitor the patients in the post-procedure area. Dr. Page may have directed unqualified staff to handle controlled substances. He may have directed unqualified staff to take x-rays and perform C-arm procedures. Dr. Page may have utilized consent forms that lack specificity of the procedures being performed. For example, lumbar facet injection number 1 is referred to instead of lumbar facet injections and noting the specific location. Dr. Page failed to save fluoroscopy images of a reasonable quality such that a reviewer or payer could verify the procedure performed. Procedures that involve multiple levels performed often only had one saved image in the chart, so the remaining levels could not be verified or reviewed should the need arise. Further, oftentimes the images saved were illegible and no verification could be made as to what procedure was performed or where the final needle position was located. It is unclear what the process is for determining discharge of a patient from the post-anesthesia care unit. Dr. Page's procedure note from one particular patient, patient DS, on April 14, 2016, is unclear as to what injection and what levels the procedure was performed. Dr. Page performed a medically unnecessary lumbar facet joint injection on patient AH only 30 days or so after the first one. Standard of care would dictate 3-month intervals between facet joint injections, and only 50% improvement in pain or function was verified with the patient. Dr. Page performed a medically unnecessary repeat left hip joint steroid injection on patient AH after only 14 days after the first injection. There should be at least 3 months between hip joint injections on the same hip using steroids. Regarding the female patient DS, there are multiple inconsistencies in the procedure note and consent forms matching what was actually performed. Regarding male patient DS, he underwent a second right shoulder joint less than 30 days from the first injection, which would also be medically unnecessary. Our consultant pointed to pages 994 to 1005 of the provided medical records from Dr. Page include records of another patient, so it was in the wrong chart. Also, there was a consent form for another patient that was in the wrong chart. And again, another finding of an incorrect chart documentation. He noted that in reviewing the job responsibilities provided by Dr. Page's attorney, it appears LPNs or EMTs are responsible for placement of all IVs, giving all IM injections, and counting and logging controlled substances at the beginning and end of each shift. It was noted from the employee roster there are no RNs or LPNs and only one EMT employed by Advanced Pain Management for its multiple locations. Also, in review of the employee roster, it failed to demonstrate any employed X-ray technicians. He said the Arizona Department of Health Services Bureau of Radiation Control specifically prohibits unlicensed staff, such as MAs, to position patients for X-rays, move the X-ray tube, set technical factors, or initiate exposures. X-ray technicians ensure that the machine is being maintained properly, as well as monitor badge readings and check lead aprons for signs of wear and cracks. Oftentimes, X-ray technicians can alter the amount of exposure in the tube settings, which helps to minimize radiation exposure for the staff and the patients. Medical assistants cannot alter the exposure setting of the tube, and therefore higher than necessary radiation exposure could be occurring in the procedure room. It is unlikely that Dr. Page would be able to perform 40 to 60 procedures per day while removing his gloves and handling the X-ray tube between each exposure. It's also standard of care to save legible fluoroscopic images for the procedures performed. And he noted that some of the images saved were photocopies of images that were printed using thermal paper, and he felt that made them difficult to read and illegible. His response that indicates the office policy requires only licensed providers such as CRNAs or physicians to place the IV catheter. He stated he did not see any evidence in the CRNA charts that they routinely place the IVs. In reviewing the employee certifications, it was noted that many MAs have received ACLS cards from a place called CPR Solutions. The American Heart Association specifically states that anyone who has passed an ACLS class is designated as having earned a course completion, but this does not designate a certification. The American Heart Association does not certify anyone. There is no requirement to be a licensed healthcare professional to enroll and complete ACLS training. However, if an employee is not qualified to administer the emergency drugs and therapies, there's little reason to have the certification. The complainant notes that timeout procedures were not performed. The timeout procedure is standard of care in licensed facilities like hospitals and ambulatory surgery centers. If the PACU or postoperative care unit is truly staffed by only a medical assistant, it's a significant threat to patient safety. Standard of care requires patients in a postoperative care unit, particularly moderate to deep propofol sedations like these, should be monitored by qualified personnel such as a registered nurse rather than a medical assistant. Medical assistants are qualified to obtain vital signs, but not to interpret vital signs, nor can they provide significant portion of the skills required in ACLS treatments. States, Dr. Page's board response, they state only authorized personnel are granted access to handle medication, but they do not specify whether the employee must be licensed. It's unclear from Dr. Page's board response if MAs are given the responsibility of wasting or handling controlled substances. The complainant paints a picture of a chaotic and unsafe environment at Dr. Page's advanced pain management centers. The complainant is a former employee, a point in which is made in his official response. While this may be true, whether a current or former employee, these are important issues that have been raised by the complainant.
Thank you, Dr. Perron. Dr. Page, would you like to make a response, please?
Dr. Page is going to respond to the substantive items of the long laundry list that you just heard. But before then, if I could just take a minute of the board's time, I do want to circle back to the point that about the fact that both of these complaints were not made by any current patients. In fact, you were given a list of 10 patients, and none of those complaints in the random review, none of those patients have filed a complaint as well. These are not just former employees. These are both former CRNAs. Employees that were hired, frankly, as an attempt to raise the safety of the practice. Of these two employees, PR, who is not on the phone, I understand that SC is on the phone, but PR worked for the practice for at least 6 months, both as an independent contractor and then full-time employee. She had both of the employees had multiple employee personnel issues. The reason that I bring this up is because those are the issues that both of these CRNAs raised in their employment, both to Dr. Page and to office staff. PR raised complaints about her coworkers. She asked Dr. Page to fire the entire procedure team, including the physician at the office. Her coworkers reported that she was verbally abusive and videotaped them without permission. And also other items, including wanting a parking spot that was similar to the physicians at the office. These are the types of things that PR complained about during her employment. Her employment ended in, I believe, I'm sorry, I don't have the date that her employment ended. I believe it ended sometime in early October of 2017, and this complaint was subsequently filed at the end of October 2017. So the first time that these complaints were raised was the week that she decided to resign. And then she raised the complaints in a complaint with this board that was filed within weeks of her former coworker, SC. SC worked for the practice for 4 months, from January to April of 2017. She then filed her complaint 6 months later. During this time, before she notified the board, she actually filed a complaint with another Arizona administrative body requesting severance. And so after that was done and a settlement was made in that case, she then decided 6 months later to file this one along with her former coworker. SC's complaints during her employment related to the fact that she wanted to be paid $1,400 a day. Her coworker's complaints were that she didn't want to be called a nurse because she was a CRNA. She called a medical assistant a half-pint bitch. She also complained that the MAs ate in the wrong place at the office. Again, and she also complained about the lead aprons being provided, which actually is part of her complaint. She refused to wear an apron because it was the wrong color. She preferred red. When she was offered the blue, which is the office employee, which is the office color, she refused it unless it was the same apron that Dr. Page wore. And then when the office agreed to do that, she then refused. At that point, we understand that she refused. She also wanted a reserved parking spot. These are the types of complaints that were raised by this particular employee who then 6 months later decided to cite safety concerns, a CRNA. We're not talking about a front office employee. We're talking about a CRNA, somebody that was hired by Dr. Page as part of his staff to help raise these levels. The other brief item that I wanted to raise is the fact that we believe Dr. Hogan is the specialist that was retained to provide the review of the 10 patients. Dr. Hogan is a direct competitor of Dr. Page's. We actually think it was a conflict of interest that he even accepted this assignment. His office, one of his offices, is in direct competition very close by to one of Dr. Page's offices. And so I just mention it, not to cast any negative aspersions on him, but to raise the fact that this is the person that drafted the report that we're relying on today. And Dr. Page will address each of the items. The other point I want to address is the fact that the standard of care cited by Dr. Hogan is actually the Medicare standard of care relating to billing guidelines. So Dr. Hogan's, it appears based on his report, Dr. Hogan's standard of care is what Medicare would pay for. We would submit that that's not the appropriate standard of care. It's not what's taught in medical schools, and it's not something that, if you look at how carefully worded some of the things are and what he may or may not have done, in any way proves that there were any violations in terms of the types of procedures that were performed. As to that, now we're in a situation where, because of 2 employees that were disgruntled and filed complaints, about 5 years worth of every patient's medical records were reviewed or were requested, and then 10 patients' samples were randomly reviewed, about half of which weren't even treated by Dr. Page. They were treated by other providers in the practice, but Dr. Page is prepared, and he's reviewed all of them, and he's prepared to address each of the items that Dr. Hogan raised in his report. Thank you very much.
Thank you for the opportunity today. I looked at this case as an opportunity to improve patient safety in our practice. And we have made some changes since this case was filed. And I want to kind of briefly go through some of these accusations that were made, and then talk about some of the safety things that we put in place since the case was filed. So I'm just going to kind of briefly go through some of the main items that were brought up in the complaint. I think one of the first ones is that we used unqualified medical assistants to start IVs and administer IV medications. About 18 months ago, we hired RNs for all of our pre-op and recovery areas. So for the past 18 months, the RNs have done all the IVs and given all the IV medications. Prior to that, the medical assistants that were certified did start the IVs under physician supervision. We were not aware of any state or national guidelines that prohibit MAs from starting IVs. If they're certified and if they're under the supervision of a physician, under no circumstance were the medical assistants did they ever give medications IV. It's against our company policy. I never witnessed it. We do run several clinics. If this happened in a facility I was not in, it's possible, but it's against our company policy, and I never witnessed that activity. Only licensed providers would give medications through the IV. Second accusation, unqualified staff monitor the patient's post-procedure. Like you stated before, for the past 18 months, we've had RNs in our pre-op and post-op area. Prior to that, it was the duty of the CRNA or the physician to monitor the patient until they were stable and sign the discharge requirements. The next accusation, unqualified staff to handle the controlled narcotics. In our practice, as is the DEA policy, a licensed provider and one other staff member, usually a medical assistant, they count the opioids at the beginning of the day and at the end of the day, and also if there's any waste. And these are in log books, which can be obtained and we can give to the board. We were inspected by the DEA several years ago, and they found no faults with the practice. The next accusation, we use unqualified staff taking x-rays. For the past 18 months, we've hired full-time licensed x-ray techs, and this can be verified by employment records. Prior to that, it was up to the physician to take the C-arm pictures with the foot pedal, and that's the way that I have done it for many years, as I've taken the images myself. But there came a time that we were getting busier, and we felt it was a good idea to hire certified x-ray techs, and all of our facilities have had them and have for the past 18 months. It's our policy that medical assistants are not to handle the x-ray machine or position the patients, and we've had all of our medical assistants sign statements saying that they It's against company policy to handle any of the X-ray units or position the patients. There's an accusation that we failed to save good images, on our C-arms. I agree with this. I think by the time the images were printed and faxed and put on the chart, some of them were of poor quality. We do have better quality images saved on the drives in the C-arm machines. Some of our older C-arm units, we're looking into new technology that can convert the digital or the images to digital. The problem is the paper on the C-arm machines fades over time. We've been working on that issue. There's an accusation that we don't have axillary power. I think we do all of our physicians in an office setting. It's not a surgery center or a hospital, and we don't know of any requirements to have a generator. All of our emergency equipment have ancillary power by batteries, including the lighting and all the emergency equipment and the suction, if there's a power outage. There was an accusation that we don't have safety straps. When one of the CRNAs complained, we instituted safety straps on all the beds in all of our facilities. There's an accusation that we don't do timeouts. I've done a timeout on every single patient that I've done for over 10 years. When the patients are brought to the room, we identify the patient by their birth date and name, the procedure, and the site. This is done on every single patient. Up until a few years ago, it wasn't documented. We were inspected by MICA, and they suggested that we start documenting our timeouts with the stamp. So for the past couple of years, it's been documented. If the patient gets sedation, it's documented by the nurse anesthetist, and if it's not, the medical assistant documents the timeout. I don't believe that doing timeouts in an office setting is a standard of care, but we've always done it, and we've documented it over the past 2 years. All of our staff we do regular ACLS courses. We also do emergency drills. Only the providers can actually run a code, but we thought it would be important if everyone would be familiar with what goes on during a code situation. Luckily, we have not had to institute that. We have had an excellent safety record. I think in closing, Dr. Hogan comes up with the conclusion that we're running a chaotic and unsafe environment. This just is not true. It's a subjective statement by one of my main competitors who happens to have an office right next to mine. We have had a very good safety record over the past 16 years. We've been inspected on a regular basis within the past several years by MICA, the DEA, Arizona Radiation Commission, the DES, as well as most insurance carriers. We've corrected any deficiencies that have been found. I think, in conclusion, other than just some of the safety issues that we put in place, hiring the RNs and the X-ray techs, the safety straps, we didn't notice there's some deficiency on charting, and so we've instituted an action plan to improve our charting and chart, and we've started doing random chart audits by a third party to take a look at our charting. We're trying to improve our images on the C-arm, and then I've signed up. I haven't taken it, but I've signed up for a CME course on informed consent and decision making. All pain clinics in 2019, according to new legislation by the governor, have to be. There's a lot of new regulations that are going to be instituted by the DES. When we started an action plan, we believe that our clinic will probably be the first pain clinic in Phoenix that will be certified with the new regulations that were passed in 2019. And just one last thing, there was accusation that we did not have fully stocked emergency kits in the available. This is just not true. We have fully stocked emergency kits in each procedure room. There's a logbook to make sure that all of the drugs are not expired. We have all new CRNAs take a look at the emergency kits, and if they request any other information or drugs, then we promptly get them installed. CPR boards was brought up. This is not a requirement for an office, for a physician's office. We can use any flat surface to perform CPR, and those many physician offices that do not have CPR boards. Thank you.
Doctor, you went through a long list there. The thing that you neglected to talk about was unnecessary procedures.
Yes. There's two accusations. One, there was some discussion about a facet block being 20 days apart. After I read the complaint, I was a little bit confused because it's been the standard for many years to do a maximum of 3 facet injections per 6 months. So I had a phone call with the head of the pain fellowship program at Rush University in Chicago about this subject, and he assured me that the standard nationwide is still a maximum of 3 facet injections per 6 months. There's a Medicare payment guideline that says 1 every 3 months, but the general standard in most pain physicians still go by the maximum of 3 facet injections per 6 months. And then as far as the hip injection, several years ago we would do a series of 3 hip injections, but quite some time ago we changed that to the standard, which is 1 injection per 3 months maximum, and with 50% pain relief with each injection.
My last question is, what took so long to get this? The employee roster. I was just handed this. Now.
Yeah, I understand that. That was actually emailed back in March. Let me take a step back. There were multiple requests for copies of an employee roster for Dr. Page. That is the latest. I think that's the 3rd version of what was provided. I understand it wasn't received by email. The first version had a list of all the employees and their addresses. Then there was a request for clarification that the employees and their addresses, and that it would include all current and former employees in the last 2 years. That was the second version that was received months ago. Then the final request was for all employees for the last 2 years with their phone numbers. As you can imagine, Dr. Page runs a practice. It doesn't.
Well, you have office managers and administration.
Right.
I don't expect him to do it.
Absolutely.
But I expect you to comply with the board.
Absolutely.
I don't feel like you comply with the board.
And Dr. Cunningham, what had to happen?
Don't talk over me.
Oh, okay. That's fine. If you don't want me to finish,
I'll let you finish. But I'm very disappointed that we're getting this today. Okay? Getting this today. Dr. Pra,
yeah,
would you
I'd
like to clarify that?
My very first time that I subpoenaed that was in July of 2018. I then emailed you again in August of 2018, September of 2018, October of 2018, November of 2018, and I had my executive director reach out to you, and it wasn't until the executive director reached out to you that you actually sent me the first one, had absolutely no contact information whatsoever, and we had actually asked for contact information too. And then you still didn't send it until December, and then we got something that had no idea what the employees, whether they were current employees or previous employees, or whether they were, and what their job description was, and no way to contact them. So I subpoenaed again, and we have not gotten another thing from you. So until today.
So as I said, this is the 3rd version of the employee roster. In fact, I believe correctly, the first version actually wasn't emailed, even though Dr. Page is represented. it was requested from his office manager, and I believe you were provided with a list of the patients and their job responsibilities. Then in follow-up to that, I received an email from you in which you requested the roster of the patients and their addresses, which I believe was provided timely. Then there was a second version that was requested, which included their positions, and it wasn't all current employees, it was all current and former employees for the last 2 years. So that again had to get taken. And in the interim, there was an email that was sent from me clarifying that the information you were requesting, including home addresses, was personal employee information. And I asked for you to confirm that the board would be holding that information private and confidential, similar to the HIPAA requirements. I did not get a response to that email from you. Certainly I did not come here prepared with copies of emails that I've exchanged with Dr. Pra or your medical director, but those are certainly something that can be provided if that's something that is completely my responsibility.
I trust Dr. Pra in her communication.
Right. And
okay.
Dr. Pra will agree that I did send you an email asking for that, and then I sent a follow-up saying I never got a response to this. Is this something that you still want?
I think the process is that it's been a difficult process extracting information from.
And certainly that's my responsibility, and if that's something that the board chooses to consider to be a failure on my part, I certainly hope that that's not something that affects the board's opinion of my client. There were 3 versions requested, 3 versions
supplied. Okay, got it. Questions from other board members?
So I'm confused, Dr. Page. Are you saying you did fall below the standard of care 18 months ago, or you did not?
I do not believe that we fell below the standard of care 18 months ago.
But 18 months ago, you said you had to institute several safety protocols, including hiring the nurses, presumably for medication delivery, radiology technicians to handle the machinery, and I believe your words were, after the CRNAs complained about no safety straps, you added them?
Yes, safety straps are. I've been in many hospitals and surgery centers that don't have safety straps. I don't think that's a standard of care. There are many pain physicians that take their own C-arm images. I don't think that every pain physician in Phoenix hires a certified X-ray tech. That's the same with orthopedic physicians, and I think once we started getting into a higher volume practice, we felt it would be better if we had certified X-ray techs. As far as hiring nurses, I think it's just an improved quality of care issue that we decided. I don't think we fell below the standard of care.
And who is dispensing medications before this? Sorry.
Any IV medications were given by a licensed, either the CRNA or the physician, and medical assistants are able to give IM medications.
And EMT also, you said?
Yes, we had a paramedic that worked for us for a while, and she was able to. It's within her scope of practice to start IVs as well.
And do you still believe that timeouts are not the standard of care?
For us, I believe that they're a great idea, and I've always done them, and we've for the past several years we've been documenting them. But we checked, everywhere that we could look, and I didn't see a regulation that in an office setting timeouts are required.
Do you think it's a good standard?
I absolutely think it's a good idea, for sure.
Do you think there are errors made that could have been corrected with the timeout?
It's possible.
No, I don't think it's possible. I think it's a very well-known fact that errors are made that could be corrected with a timeout.
Yes, you're correct.
Thank you. And you agree that your fluoroscopy saved images were substandard?
Yes.
That's all I have.
Dr. Erstrasser?
Nothing right now.
Dr. Reese? How about you, Mr. Berg? We're going to let the complainant...
Did you want me to read the second one?
Go ahead. Let's do that.
Did you want to have the complainant on the phone? I don't believe she's on the phone yet.
Oh, she is on the phone. She is. Yeah, she's been waiting.
Is she on the phone? Okay. All right.
Go ahead.
The second complaint is also from a CRNA, and this complainant states that she had never seen such a shoddy, unsafe practice as what she observed at the advanced pain management offices. She states she observed MAs counting narcotics by themselves, wasting narcotics by themselves, giving IV Zofran and Toradol into a HEP block, and positioning and shooting scout films and taking x-rays. She states she was provided a small, ill-fitting lead apron. She states she asked to wear her own lead apron, but Dr. Page would not allow it because it was the wrong color. She states she never received an X-ray badge for exposure monitoring. She states patients were flopped into a wheelchair from the X-ray table after deep sedation was administered. She states no one monitored the airway as they dozed and leaned over in the wheelchair. She states the busy MAs were not watching them afterwards at all. She alleges Dr. Page and the MAs would often make derogatory remarks about patients on the table. She states Dr. Page bragged about sleeping with a CRNA colleague whom he hired after she was fired. She states he often described how their dates went and gave details of his love life while the patients were on the procedure table. She states the MAs drank and ate in the procedure room to the point that food would be spread out over her anesthesia cart in the morning. She states the MAs acted insolently and rude when they were asked not to eat in the OR. And pretty much this was reviewed by the same board-certified pain management specialist who often works for the board. And he had very similar concerns as the last case.
Okay. Mary, can you come over and help me? I'm frozen. I'm frozen. I can't even get out. I can't even exit out.
I'll give you mine. Hold on.
I don't know why. I won't. I don't know what happened. Okay, thank you. You're welcome. Maybe get it to unfreeze.
Try.
Okay. Dr. Page or your attorney, would you like to respond?
Well, I think that I already did with my prefatory comments, and that Dr. Page addressed in terms of the various accusations about the office and the policies. One clarification I wanted to make: the questioning by Dr. Madem about the standard of care for timeouts. Certainly, that's something that is a great practice, but I think the reality is, unless I'm incorrect, and Dr. Madem, you have the better resource that this is not a standard of care, and that the expert Dr. Hogan concedes that it's not currently the standard of care. Certainly, it's great practice to have, but that timeouts aren't recognized as the current standard of care for offices. And I also want to clarify that Dr. Page did testify that he has practiced timeouts for the last at least 10 years of his practice, and that certainly at this point for the last 2 years they've been documented. And certainly documentation is proof, but of course his word is that they've been doing it for the last 10 years. One other clarification that I actually did not raise in terms of the timing, and I do think timing is important. Miss Rose, PR, the first CRNA, quit in the beginning of October 2017, and I do think that, and then the complaints were filed in the mid and at the end of October of 2017. I do think it's significant to note that this MICA audit that Dr. Page is referring to occurred at the beginning of October 2017 in terms of the recommendations that were already being implemented by the practice and that were shared by the office manager to the staff in terms of things that MICA recommended could be implemented to assist with safety. And then, interestingly, those were similarly repeated in the complaint by the CRNAs.
Can I ask a question?
Go right ahead.
Dr. Payne, I understand your response, but do you think that all of these allegations are just false or sham, or that because I'm getting the impression from you and from your counsel that we're wasting your time. These things are just minor, or we've taken care of them, or they're not that they happen from a disgruntled employee, or I'm just getting the sense that this is all foible.
Safety is a huge concern, and like I said previously, any opportunity to make to improve safety, I'm all for, and it's a constant evolving process, and we're not all perfect, and I take this complaint very, very seriously. And we've looked at everything from A to Z, trying to improve in any possible way that we can. Sometimes these outside entities that come in and do inspections can be a big help, and and they have. And even complaints like this can be, even though it's uncomfortable and I don't like being here, I look at every opportunity to improve. And honestly, I think probably we could have, we possibly should have had RNs earlier than we did. I wish that maybe we would have. Luckily, we've never had any incidents, and as far as having X-ray techs, certified X-ray techs, I think they have been helpful to the practice, and we have probably saved some X-ray exposure. Just ever since I've been doing procedures, I've used a foot pedal and taken my own X-ray pictures. But I think more and more, as some of these policies and procedures that are in surgery centers are trickling down. They start in hospitals and surgery centers, and then they go to physicians' offices. And I think, we could have been a little slow to move in that direction. But I think we've made a lot of good changes in the practice.
If you have one CRNA that has these issues and raises them, that's one thing, and maybe we can dismiss that as a disgruntled employee in whatever scenario. But there's two of them separate here. So do you have any thoughts on why this may have happened kind of two times in a row, and why these are similar allegations?
There was a lot of hard feelings between when these CRNAs were let go. They were let go just about the same time. These CRNAs communicated and basically filed this complaint together. They raised some concerns. I'm not going to dismiss them, but we had a lot of issues, and I'm really not here to go over all the issues we had with these CRNAs, but there were a lot of hard feelings. The one particular CRNA couldn't get along with the other physician in our practice, and they literally, it was awful. We did conflict resolution meetings all the time. I just think there were a lot of hard feelings. And then the other CRNA was very upset that we didn't give her a raise. And so I think it was just sort of, kind of a timing. Since then we've had many other CRNAs that have worked for us that have never raised any issues or concerns. And, we've had two CRNAs in the practice for over a year and a half since they left. And, they've had no issues at all.
Any other question?
I do.
Go ahead. Dr. Herbstreit.
So when you do your procedures, how many days a week do you do your procedures?
4 or 5 days a week.
4 or 5 days a week?
Yes.
Okay. And then on an average, how many procedures per day?
Maybe 35.
You think that's a lot?
I mean, I have been discussion with other pain physicians in the community. Some do more than that, some do less.
How do you think patients interpret that? Well, I can tell you, because they tell it's a mill, and they're very uncomfortable about it. They just feel like they're just a number. They get in, they get out, and they're on their way. So in terms of a patient-physician relationship, it's not a very good one. Okay. Now, I'm not talking about your practice particularly. I'm just talking about the pain management arena that's out there, because it's not okay. And that's how they look at it. And mistakes can be made. 30 procedures a day. Now, these procedures range from what? Joint injections, nerve blocks, what?
Yes, joint injections, knee injections, hip injections, epidural injections.
RFAs?
Yes.
Okay, what else?
That's the majority of them.
So it does sound like it is the standard, but I'm in total disagreement, and I think you're going to find that through as the insurance companies get more of the patient dissatisfaction, that there's going to be an allotment on the number. Okay. And just like you got pressured in to rearrange your whole office, because they're going to have standards of care for practices in pain management, and it's not every guy or gal is going to be able to open their own shop, okay? Because they're responsible to the patients, and so are we. So, I think that's an awful lot of procedures.
Anybody else? Yes, go ahead. Because we do want to let the complainant time.
I'm just wondering if I can, what kind of workup do you do? Who does your physical exam and history?
There's 15 providers in our practice. I mean, the patients get initial consultation done by
providers. What does that entail?
Nurse practitioners or other pain physicians, and imaging is ordered.
Role like the mechanic, you come in and do the.
I'll see some new patient consults and follow-ups as well.
Mm-hmm. Yeah, I just wonder, what did you notice in the chart review in terms of connection to the patient, in terms of review of symptoms, review of taking a physical examination, being treating it like a medical practice?
The truth is, it's been so long since I did this case that I can't tell you that right now without reviewing it again. I don't really remember.
Do we want to let the complainant make a statement? Go ahead and open the phone up, and if you'll do that, Justin. And this is, tell her to go by her initials. This is SC.
SC, are you still available?
Yes, I am.
Okay.
SC, I'll come over there.
It's right here.
Yeah, I'm turning my speaker off so I can hear you better.
ISC is Dr. Cunningham. I'm the chair of the Osteopathic Board. I hope you've been able to hear a lot of the statements that Dr. Page and his attorney has made. Would you care to make any statements regarding what you've heard today?
It was a little difficult to hear Dr. Page's attorney. I could hear Dr. Page pretty well and Dr. Cunningham very clearly. My statement was read, and I stand by it and still agree. However, I was there I left 2 years ago, and so I did hear what Dr. Page had to say, but when I was there, it's all I can attest to, and it was an unsafe, very hurried practice that I found unsafe for the patient. Very worrisome. And I mentioned that in a couple times to Dr. Page, and I was sort of brushed off. And that's when I finally said, I'm just worried about my own license and my own career, because I've done pain other places for many, many years. I've never had a situation such as that. So I did, I complained because I was worried about x-ray radiation not being monitored. I wanted to wear a custom-made apron of my own to protect myself, and they wouldn't allow it because it was the wrong color. Their aprons were very skimpy and little, and I was constantly having to turn around to do my, drop my medications for the patient, and basically dumping them in the wheelchair and having the MA watch them while we went to do the next case over and over and over again all day long was just so unsafe for me. I left and didn't really quit. What I did was complained, and then they didn't put me on the schedule after Dr. Page replaced me, so I didn't have. According to my contract, I was supposed to have a 30-day out, and they didn't abide by that. So I called OSHA, and they stepped in, and they did get me my severance that I was due because I was summarily not put back on the schedule because of my complaints, I figured.
Can I ask you a question? So is it your statement then that there were medical assistants that were starting IVs and pushing medications through those IVs?
Yeah. The way it was there, because we had such a large amount of patients every day, the MAs would start a little hep block on IV on the patients before we brought them in the room. So I was with the preceding patient, of course, finishing them up, and the next patient would get a hep block, which means IV access without the fluid came in there, and no tubing, but there was still an access port. And so the MAs would start that. We would do the case. I would afterwards the MA and I would bring them out sleepy in a wheelchair to where the other MA was busy intaking the next patient. He would keep an eye on both, sort of. And word would get back to me in the OR during the following case, oh, so-and-so is achy or so-and-so is nauseated. Can I give Zofran or Toradol? And I would say yes, because I was with a sleeping patient on the table at the time. So they did do that, yes.
Okay. What about the X-ray? Who was with the patient in the PACU or after the? Was it the MA that would monitor them? Was it you? Because I was saying that you should be monitoring them and discharging the patient.
There was one MA who did pre and post-op together. He'd have a room full of patients. Some were sleepy, some were just getting checked in. And he had to do it. The man I was mostly working with, the MA, did it all by himself because I was across the hall in a room with the door shut because of X-ray.
Okay. And then what about the C-arm with the X-rays? Was Dr. Page degloving and then repositioning the C-arm?
No, absolutely not. He would tell his MA, move it here, move it there, or she would just move it because she was very used to working with him. And when I mentioned that to Dr. Page, he's like, oh, no, I'm doing it, Steve. When they come back to ask, you tell them, I'm doing the X-ray. I said, well, no, I'm not, because you're not doing the X-ray. The MA is. And so, yes, the MA did the X-ray. Dr. Page was in the room. He would direct them if he said, oh, a little higher, a little lower, whatever, but the MA was running the X-ray machine. That's right.
So it's your statement that you filed this complaint not because of retribution to Dr. Page and the practice, but because of the unfair, the unsafe environment that you were in.
Absolutely. I picked up a different job, and I'm still doing pain in California, even as we speak. And I moved on with my life, and maybe someone would say, well, I'm out of there, so I don't care. But I've been doing anesthesia for 25 years, continuously, 25 years. And I have to say, I've never seen a place that runs that hurried and that carelessly. At least at the time, it was hurried and careless when I was there. That's what I observed. And I thought, if I had a relative going in there for pain, I wouldn't want this to happen to them. So that's when I complained and started this. I had no retribution whatsoever. I was already out, moved on, but I just was concerned for the community and the patients. It's a pure safety issue.
One last question. Did you observe or did you have any knowledge of Dr. Page that you felt was doing inappropriate procedures on these patients?
I did not have access to the charts to see that it was only 1 week or 2 weeks from the preceding one. I didn't see that because I rotated my schedule with another CRNA there. So she and I were never there at the same time, but I wasn't there every single day. I think I was there twice a month. And so I wasn't aware that they were being done that frequently, but I know it's way too much. The interval too quick for steroid use and radiation use to be that fast. Yes, I did not know that, though. I didn't have access to a chart.
And I'm sorry to ask one last question. Were you aware of any poor outcomes with patients that had a procedure and they had issues with breathing or things like that, or had to be...
No.
Okay.
No. In terms of anesthesia, I can't speak for the pain-related part of it, but for anesthesia, I'm very familiar with giving propofol and aliquot dosages, so they're not apneic. And I was very aware of not sedating people so much that they would be unsafe. And in fact, I have to give Dr. Page credit because he did say, hey, if they move a little bit, I'm okay with that, which is great because I was very certain that they had to be breathing and safe, taken to recovery, or they wouldn't go to recovery. They would stay in the operating room a little longer, which is what I did from time to time, keep them on the table a little longer so we could actually roll them into a wheelchair from the X-ray table and wheel them out. I only wheeled them out when I knew they were still breathing, even though they were sleepy, because I knew no one was licensed to watch them afterwards.
Okay. Any questions from board members? Any questions that you have, Dr. Erbschasser, Dr. Madam,
No.
Dr. Rees? No. Dr. Craw? Okay. Thank you very much. Thank you. Still stay on the line here, and we're still in session here. Any responses that you would like to make?
Dr. Payton.
No safety concerns were made by her until after she left the practice, number one. Number two, she had a lot of safety issues herself while she was there. Many of her history and physicals were totally inaccurate. One of the reasons she was let go was she did group interviews with all the patients where she would line everyone up in a circle and ask them if they had high blood pressure or if they had issues like that. And so there were multiple issues why she was terminated. I've always taken every x-ray picture myself with the foot pedal. No, it's just not true that when she's
positioning the C-arm.
There were times that the medical assistant's position, which we found out was not allowed, and that's why we had all of our MAs sign a form saying they were not allowed to touch the C-arm.
Any other questions from board members?
When did they sign that?
After this complaint was filed.
So a lot of things happened after the complaints, right?
Any questions from you have any questions? I'm going to make a motion to go into executive session for legal advice. Can I have a second?
Yeah.
Dr. Reese, all signify by saying aye.
Aye.
All opposed, same sign. We'll be right back. Thank you.
I think it's updated. We got to get with the medical board and with Sean on Monday. We'll get with Sean to say what's going on.
If we have that number to call in on Monday for follow-up would be great. Where's that, ma'am?
Justin, can you go over that number?
Yes, I'll get it right now.
480-657. 657-7703.
Yep.
Okay. Yeah, I have nothing really to add. I mean, you guys covered it very well. And if I have any, if you want to ask me anything else, I can stay on. Otherwise, I can just wait for your follow-up. That's all right.
Do you want her to stay on the line?
No, that's okay. I think we're good.
Thank you. Thank you.
We're waiting for Dr.
All right. Thank you very much for hearing us now. I really appreciate it.
You're welcome.
We're waiting for Dr. Reese.
Thank you. Bye-bye.
Bye-bye. Yeah, that's yours.
All right, we're out of executive session for legal advice. I think that the board members, such as myself, we just had some more questions about the roster here. Is this a complete roster of all your past employees and current employees of all offices for the last 2 years? Is that what you said?
It should be for the last 2 years, but that would have been as of maybe early March.
So, and this is for all offices, including your Tucson office here in Phoenix and also in Tucson?
It should be. If there's something specific that you think is missing or incomplete, I'm happy to address that.
Okay.
No.
Yeah.
So that's really your responsibility.
Yeah.
Absolutely. I just the question was asked in a way that I thought maybe there was a follow-up. Okay.
Gene, what's your feeling? Is this sufficient, or do you think I need to move forward with a board order to get more information? What's your feeling?
That's up to the board. There's 6 pages of employees. Not all of them have contact information.
Yeah.
We recognize that this was just given to us today. You may want to suggest that the staff take this and work from it, and if we find that it's not sufficient or we need additional information, you can authorize the staff to issue a subpoena for additional information.
So I think that the thing that I appreciate you getting this finally to us, but I think that there's, like you said, their contact information I think is still not what we have on there. I think the addresses are the thing that we need to have on there as well. Dr. Pross says she has responded to you. and let you know that those would can become confidential. Also, in addition, we want the email addresses, if you have those two, of each of the employees. And date of employment. Do you have dates of employment as well? Dates of employment for these. You got the position, you got current and past. So I guess it was date of employment, address, and emails as well, as we were looking for as well.
So I attempted to explain why there was only limited information in the phone number column before, but you...
Go ahead.
So some of these employees are former employees because of the 2-year time frame. Those employee HR records are held off-site in storage, and so what the office staff had to do was literally pull the files and find the phone numbers and get that information. The phone numbers that you have are the phone numbers that they have. I'm happy to do another follow-up with the staff to get that information that's requested. I believe the addresses were provided with the second version.
They're not on this one. I don't see them.
Right, because the request changed. The first version just asked for the names of the current employees. The second.
How about you do this to make it easy on our staff? Put it on everything on a spreadsheet, just like you've done here. Like I said, and in addition to this information, then add the address and also emails if you've got that as well, and dates of employment as well. And I think you've got the position and. You got and you've got everyone from MAs, PAs, MDs, DOs, LPNs, EMTs, front office staff, everybody in their entire practice.
In a timely fashion.
So, right. So,
Dr. Cunningham,
yeah.
Sorry to interject. Could we also request that it be in a digital format like Excel and not a PDF?
Right. Could we get it in a digital format as well? Okay. All right. Okay. And then, when do you want this by?
2 weeks.
2 weeks. Okay. So today is
17th.
Let's look at the 17th. Let's look at the calendar. So we would like to. How about we? If you have them to us by, I think will be by June 3rd. That'd be great. Okay. June 3rd. All right.
I want. Dr. Cunningham, is it feasible that we get... You said you had Micah come out and...
Yes.
Say again, I can't hear you.
Yes, Micah came out and did an inspection.
When was that?
When
was that?
I believe it was early 2017.
Okay, so can we have a copy of that?
Yes.
Report?
Yes.
And who else came out? Radiology?
Yeah. Let's see, the DEA did an inspection.
Okay.
When was that?
I think it was in...
So you're asking for copies of reports from his malpractice carrier on internal assessments that were done? The board is asking for them?
Internal
Potentially
assessment.
privileged.
Privileged for what?
In terms of information from his malpractice carrier, in terms of recommendations?
Do you want to see what the recommendations were?
Okay, that's fine. I'm just clarifying.
Yeah.
Okay.
The DEA did an inspection.
Yeah. And I would expect them to. So we should have a report on that.
Okay.
And we should have it on radiology. Radiation.
I came out to talk to you as well.
Because when we used to have X-ray in our office, we had that too. So I would like to just kind of take a look at that.
Okay. And if we can have all that by June 3rd.
Did we want to ask what was the reason that Micah came out? Did you invite them out, or was
the
there an
random inspection? They
Random?
inspect all of their facilities.
And so, as far as you know, this is the complete list that you have from all offices?
For employees for the last 2 years, as of March 2019, yes. But we will update it and provide it by June 3rd.
Okay, great. All right.
And this MICA assessment was the one that was performed in October of 2017?
We'll take that as well. Okay.
Well, that's the assessment that Dr. Page was referencing. Okay.
Anything else that you... Go ahead.
If there are any Medicare inspections or communications that we...
Have you had any Medicare chart reviews or anything like that
No.
recently for billing, any of those types of
Not
things?
that I'm aware of.
Anything from the OIG?
We did have an OIG issue several years ago.
What's several years?
I think it was in 2016.
Okay. Were there issues or?
No, it had to do with the Millennium Labs was giving us urine cups for free, and apparently...
Got it. That's fine. I got that. But if you have that report, the final report, that'd be nice if you sent that to us, okay? Nothing from Medicare, nothing from any of the insurance carriers that have come out or anything like that recently?
No.
For chart reviews or anything like that? From United Healthcare, any of those things?
I mean, we get chart reviews from all of those insurance companies regularly.
So do we in our office, but I was just curious if there were any issues at all. Have you been ever ordered to pay back any monies or anything like that?
Not that I'm aware of.
Okay. All right.
You were real specific about that micro report from 2017. Is there a more recent one that happened?
No, that was the last one.
Okay.
All right.
Do you want to reduce this to an order? So it's clear what you're
I think that we
requesting?
should do it as an order, and then let's get it to them, and then there is no
ambiguity.
Yeah, ambiguity, and there's full clarity. Okay.
So I would need a motion.
So I make a motion for an order, just as I have stipulated before. You've got all those, Gene, don't you?
Yes.
Okay. I have a motion. Can I have a second? Second from Dr. Madam. Any discussion? All in favor signify by saying aye.
Aye.
All opposed, same sign. And then once we get that information, we want our board staff to do some more investigation. We will reset this then to have you come back again. Dr. Prowl, what are you thinking? September? We have August, September? Okay, September. We're going to try and get this on the board for September.
I have a trial date set for an almost 2-week trial in September.
Okay.
So just
you can work with the
as
board
a note.
and talk about it, okay?
Okay.
All right. All right. Any other, anything else? Okay. We'll look forward to seeing you in September. Thank you. Okay. Next case is DO-18-0014A, Roy Niles Skousen, DO, license number 2214. Dr. Skousen, can you come forward, please? Thank you, Dr. Skousen. Just have a seat right there. Welcome. Thank you. Can you swear in Dr. Skousen for us?
Do you swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do. And can you introduce your counsel with you?
Hi, I'm Tom Swift from Tucson.
Okay, great. And Dr. Skousen, just briefly, can you just tell us about your training and the current practice that you have now?
Let's see, I graduated from Kirksville in '85. Did a rotating internship with Dr. Pra here in Phoenix. Went back to Tulsa, Oklahoma, and did a anesthesia residency. And currently board certified. I've practiced in Tucson, Enid, Oklahoma, Tulsa, Oklahoma, Oklahoma City currently at the University of Oklahoma Medical Center.
Okay, great. And Dr. Pra, I believe this is yours.
Yes, it is. Dr. James Gillard and Dr. Christopher O'Neill filed separate complaints reporting the conduct of Dr. Skousen, an anesthesiologist, during a medical procedure. Dr. Gillard is the chief of staff at Carondelet St. Mary's Hospital in Tucson, and he reported that on November 1st, 2017, Dr. Skousen was unable to continue anesthesia care to a patient in the operating room. Dr. Skousen was transported to the hospital emergency room, but he stated he had not complied with the hospital's investigation of the incident. The second complaint was filed by Dr. Christopher O'Neill. In October of 2018, Dr. O'Neill advised that on November 1st, 2017, he responded to the hospital operating room after Dr. Skousen was found slumped over in a chair and unresponsive. Prior to that, he had problems intubating the patient and dropped his laryngoscope along with other signs of impairment. He was unsteady, bleary-eyed, and appeared intoxicated. Dr. O'Neill assumed anesthesia duties for the patient. Dr. O'Neill advised that this incident could have resulted in severely injuring or killing the patient. He stated that when he arrived to take care of the patient, the anesthesia gas, sevoflurane, was nearly off, and the patient was hypertensive and tachycardic. He states Dr. Skousen stood up and was unsteady and bleary-eyed and appeared intoxicated. Dr. O'Neill said he told Dr. Skousen that he was relieved and he shouldn't drive. He told him to go to the emergency room for an evaluation, and some staff members assisted him in a wheelchair. Dr. O'Neill found that the anesthesia record was nearly blank after 2 hours of care. He stated it was a very messy anesthesia workspace, and he was unable to tell what Dr. Skousen had been doing for an anesthetic. He stated there was 100 micrograms of fentanyl unaccounted for. Dr. O'Neill also noted that the intraoperative record was unreadable with scratches for notations. No pre-op evaluation was documented, and it was completely blank. What notations were on the record were inaccurate and based on the automated record kept by the machine. Dr. O'Neill found that the patient was halfway through a 4-hour reduction mammoplasty. Based on the monitoring recordings just prior to his arrival, the patient's anesthesia was turned off and she appeared to be nearly awake, hypertensive, and tachycardic. Dr. Skousen responded that this was a one-time incident and he was not allowed to return to the hospital or continue work. The emergency room doctor, he states, the emergency room doctor concluded that this incident was probably a cardiac event, and he was later to see Dr. Udall, a family practice physician, who he states believed the matter was related to blood sugars. Dr. Skousen stated he did comply with the hospital's investigation. He advised that after the incident he was able to drink some chocolate milk and a soda with caffeine and felt much better. He believed that the incident was a momentary lowering of his blood glucose that corrected when the problem was resolved. We also included in this report are some medical reports from the hospital emergency room, but I don't feel comfortable to bring those up unless we go into executive session.
Okay. Great. Dr. Skousen, would you like to make any comments before we ask any more questions?
I'd be happy to explain from the beginning to end if that's what you need me to do, or I can just respond to questions however you'd like.
Why don't you just give a 2 to 3 minute what's going on?
Okay. I was doing locum tenens work in Tucson. I'd previously worked in Tucson after I'd finished my residency, and then moved back to Oklahoma. And I was always kind of wanting to return to Arizona. This is where I'm from. I was born and raised. Most of my family still lives here. I'd worked there for 2 weeks and didn't have a single problem. It was a Monday morning. I hadn't slept the night before. I had leg cramps. I had taken some Klonopin to help relieve that, thinking that I might get some sleep. I got up the next morning, had just a quick soda for breakfast, went into the long case, and at about an hour and a half into the case, I just felt real fuzzy. I noticed that I couldn't quite concentrate on marking the chart, and the paper that they had given me for the chart, evidently, when I wrote on the back of it, it leaked through to the front, and when I wrote on the front, it leaked through to the back, so it would have been an inappropriate chart. So I didn't chart a whole lot of things on that, thinking I would get another pen later and finish it up from the automated record keeping. I could just transcribe it to the paper. Well, when I was feeling fuzzy, I heard this code blue operating room, such and such, and I go, wait a minute, that's the room I'm in. I got up, walked over to the nurse, and I asked her, what's going on with the code blue? She explained to me that she had seen that I was kind of sleepy and kind of trying to fight it off, and that she had called Dr. O'Neill. Dr. O'Neill said he could not come now. He says he was in the middle of a case, and he got angry, and he says, well, if he needs that much help, call a code. So the nurse called a code. And I'm like, oh, well, okay. And so I went back to my station, and finally Dr. O'Neill shows up at about 5 or 10 minutes later, and at that time the patients had started to move. They had switched from one side of the mammoplasty to the other, and they had gotten... The initial incision is, again, stimulating on the opposite side, and so she started to move a little bit. I increased the amount of inhalation agent, got some muscle relaxant out, and gave the muscle relaxant. At that point in time is exactly when Dr. O'Neill walks in, and he says, "Are you okay?" I said, "Yeah, I'm fine. I had lost my pen. It had fallen on the floor, and I was looking for it. And again, the pen, because it was the type it was leaking through into the paper and also on my fingers." But he said, "Why don't you go take a break? I'll kind of look after things." And I said, "Well, I don't have much written down because, I've been busy, with the pen and stuff." And so I went and got a couple of, I think it was a couple of cartons of milk, a soda, and maybe a muffin. I can't remember exactly what it was. I was gone about 10, maybe 15 minutes, came back in, and by that time Dr. O'Neill said, "Well, we need to send you to the emergency room." And they had a wheelchair there waiting for me, and I said, "Emergency room, I'm fine now. I think my sugar was a little low. I feel much better now. I got a little caffeine in me." And they were insisting that I go to the emergency room, and being just the rental there at the hospital, I said, "Sure, no problem." And they said, "Get it in the wheelchair." And I says, "I don't need the wheelchair." So I walked down to the emergency room, and there I met the emergency room doctor. We went through the whole emergency room procedure, after which I hung out in the emergency room for another couple of 2-3 hours. And then I went back and talked to Dr. O'Neill, and he says, "Well, we don't need you the rest of the day." So I got in my car and drove back to the hotel.
Dr. Pra, the only thing I didn't... we got to go into executive session for the Dr. Sucher. Okay, all right. Any questions for board members before we ask them anything else?
One thing I might want to point out is that every time that Dr. O'Neill has recounted the story, it's he came in, I was slumped over, unresponsive. But when he came in, I was administering medication to the patient. I'd already increased the level of anesthetic. And he sent me off for a break. I ate, felt better, and then came back. He always says in his accountings that he sent me right off and that I was put in a wheelchair and taken off to the emergency room. There's so many discrepancies, and each time that he tells the story, that I begin to wonder.
Do you have a question?
Well, that's a big difference.
Yes, it is. I agree. And that...
If you weren't feeling well, why didn't you let somebody know?
Well, I wasn't aware that I wasn't functioning at 100%.
Well,
I had not been up the night before, and that happens all the time with anesthesia, obviously. And I was doing fine the first part of the case, and I realized that I was just getting a little sleepy, and then I heard the code blue. And at that point in time, I'm going, "Oh, well, what's happening?" So I went and talked to the nurse, and she says, "Well, looked like you were falling asleep." And I said, "Well, yeah, I think I was, but I was on a rolling stool, not a chair." And I don't know how many of us have had experience with that, but if you fall asleep on a rolling stool, you'll fall on the ground. So I couldn't have been slumped over my equipment. I couldn't have been slumped over as they describe. It was physically impossible.
Has this ever happened to you before?
Never. This hasn't happened since.
It was one single time.
One single time in a case, which was the most bizarre part.
And what do you think it's blood sugar?
I know that through the history of working and things, I get a little shaky, and usually I can ask for a break, or we used to be able to drink in the operating rooms, obviously, and so I always had a soda or something, or in a substerile room I could go grab a Dr. Pepper or something like that. But then they got a little bit more strict on drinking in the rooms, and so I had to plan it. And everywhere that I've worked, they're pretty good about giving breaks. This at Carondelet, no breaks, no lunch. You hurried from place to place. You were lucky if you got any time until the time we were ready to go home. I can't use that as an excuse, but that's the only thing I can think of.
We're going to go into executive session and ask for... okay. So, can I have a motion? Dr. Reese, can I have a second? Second. We're going to executive session for medical information from the doctor. All in favor signify by saying aye. Aye. All opposed, same sign. So all of you, can you just step out for a while here?
And please take your belongings.
Take all your belongings too, please.
I think that's one of the...
Oh, yeah, that's my stuff. Okay. Yeah. Thank you.
Yes, I thought so.
Thank you.
information. Just stay there and relax. I'm going to make a motion for us to go into executive session for our legal advice. I got a second from Dr. Reese. All in favor, say aye. Aye. All opposed? We'll be right back. Just stay where you're at.
That's about the only way I can do it.
Good. I drank almost a whole pitcher of water today.
Doctor, and I want to tell you, that's true. Your family I have known for many years as being DOs in this community, as well as yourself. And that being said, I think that you have been an integral part, as well as your family too, but I think the board has concerns, and I think you do too. I think you realize you haven't been taking care of yourself, okay?
Absolutely. I agree.
I don't think we want to do anything right at this point with you until we get some more information, okay? So don't look at this as anything punitive. We're just here to help you, okay? So I want you and I know you said you're under the 8 ball sometimes with your finances. It doesn't do any good if you're not here. That's what I just tell you, okay? So what we'd like to do is I'd like a motion. I'm going to make a motion to do an interim order. So I'd like to all of these individuals need to be approved by our board. And if that happens, if it's a person in Oklahoma where you're at, that's fine, okay? Just get all the information. So I'd like to have you see an internist, okay? Get a full evaluation, all right? Get some blood work, get a full workup. I'd like to go get a cardiologist, too. Get that done, too. You have a history of sleep apnea, like you see a pulmonologist. Mm-hmm. And then you're a stressed man. You've been through a lot of stuff, this and everything. And I don't think you're crazy. Please don't think that. And I always tell this to Dr. Reese, too, our psychiatrist on the board. I'd just like you to go get an evaluation by a psychiatrist, okay? And just do that for us, okay?
Absolutely.
So if you can make those appointments after the board order comes out and make those appointments within 15 days after that. Doesn't mean you have to be seen in 15 days, but at least make the appointment, and hopefully then be seen 30 days after that. And then we'll come back and we'll talk about this in either August or September, okay?
Sounds
and
good.
Hopefully then we'll get this all behind us, okay? So that's my motion. Do I have a second? Second, I'll do it, Mr. Burry. And any discussion before we vote? All signify by saying aye.
Aye.
All opposed, saying aye. Thank you so much, Dr. Scalzo, for coming. Thank you for all your work and what your family has done in the DO community, okay? We have an applicant, I believe, that needs to go catch a flight.
Dr. Mitz, case number 2019-0067.
I'm sorry, which one is it?
Dr. Mitz.
Dr. Mitz. So this is DO-19-0067A, Kyle Blaine Mitz. Welcome, Dr. Mitz. Please tell me, whose is this? Is this yours?
I can do it, Dr.
Yeah, just your real quick for us.
Okay.
Go ahead, Justin.
Dr. Mitz applied for a license on January 29, 2019. Dr. Mitz disclosed a yes answer on his application. Dr. Mitz states he was arrested, pled no contest, and paid a fine, which resolved the matter.
You know, this is a long time ago.
Yes.
Tell me what happened. Because you didn't really give us an explanation what happened. I know it's a long time ago when you were in your undergraduate. What happened?
Oh, I was just on spring break on the beach with my buddies, and I wasn't 21, and I didn't look like I was 21.
You don't look 21 now to me. Okay.
So when they approached me, they said, "Are you 21?" I said, "No." And I got a ticket, paid the fine, and then I pled no contest, basically.
No history of alcohol issues, anything, nothing like that?
No, sir.
Where are you planning to go practice?
So I am finishing my residency in Dayton, Ohio, and I'm going to be in fellowship at the University of Arizona for neurorhinology.
Congratulations.
Thanks.
So what? I'm sorry. What?
Neurorhinology. They're changing the name of it. It used to just be rhinology, but now they're trying to
Neuro
make sure that you're getting enough skull base.
Rhinology.
What, you study the nose?
Well, and the neuro aspects of all that.
Yeah,
nerves.
Brain tumors through the nose, basically.
Yeah. It's becoming super subspecialized.
Yes. Wow.
Good for you.
Where is your training?
In Dayton, Ohio, at Grandview.
Huh? Yeah, sure.
Spend time there.
And they have a specific...
No. He's going to be doing that at the U of A now.
Oh, the U of A.
He's going to be going... So he needs a license to practice here. Any questions from other doctors? All right. Thank you for coming. I'm going to make a motion.
To approve for an unrestricted license.
For an unrestricted license, go ahead. Dr. Maiden made that. Can I have a second?
Second
by Mr. Berg. All in favor signify by saying aye.
Aye.
All opposed, same sign.
Wear a beard so you look a little old.
They told me that when I first started to wear a mustache, and I look like a caterpillar on me. I don't know. When I started many years ago. Okay. Welcome to Arizona. Thank you for coming. Okay?
Good luck.
Thank you.
Good luck. You're going to have to probably explain this every time you go somewhere, so hopefully you won't have to do it anymore with us, okay?
Okay. Thank you.
Good luck to you, sir.
Thank you.
All right.
Don't do that again.
All right. So we're going to go back to the cases. Next case is JDO-18-0092A, George William English, license number 1197. Doctor, come forward. Welcome. Could you swear the doctor in, please?
Please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
And can you introduce your counsel with you?
Kimberly Kent, your
Not my own. Just call me. I like being called that, but it's no.
I'm sorry.
That's fine.
It's
that's
Kimberly
fine.
Kent. It's been a long day for me, too.
Oh, I know it's long.
Longer for you, though.
Okay. Thank you for being here. Can you just tell me a little about your training and also what type of practice you have now?
Okay, 1971.
Just talk right into here because we're hard to hear.
1971, I was graduated from the College of Osteopathic Medicine and Surgery in Des Moines, Iowa. Went to Tucson, Arizona, and completed a rotating internship at the Tucson General Hospital in '72. Practiced general medicine in Tucson for approximately 4 years, and in 1976 was accepted in the residency program at the old Phoenix General Hospital on Indian School on 19th.
I remember you were there. Yeah. That shows you how old I am.
I've been in practice as a general radiologist with a specialty in mammography in the cities of Glendale and Phoenix and Mesa.
Okay. Do you want to go ahead and do this case, Dr. Pra?
Mm-hmm. This was reviewed by a board-certified radiologist. This patient had a screening mammogram at mobile on-site mammography on March 9th, 2009, and was interpreted by Dr. English as being normal. On May 2nd, 2014, she had another screening exam that was also interpreted by Dr. English as being normal. On October 21st, 2015, she presented to her primary care physician with right breast pain. A diagnostic mammogram, ultrasound, and contrast enhanced mammogram were done at Mayo Clinic on November 3rd, 2015, and these tests showed masses in the right upper quadrant and right axillary lymphadenopathy. Biopsy showed that it was invasive ductal carcinoma and with mets to the axillary nodes and bone metastasis. Our expert did look at all the mammograms and felt that the 2014 mammogram showed a significant increase in the calcifications throughout the right upper quadrant. With increased nodularity, it also can be argued that the right axillary nodes appeared enlarged. Her concern was that there was an 18-month delay in the diagnosis of breast cancer, which may have increased the chance of metastasis.
You heard the review. Would you care to respond, Doctor?
Yes. Let's take it in three basic areas of her concern and what I saw. First of all, let's talk about the calcifications. calcifications were multiple scattered in both breasts. They were of different size, but they were microcalcifications. Calcifications because of age, and this particular patient was seen in 09 and in 14. And 14 is when calcifications had slightly increased in its overall number, and I felt at the time, because of the aging, that this probably was something like adenosis or secondary to it. However, the other thing that I have a little bit of a question about was the term nodularity and increased density, if I'm not mistaken. Mm-hmm. We've had at least 4 radiologists review these, including myself, including the plaintiff's radiologist. There was no mass. There was no nodularity. The nodularity and questionable mass was obtained when they did the contrast-enhanced diagnostic mammogram. And it was also noted on the ultrasound, which we don't do when we do screening mammograms, neither one of those procedures. In fact, the Mayo diagnostic mammogram, it was experimental doing contrast enhancement, and contrast enhancement shows increased vascularity. And that's when they saw the area of increased vascularity and then ordered an ultrasound, which led them on the path to getting an ultrasound diagnostic study, which was then biopsied using ultrasound. So that's the other question. And the other one is the lymph node that she talks about. The lymph node measured less than 2.5 centimeters. It was a solitary node, and it was on the films. However, any node that's less than 2.5 centimeters is generally considered within the normal range. So I understand what she's saying, but I have to disagree with the way she presented it. There was one area also that I have a little question about, and I want to bring this up because it really impacts any physician that has to come before the board or even goes to court. When somebody makes the statement they fell out of compliance and they weren't within standard, that bothers me, for one thing, because I'm the one it's directed at. But there were other radiologists that looked at this, and all of a sudden they're considered out of compliance too then, or not following the standard for a radiologist interpreting mammograms. But she is talking about a mass, and nobody, not plaintiff's attorneys, not my defense attorneys, were ever able to initiate from any of the expert witnesses that there was indeed a mass there. So I'm a little confused by that statement.
What do you do differently now? If you had the same case, what do you do differently now?
Well, luckily now we're doing 3D on screening mammograms, and three-dimensional, or tomosynthesis, as the proper term is, allows us to look through the breast in millimeters and actually see if there is something that would be suspicious. So, yes, it's a great aid. And again, we're talking, when this was done in 09, and nobody in 09, by the way, ever questioned whether there was anything there. And it's the 14 study that people were a little maybe concerned about, and that's why they brought this up. It's in tomosynthesis, you can look and see in dense breasts, which this woman had, dense breasts, a lot more. And we're doing it now as a screening procedure. Technically, if you want to look at it in a certain way, it's not a screening procedure. It's actually more of a diagnostic study because we can actually see more. But because of marketing and because of the fact that it helps us so much, and rather than having 4 images, we now have multiple images to look at and to be able to understand what's going on within that breast. So, yeah, that's what we're doing now, and I think that's great, and I hope that everybody can bring this on board. It is expensive, but, hopefully we won't be doing just 4-view screening mammograms anymore.
Dr. Erbstrasser or Dr. Madem?
With the breast density and change in calcification, that does not seem that astounding. I really don't see this being significantly outside of standard of practice. Yeah,
I didn't either when I looked at it. I feel bad for the patient.
Agree with that.
I also, my feeling is that Dr. English is as much an expert in the field as anybody we can hire to do an expert evaluation. So I would go by what he says as much as the expert does.
I would like to make a motion for executive dismissal.
I have a motion for dismissal of Dr. Madem, a second by Dr. Reese. Any discussion before we vote? All in favor signify by saying aye.
Aye.
All opposed, same sign. Dr. English, you don't remember, I was probably like 16, but I was a transporter at Phoenix General Hospital when you were working there.
Oh, I remember you. I hair then.
I just had my license, and I got my first job working at the hospital there. I still remember.
Let me make one little statement real quick. This has nothing to do with anybody here or anything that's going on. I don't know if any of the other physicians behind me. One thing that happens in these cases is some physician or somebody in the hospital will make a statement to the patient that, was that tumor there? Was that breast cancer there when you had your mammogram a year ago? We just can't see everything.
No.
And when they say, oh, yes, it was, that's when we get into legal problems.
Sure.
And if nothing else, as we all know, a cancer cell it morphs, and it becomes from one cell into many.
Yeah.
And all this does when we start telling people that is it gives them concern, and then they go see a lawyer, and she'll be out of business. But
all right.
Well, and from that
Gentlemen,
standpoint,
thank
I can say that from the lawyer perspective, we have to be cognizant of the sympathy factor because. It is a sad case.
Yeah, it is.
Very sad.
It was.
It's hard to find a jury that wouldn't be scared to death that this could happen to them. So this was a business decision that was made by the company without the consent of the physician, and he had no control over it. So that's why we're here.
It's nice to see you again. Take care.
Thank you.
Gentlemen, thank you.
Thank you.
Next case is DO-18-0120A, Dennis Lee Furr, DO, license number 006668. Dr. Furr, welcome. Please have a seat right there. You have your counsel with you. Would you please swear in, Dr. Furr, please?
Do you swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes, I do.
Dr. Furr, could you introduce your counsel with you, too?
Bruce Smith.
Welcome again. And could you give us a little bit about your training and the type of practice that you have now, Dr. Furr?
Certainly. I was trained at University Health Sciences, Kansas City, Missouri. Did family practice residency.
I'm curious, when did you graduate?
84.
Oh, you were before
a few
me.
years
You're
ago.
older than me. Wow. Okay. All right.
I'm not 21.
Okay.
And family practice residency in Denver, board certified American College of Osteopathic Family Practice. I practiced family practice since 1987 in Denver. The scope of my practice, I'll explain in Arizona, is I do some chart review consulting work regarding organ tissue donation here.
Okay. Dr. Pra, this is yours.
This complaint came to us from the Colorado Medical Board regarding a disciplinary action taken against Dr. Furr in the form of a letter of admonition with regard to substandard care and treatment of an inmate and lack of documentation. This was a 37-year-old male inmate that began to complain to nursing of not feeling well on December 12, 2014 at 7:56 a.m. His temperature was 102.9. He was transferred to an inpatient unit for closer observation. At 16:48 and 17:01, his temperature was 102.5 with a pulse of 103 and respirations of 20. His oxygen saturation was 91%. At 22:19, his temperature was 103.1. His other vital signs were not documented. He was given ibuprofen and Tylenol. There's no evidence that any provider was called on December 13th, which is the next day, at 07:49 and at 13:33. He was afebrile, and his oxygen saturation was 98% with a respiratory rate of 26. At 15:11, the nursing staff noticed the patient was producing blood from coughing so hard. Dr. Furr was the on-call provider and was notified. He prescribed Robitussin DMX and Robitussin with codeine. The medical record does not document the conversation with the provider other than to mention the prescribed cough medications. The nurse noted the doctor on call recommended 2 medicines that we do not have or cannot get. The nurse did not indicate whether the provider on call was notified the medications could not be provided. At 1600, his temperature was 100.3. His cough was better, but now he's complaining of a headache. There's no indication that the provider was notified. The following day, on December 14th, he was noted to have a temperature of 98.1, respiratory rate of 18, pulse of 121. Oxygen saturation was low at 91%. He complained of weakness, sore throat, coughing, and fever. No indication that any provider was notified. During the evening shift that same day, he told the nursing staff that he was not feeling well and he had liver pain. The deputy on staff noted the patient looked sick. When the nurse attempted to take his vital signs, he was agitated and moving vigorously. He requested anti-anxiety medications and noted that he had coughed up blood. At 13:30, the deputy noted the patient had fallen off the toilet. The video of the patient falling off the toilet and crawling back to his bed was viewed by the nurse and the deputy. Once the nurse went back to check on the patient at 19:41, he was found with no pulse or respirations. An autopsy report reveals that the patient died of Staph aureus sepsis due to bacterial pneumonia.
Hey, Doctor, I know you've been through this already with the Colorado board. Tell me what you think, man.
First, I'll discuss what I was doing. At one point of time, there was somebody that worked for the prison system and asked me to talk about the fact that they don't have a lot of coverage. And they had asked me if I would be interested in working, to which I said no, I have a practice. He said, would you be interested in doing some coverage because we don't have time to do that? And this was a number of years back, to which I agreed because it is difficult in the correctional system, I understand, to get people to cover and do anything, so which I did this. I did contract not for the prisons, but for CCS to do one weekend out of the month and one weeknight as far as on-call coverage, in which case they said they would call me on advice or on cases that they weren't exactly sure about, to which I did. And I will be honest, I have absolutely no recollection of this, and I will tell you why. I was called that one time, and everything I have is from the records that they have. And I can only give you what my routine would have been with the individual. My routine is I was getting a response of somebody who had been ill and was doing better. I, again, not knowing, but I would have asked, what does the person look like? How are they doing? Give me some of the other vitals there. And in the prison system, in this case, I don't recollect, again, this one, but I know at times somebody might have said, well, they said they're coughing up blood, in which case I say, did they cough up blood? Do they say they coughed up blood or what? And in this case, I am only assuming from my habits of what I would ask that it may have been blood tinged or nobody saw it. And from there, I probably would have assumed the fact of this is bronchitis, they're doing better, and prescribed the Robitussin. I don't know, though. Unfortunately, the individual demise the next day, I never received a call from them again, and my usual habit would have been to say, well, if anything changes, call me. If there's any concern, call me. If there's a concern, send him on in if you need to, because my habits would be to, what do you see in the patient? They were my eyes and ears there, and there were nurses there, and it was an infirmary, and that would have been the case. The next thing I even knew anything about this entire incident of the death of the patient was a couple years later when the complaint against the prison system, CCS, the nurses, and myself came. I had prior to that, though, I had my wife had been in health condition. She had cancer, and I had already resigned from them prior to that. However,
did you keep any records on when you would get any of these phone interactions, like when we're on call? I always write the date of birth, the name of the patient, what was done, just to be able to have some sort of record of some sort.
I was on call for about 5 or 6 different prisons, and no, I didn't. I had no ability with the prison system, with their systems to do this. So I didn't take notes myself. They're kind of a system where I didn't have a chance to interact with them. I knew no one there. I couldn't get on a medical system of where I could leave notes at all. It would so no, I didn't.
I was just wondering if you kept notes for yourself, your own record.
I did not.
Okay. Questions from other board members?
No, that's one of my primary concerns is an interaction without keeping charting. Part of the contract with the prison system is actually the contractor shall create or be made to create such medical records. Granted, that's just one clause in a long contract. But otherwise, the information that was given at the time of the call is not terribly unstable. Hemoptysis is always a concern in the prison population, and I'd probably have a lower threshold. But my opinion's in hindsight, not foresight. So I could only sympathize with the information you had on the call.
How many times did they call you?
Just once.
On this one.
And they told you it was coughing up blood, did they say?
I'm assuming, again, without a recollection, I'd ask, did you see blood? Is he saying he has blood? Because as you know, in the prison system, oftentimes, they'll cut the finger and put it in the urine so they can say they have kidney stones, so they can go on to the hospital, or they'll do different things like that.
I'm just curious why you took that job in the first place.
I said the same thing.
It's very serious. Well, why would you take a job where you have no contact, with no record, where you're relying on somebody you can't see?
I appreciate the question. I'll tell you why. The person that asked me, they were having difficulty with that. But they also know I initially had an interest in prison ministry for individuals, fathers and things that I thought I could develop something in there in the future, and I'd still like to down the line, I'll be honest with you.
So you had some missionary zeal.
There were ulterior motives, yes, there were.
Because otherwise it makes no sense.
No good.
It was nominal.
As you say, Dr.
It was nominal payment that I got from that, so yeah.
No good deed goes unpunished.
That was going to be my comment.
All I can say is I have a favorite poem. Of all the words of tongue and pen, the saddest of these it might have been, and that's I look back at with that.
Any questions from other board members?
No.
Dr. Prof. What would you like to do with those?
I would like to dismiss it.
You want to do a letter of concern?
I don't think a straight dismissal is appropriate in this case because there certainly are still standards of care, and the doctor's quite smart enough to know what he's walking into also. I think it does raise to the level of a letter of concern, but not disciplinary.
Yeah. Letter of concern is non-disciplinary in the state of Arizona.
But if I may address the board, it is something that is posted on the board's website. And I can tell you from past cases that I've had where I've represented providers that have weekend coverage. The provider who does get a call over the weekend and is asked about a patient's condition, that provider will maybe give orders to the institution, and those orders are recorded, but the provider does not make a formal chart entry on behalf of the provider. They might give an email update. I got a call about this patient. They were a little bit dehydrated. I ordered labs and fluids, for example. But, there's no formal chart entry, and those records are not kept in perpetuity.
That being said, Mr. Smith, there was a formal agreement on a contract of a physician-patient agreement here.
But those agreements, I believe, were for physicians who are contracted to actually be in the prison.
The contract that we're given was the contract that had those statements in it. Was there another contract that I'm not aware of?
No, but the CCS contract required that they provide the doctors within the prison system. The nursing staff at the jail were county employees. CCS provided the actual doctors that would actually go into the jail. And it's standard contract language that in those situations the doctor is required to create a medical record and have that medical record as part of the prison records.
Correct, but that is the contract that Dr. Furr had, correct?
It was the contract that CCS had. I would not believe in this situation where you're getting a call after hours and you're getting a telephone order that the provider would have to necessarily create a chart entry when the chart entry that you're supposed to make is an electronic chart in a prison and you do not have access to that prison
Mr.
system.
Smith, it's either a contractual agreement or it's not. It was a contractual agreement. He was being paid. There was a contract in place.
There was a contract, but when you look at all of the documents submitted, there was no complaint by Arapahoe County about this matter at all.
That's the question, though.
All right.
So I don't
you want to make a motion?
I make a motion for a non-disciplinary letter of concern.
For failure to diagnose pneumonia or record keeping? What do you
record
mean?
keeping.
Record
So all I'm
keeping?
just
Okay. Do I have a second? Do I have a second?
Yeah.
Can you give me a second?
No, Dr. Roos disagrees.
Okay. I'll make a second then, so we can move further. Any discussion before we go forward?
Cunningham, just a point of clarification, the letter of concern is non-disciplinary, and therefore it's not published on the website, but it is a public record for 5 years.
It's not published on the
Okay,
website.
because some boards actually put letters of concern on their
We don't do that.
website.
Just to clarify.
Right.
Thank you.
Okay. All right. Any discussion? Let's have a roll call, please.
Mr. Berg.
No.
Dr. Reese.
No.
Dr. Madem.
Aye.
Dr. Erbstrasser.
No.
Dr. Cunningham.
Yes. Motion fails to pass. Can I have another motion?
I'd make a motion for executive dismissal.
I have a motion for executive dismissal.
No dismissal.
For
just dismissal,
For
not
dismissal.
Sorry, dismissal.
Dismissal. And do I have a second? Dr. Erbstrasser. All right. Can I have a roll? Any discussion before we vote? Let's have a roll call again.
Mr. Berg.
Yes.
Dr. Reese.
Yes.
Dr. Madem.
No.
Dr. Erbstrasser.
Yes.
Dr. Cunningham.
No. So motion passes. Good luck, doctor. I hope this has been a valuable lesson to you.
It has.
Okay.
Thank you.
Really
very
appreciate
much.
your work.
Yeah, really.
Thank you.
Thank you.
All right.
You guys have a great day.
All right,
I
thank
shake
you.
your hands.
Have a safe trip back.
Thank you.
All right. Next case is DO-18-00898, Randy Charles Hancock, DO, license number 3297. Dr. Hancock, come forward, please. Welcome.
And I'm sorry, Mr. Chairman, I'm going to have to recuse myself from this.
Okay, so we'll recuse himself. We'll note that on the record for Dr. Madem. All right. Would you please swear in Dr. Hancock, please?
Please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes.
All right. Can you please give us a little bit about your training and the type of practice you have now, Dr. Hancock?
Yes, my name is Dr. Andy Hancock. I did my medical school at Kirksville College of Osteopathic Medicine, graduated in 96, did a residency at Phoenix General, and that became John C. Lincoln, and I finished that program. My interest was always rural health. I started a practice in Black Canyon City. I think that's nearly 20 years ago on that one. I converted it about 10 years ago into a non-for-profit. It's a 501c3. That made it possible for me to go to the USDA, and we were able to do special financing through them to fund a facility. And because of that, in that town, we're able to have pharmacy, phlebotomy, a cardiologist once a week, plastic surgeon every other week. And
are you a FQHC? Is that what you are?
Trying to be.
Okay.
So we're also with National Health Service. Okay. So that's kind of where I'm at.
Okay. Dr. Prawn, would you like to review this case?
This case was referred to us by the Arizona Medical Board, the PA Board, regarding concerns raised regarding Dr. Randy Hancock's supervision of PA Carrie Mallon. The medical board felt the PA Mallon had deviated from the standard of care by failing to follow CDC recommendations in that 5 of 6 patients that they... Five of 6 patients that they reviewed were on greater than 90 morphine milliequivalents per day. They also found PA Mallon deviated from the standard of care by failing to appropriately monitor patients on high-dose narcotics and failed to require surgical and psychiatric follow-up for a patient receiving high-dose opioids in combination with benzodiazepines with a history of bipolar disorder, anxiety, and a surgical lesion noted on MRI and EMG. They found he had fallen below the standard of care by prescribing benzodiazepines in combination with opioids and prescribed large doses of medication that caused respiratory depression in an asthmatic patient with sleep apnea. Dr. Hancock answered in his board response that he was asked by PA Mallon to serve as his temporary supervisor because of his prior supervisor had left practice. When staff spoke to Dr. Hancock by phone in September of 2018, he stated he had sold the practice in Spring Valley to PA Mallon when he needed a supervisor, he felt obligated. He states the practice is in a rural area and the people really need him. He states his practice is in Black Canyon City, which is about 30 miles away. He states he reviewed the records remotely 1 time per week and discussed the cases. He states he did meet with PA Mallon every other week to discuss cases in person. He stated he did not feel PA Mallon was overprescribing, and he feels he inherited these patients from another provider.
Doctor.
Do you want to hear
yes,
what?
Go ahead.
Okay. So PA Mallon took over the practice in Spring Valley. He had a physician there that was going to be his supervising physician. After being there a little while, he contacted me and said that he felt that the physician that was there was overprescribing, and he wanted to let him go, and he wanted to know if I would temporarily be his supervising physician while he brought the patients down from some of the higher doses that they were on. And I'd agree to do this, and by the way, this was without any financial compensation on my part at all. So I reviewed his charts, not all, of course, just samples. He appeared to be doing what he said he was doing. I reminded him on a regular basis that this is temporary. He was interviewing physicians. One of the physicians he interviewed was a naturopath, MD gone naturopath, and apparently that physician's answer was, I don't know, acupuncture and chelation or something, and so he kept bothering the PA, saying he was going to fix everything, I guess, I don't know, and the PA kept telling him that wasn't going to work because he had relayed the situation to this physician. That physician is the one that turned in the board complaint after multiple attempts to try and work with the PA. And then at that point, I don't think anybody wanted to get involved after the board complaint started. So I'm still involved with it. But as I talked to him and as I looked at his records, he was, and this started before the 90 MMEs, but he was trying to bring them down, from what I could tell. And I was comfortable because most of these patients had been existing patients on the narcotics that they were on, but he had some that he discharged that would not be compliant, and I felt that he was doing what he said he was going to do, and I felt that he was doing the safest thing for the patients.
Question for board members?
Oh, I'm sorry, and currently he has and I had suggested to him this before, currently he has pain management that comes to his office. So he's been working on that, and he finally got somebody to come in. They come in.
Is that after his board action that he had against him?
Yeah, after the board action.
So clearly there were deficiencies if there was a board action, correct, Doctor?
Well, I think that I reviewed...
What's my question, yes or no? Yes or no?
Was there deficiencies in...
his prescribing?
His board thought so, yes.
Yes. So there were deficiencies, is that correct?
Yes.
Okay. And were you supervising the physician at that time, PA at that time?
I was.
So then were you part of this then as well? Because you know there's an opioid issue here. So I don't really care for the attitude of the lackadaisical attitude about opioid prescribing, that you think he's doing okay. Clearly his board didn't think so. And I don't think you were supervising either, Doctor.
What do you mean? I don't know what you mean by I wasn't supervising.
Well, you're allowing him to go ahead and practice. He's a PA. He's under your license.
Well,
he's not an MP. He's not autonomous. He's under your license, Doctor. Do you understand that?
I do understand that.
Okay.
And
I must understand that it automatically overflows to you then, whatever his actions are, then also are reflected onto you. Okay?
I understand that.
Okay, good. I'm glad we're on the same page. Okay? So I think you have a deficiency, too, with how you were supervising him. All right. Do I have any other questions from other board members? Dr. Herbstrasser?
How are you supervising him now?
I'm still reviewing charts and discussing with him his patients.
Once a week, twice a week?
Weekly. But I understand there's a crisis, and I'm trying to understand.
You said earlier in your statement, before I started asking questions, you thought his prescribing patterns were fine.
He took over for somebody.
Doesn't matter.
And
doesn't matter. I don't care if he lives.
He started
75
bringing.
miles away.
He was bringing
30 miles away. There's a standard of care now. Okay.
But this all started before that standard, and he was bringing them within that standard.
It doesn't matter.
I don't know why it doesn't matter. It does matter.
I'm going to say it doesn't matter in how that we know that overprescribing, even before we had these new laws in place, there was overprescribing. We have issues with people overprescribing, and his board thought he was overprescribing. Do you understand?
I do.
Okay. So that's where I have the issue. You're supervising a PA that was overprescribing. Okay? I don't care where he got the patients from. I don't care if he had another physician that was prescribing. He picked up the baton and went forward with it. Okay?
And he was working on bringing them down, and he was successful in doing that.
Still found him not where he should be. Okay? Do you understand that?
I do.
Okay.
Well, perhaps you can learn from this. If you're still supervising him, what are you going to do differently?
Well, he's been interviewing other physicians to take over. Like I said, was doing this just to help. I thought I was helping the population in the area, because we even have patients that have written to the governor, and we have letters from the governor saying that if a patient was on 90 MMEs prior to this crisis, that they were okay to stay on that. I don't have any patients that I'm doing that with, but we have letters from them, from the governor, saying that. So it's very confusing when you see that, and I know you're appointed by the governor, and then we come to the board and hear that is not the case. So,
tell me what other things besides opioids how are you prescribing? How are you supervising him? Are you sitting down with him physically and looking at the charts? Do you meet?
Well, I meet with him, and
how often?
Weekly.
Weekly. So what day of the week do you? So if we
it's
keep a log,
it varies. I don't keep a log, and it's not.
You keep a log. Do you sign off on the charts?
No.
How do we know that you've done it then or not?
I didn't know I needed to sign off on the charts. I didn't know that was required. Like I said, this was a new thing to me, but okay. I don't know that you can know. I didn't know that I needed to sign off on them.
Do you meet with him in person or just over the phone?
I usually meet with him in person.
How many charts do you review at a time?
Usually 7 to 10.
And what kind of type of charts are they?
A mixture of it's just samples of everything. I felt that he was trying to help, okay. And I was too. Okay. And I felt that, and he felt the same way, that these patients were getting more than maybe is the most beneficial, so he was bringing them down, and I was trying to help him do it.
I'm glad to see that there's a pain management doctor in place, because clearly there's a problem that was occurring before that, okay? Right? Because his board admonished him for it, okay? So, and you were the responsible physician at that time, so you're the one on the hook, okay? You're the one on the hook. And you're still supervising, okay? So, I don't know. Any other questions from other board members?
What kind of practice do you have?
Family practice.
Family practice.
Yes.
It's a full range of family practice.
Yes.
How many patients do you see a day?
Me personally?
Yeah.
Oh. And this is not about my patients. This is about the PAs, because my patients are all within 90 MMEs. But I probably see about when the EMRs came in, I went way down, but I probably see 15 a day.
Okay. Any other questions, Dr. Oberstrasser?
No.
All right. I'm going to make a motion that he get a letter of concern for failing to supervise a PA properly, okay? Can I have a second? Second. Dr. Oberstrasser, any discussion before we vote?
Yeah.
Go ahead, Dr.
I understand that he's responsible. I just feel that he got sucked into something.
He's still doing
that. He really wanted to do the right thing, but he didn't know how. So I think I know where you're coming from and empathize with it, but nevertheless, what you did was not the right thing. You were trying to do the right thing, but what you did was not the right thing. You should have supervised him more closely.
Anything else? Can I have a roll call, please?
Yes. Mr. Berg?
Yes.
Dr. Reese?
Yes.
Dr. Erbstrasser?
Yes.
Dr. Cunningham?
Yes. Doctor, is again not to make you feel badly. This is hopefully a learning situation for you, and I hope that you will keep a log. I hope that you will keep on the calendar when you're meeting with your PA, and I will keep a log of the charts that you're reviewing with him. Okay. Good luck. We didn't get Dr. Matum for us.
And then are we all finished with the court reporter?
I think. Are we done with? Do we need them for any of the cases?
That was the last one.
Do we not need them for any of these other for compliance?
Oh, compliance. Yeah.
Hold on. Do we need her for the compliance? One? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 101, 102, 103, 104, 105, 106, 107, 108, 109, 110, 111, 112, 113, 114, 1 As a side
Of course, thank you.
Dr. Page, we are going to get that transcription. We'll do our best.
Yeah, that's right.
All right. So we don't need a corporate report anymore? We're good?
I think we're okay. Thank you.
All right. So we're going to go down then to 7. This is considerations and action in compliance with terms of board orders and requests to modify or terminate orders. The first one is AZDO-15-023A William W. Willis, license number 4742. Dr. Willis, can you come forward?
Dr. Willis is not signed in to speak.
Oh, Dr. Willis, did he say he was going to attend? Okay. Remind me about this one again, okay?
Would you like me to? Yeah. So,
Yeah.
Dr. Willis.
Oh, I remember now. Now I remember. Yeah.
He had in October 2017, his license was revoked because of an issue that occurred in another state. Where he was originally arrested in West Virginia for an outstanding warrant regarding unpaid gambling debts, and was charged with 2 felonies. And then he was summarily suspended in West Virginia, and then he also in April of 2016 he entered into an agreement with the Kentucky board that fully restricted his medical license indefinitely and pended reinstatement of his license with the resolution of the action in West Virginia. He appeared I don't remember if he appeared before the board in July of 2016.
Telephone.
Or with telephone, but
yeah.
He, anyway, so what happened is his license was revoked, but the revocation was stayed so long as he remained in compliance with the order. And he was placed on a 24-month suspension from the date of the order, and the orders were that he was to undergo a psychiatric evaluation, have a physical exam, and attend either PACE or CPEP for a practice assessment. And specifically says that the stay of the revocation should be lifted, and his license will be automatically revoked without a formal hearing if he doesn't comply. Thank you, with the board order.
Okay. So do we need to have do we just let it take into effect, or do we need to make a motion for it to go to lift the stay?
He still has a few months, and in theory he could comply. He has until October of this year.
That's right.
So I would just suggest that the staff monitor it. If he doesn't comply within that time, that they come back to you in October with an order lifting the stay and revoking his license.
Okay. All right. So we can direct the staff just what Gene said, and we'll see what happens in October.
And then we've been unable to reach him by phone or email. Is there any? Do we have any obligation to try to? I mean, is there any other way we could?
You just try your best with a record that you have, or the address that you have on record.
Okay. I don't. Are these other ones for actions and consideration? Are all the rest of these people here, or all these other ones we just need to talk about? I want to get people that are here needing to be.
Dr. Harvey is signed
Dr. Harvey, he is here. Okay. So let's do the next one, and that's DO-15-0196A William Scott Harvey, DO, license number 006072. Dr. Harvey, welcome. Have a seat right there. Welcome. Introduce your counsel with you. Introduce your attorney.
Paul Giancola.
Welcome, Mr. Giancola, again. All right. All right. Do you want to go through this one? Is this one yours, Dr. Prom? Okay.
So this case was originally opened way back in 2015 because of a call we received regarding a domestic violence incident that happened in Lake Havasu. It was It's been, the case has been continued for a long time because of obligations with the courts. He was asked to attend PACE for evaluation, and PACE found that he had a strong fund of knowledge and gave him pass Category 1. They had some other recommendations that we may need to go into executive session to discuss.
Okay. Should we go do that now? Or do you have...
That's all I have.
Okay.
Any motion in executive session?
Yeah, let's go into executive session for medical information. And so I have a motion. Do I have a second? Second. I have a second. All in favor, signify by saying aye.
Aye. Aye.
So can I have all just step outside then, please? And we're going to ask ask the doctor some questions about medical information. We're out of executive session for medical information. I'm going to make a motion pursuant of what we discussed in the executive session for the staff to craft what we had talked about. Can I have a second? Second. Second by Mr. Birch. Any discussion? All in favor signify by saying aye.
Aye. Aye.
All opposed, same sign. All right. Good luck to you. Thank you, sir.
Thank you.
All right. Next, I'm all out of whack here. Just a second here.
Yeah,
so, next is D-14-03078, Robert Ian Marouk, DO license number 3583. Dr. Marouk, would you come forward, please?
Mr. Thompson.
Oh, Mr. Thompson, I'm sorry. Did I go wrong? Hang on one second. I'm so sorry. I have jumped the gun again. I apologize. Have a seat. I'm sorry, Dr. Marouk. I apologize. Next is DO-18-01558. Joseph Christopher Thompson, DO, license number 007732. Dr. Thompson, please come forward. Please have a seat over on this side, please. All right. And then, is this your attorney?
Yes, sir.
Okay. Can you introduce your attorney with you?
This is Mr. David Cohen.
Okay. Welcome, Mr. Cohen.
Thank you.
All right. Do we need to go into executive session for this as well? Okay. We need to just go straight into executive session.
So moved.
Okay, so I got one motion. Do I have a second?
Okay.
We're going to go into executive session for medical information. Please all step out one more time.
Everybody's getting their exercise.
All signify by saying aye. All opposed? Okay. Forward, Dr. Marouk. And do we need to go into executive session for this too? Oh, where's Dr. Pra? I'm sorry.
She's in the restroom.
Okay, have a seat there. Go ahead and relax.
My guess is we are going to have to go into
Yeah, we're going to have to go and say. So we can do that without her here, can't we?
But you can stay.
You stay. Okay, you stay. And then I make a motion we go into executive session for obtain medical information from Dr. Marouk. Can I have a second? Who was that? Dr. Madam. I'll signify by saying aye. Aye. I'll oppose same sign. Please stay right there. Marouk. And we're wishing you the best. Good luck. All right.
Dr. Cunningham?
Yeah.
Sorry to interrupt. Dr. Payne is not present, so if you'd like to move on.
Yeah, let's just go ahead and go to the ones that everybody's here. Who's the next one?
Dr. Mann.
Okay, next we're going to talk about applications and licensure. This is DO-19-00568, Jonathan Paul Mann, DO, license number 005979. Dr. Mann, come forward here, and you've got your... We just met your attorney, the attorney before. Okay, welcome back again.
Thank you. Double duty.
Double duty today. All right. Can you bring us
for recommendations?
All right, good deal.
Who's there?
Do you want to bring us up to date on this?
You saw Dr. Mann
Last time. Yeah.
last time, and the board had asked for a report from one of his physicians. And that
Do we have to go into executive session again?
we probably do. The notes are in your.
Let's go into, do you want to go into executive session? Let's do that so we can ask questions. I got a so move. Do I have a second? Dr. Madam, all in favor, signify by saying aye. Again, good luck to you guys going back and forth. I hope you don't go into labor before you leave. You went up and down so much. Okay. All right.
And deliver, she does.
This is still on.
He delivers, not me.
We don't have a pediatrician here.
Well,
We're
Do I need to make a motion, or just take no action on his?
If that's the consensus of the board to take.
So do I need to take a vote? Okay. Okay. We're going to take no action on his answer that he had answered yes on in his application. Good luck to you, doctor. Travel safely. Thank you for teaching our residents. Okay.
Thank you. My pleasure. Thank you.
All right.
Thank you.
Who else is here, Justin?
Let's see. Dr. Esinger.
Okay. So next is DO-19-0072A, Brandon William Esinger. Did I say that correctly? Okay. Come on forward, doctor. And have a seat right there. Welcome.
Thank you.
Would you like to go with this, Justin? Is this yours?
Just a moment.
There's a yes response.
Yes. Dr. Esinger applied for a license on March 18, 2019. Dr. Esinger disclosed a yes answer on his application. Dr. Esinger was arrested for a misdemeanor charge on March 24, 2018. Dr. Esinger states the charge was dismissed and there's no conviction.
It was a domestic assault, as I recall.
Yes, sir.
Tell us what happened here. What went on?
So just kind of a brief summary. This was last March 24th. My girlfriend, who I'd been dating at the time, we'd been dating about 8 or 9 months. We'd broken up multiple times during that period. It was the worst relationship I'd ever been in, very, very strained. So on this evening, we had been out with some friends, and we got into a verbal argument. Upon returning to my apartment, she refused to leave my apartment, and it escalated into a physical altercation. I did shove her, trying to get her out of my apartment, and then she called the police subsequently. So,
was there any alcohol involved?
I had been drinking earlier in the night, but I was working the next day, so I had stopped earlier in the evening. So I had not been drinking. She was heavily intoxicated at the time. So yes.
Were you guys driving? You take Uber?
No, I drove us home because I had stopped drinking.
Okay.
Yes.
Any previous history of any issues like this before?
No, none. This was an extremely isolated incident. I have a completely unremarkable record. It was beyond me that it would ever escalate to that point. It was a huge mistake on my part. I should have never, tried to get her out of my apartment myself. That was my mistake. I should have just called the police myself. In hindsight, so yeah.
Where are you going to go practice?
Here, ideally. I do have a job lined up here.
Where are you going to go practice? What are you going to be doing?
Oh, emergency medicine, sorry.
Oh. Where at?
The Abrazo hospitals.
Okay. Yeah. You might be talking to this guy every so often. He's not a Brazo.
I don't talk to a Brazo.
Yeah.
He's at John Seeley. Any questions, Dr. Reese?
No.
All right. Can I have a motion?
Motion to grant him full license.
I have a motion to grant him an unrestricted full license. Can I have a second?
Second.
Dr. Erbstrasser. All in favor signify by saying aye.
Aye.
All opposed, same sign. Welcome to the state of Arizona. Good luck, doctor.
Thank you.
Thank you.
Remember, if you have one drink, get Uber. I'm just going to tell you that, okay?
Yes, sir.
One drink, okay?
Well learned.
Okay. All right.
The next case that the doctor is present for is Dr. Davi. If you please come forward.
Which one?
2019-0070. Yeah, number F.
F. Okay. DO-19-007. A welcome, Manzi Dave. Is that correct?
Mansi Dave.
Okay. Thank you. I like your accent, how you say it, much better than I do. Welcome. Can you, I think we've been through this with her before, haven't we?
Mm-hmm.
Yeah.
So basically the report I was going to give is that that she has applied for a license. She disclosed a yes answer in application. She previously had appeared before the board during her postgraduate training application. The board reviewed that and did approve that PGT for her then. So if the board
remember her. Yeah. How are you doing now?
Good.
You're not drinking, I'm sure, are you now? Okay. How's life?
Good.
How was your residency?
Great.
Good. Where are you going to go into practice?
Internal medicine, and I'm currently interviewing right now.
Oh, here in Phoenix?
Mm-hmm.
Is that your husband behind you?
Yes.
Congratulations. Boy or girl?
boy.
Okay. Any questions board members have?
No.
Have a motion?
Motion for unrestricted full
Dr. Reese,
license.
motion for unrestricted license. Second with Dr. Madam. All signify by saying aye.
Aye.
All opposed, same sign. Good luck. When are you due?
Thank you. End of August.
Close then. Okay. You got to let us know how everything turned out. Okay. Good luck to you. Okay.
That's long. That's
Where
all
are you
summer
practicing?
long.
I'm in North Phoenix.
Where-
Pediatric dentist.
Oh, okay, great. All right. We're glad to have it.
Stay
All right.
inside this summer. Because you're going to be hot.
Yeah, okay. Good luck to you. Listen to Dr. Pross. She could give you a lot of motherly advice, okay?
Thank you.
Who's our next one, Jason? Justin.
That is everybody.
We got all?
That's here.
That's here. Okay, so let's go then back to David Payne. This is EDO-17-0292A, David Levon Payne. So help us out on this one. You know, he got frustrated with me, so
Yeah, so
what do we need to do with this?
he was, so Dr. Payne was supposed to have a neurology evaluation, a neuropsych evaluation. You ordered him to have his records from his cardiologist, his primary care physician, his pain management physician, and records from Banner Desert when he was seen in the hospital. You ordered all those be sent to the board before October of 2018. He has not sent us anything, and I don't know that he's gone to any evaluations. He also should have renewed his license by December 31st, 2018.
Yeah,
Did
six
not.
month grace period.
He had a grace period. His license would expire on May 1st, 2019. He did not renew, and so his license is currently expired. You'll see a little note that he
Is it
called.
expired or is it what do you call that?
Suspended expired.
Yeah, suspended expired.
Yeah, because we have a case, an ongoing case.
So Dean, remind me again what I have to do with this because he's not going to do it, and
So, open a complaint for noncompliance.
so we need to make a motion to open a complaint for noncompliance.
Yes.
So moved.
So moved by Mr. Burch. Can I have a second?
Second.
Dr. Madam, all signify by saying aye.
Aye.
All opposed, same sign. And that disposes of it then?
Well, we have to bring it back again.
Yeah.
Then.
It'll go through the process.
Okay.
But you can refer it to formal hearing then.
So you'll see it again.
Okay. Justin, where else do we need to go?
The next one is. No, we didn't. That's okay. Kirk Ciancillo.
Number E.
And Dr. Pra will provide that report real quick.
Go ahead, Doctor. Was he here?
No.
Why isn't he here?
So we attempted to contact him. He was going to try to make it, but he was unable to get here in time. So we informed him that the board would at least consider it and determine if they'd rather have him here in person in the next month.
Is he out of state or something?
Yes.
He's out of state.
Well, the problem is isn't this where he did a prostatectomy and then he ended up with a fistula or something?
Yeah.
Correct.
Malpractice. And it was $700,000?
Yeah.
1.6.
1.6 total.
Well, I mean, he needs to come and talk to us.
Yeah.
Okay.
Okay.
Have him come talk to us.
Okay. We'll let him know that he needs to be here next month.
Yep. Okay. Anyway, where else now?
And that, I think, concludes all of it.
Do you want to talk about your...
So the two items that I
There's
have...
no medical students, so we can skip 10.
Yep.
Okay.
So 9A is the oral proceeding. We didn't receive any public comment on the rules other than, so there's a suggested rule change. I'll give a brief history. When Jenna was here, she opened a potential rulemaking dealing with the opioid prescribing CME hours, as well as some requirements in the licensure regarding the fingerprints and background checks. After that, there was no action taken on it. When Dr. Pra stepped into the interim role, she took the baton and reopened the proceedings and got everything moving. So we're moving forward with those prescribed changes. I had an additional suggestion that's a non-substantive change, but in the licensure policy, we're incurring significant delays in the requiring for primary source verification for practice experience. So requiring that hospitals provide that primary source information directly to the board. Hospitals are reluctant to give it, as well as difficult to get and determine that it's primary source. So we suggested following what the medical board did, which is just require a list from the doctor of all that practice experience, and then if the board had any concerns, they could go back and ask for 7 years of that primary experience. And then the other part of it would be always requiring copies of the national examinations, no matter when they were taken, and those should come directly from the examining body. So that would save some significant time on our licensing department.
Let's do it. Do we have to do anything?
You just
say, yeah, let's do it?
Yes, direct staff to adopt those changes.
I direct staff to adopt those
We would
changes.
come back to view them, though.
No, they're provided in the report.
But we didn't have the oral proceeding of one.
So we would do a separate oral proceeding, not in front of the board, on a separate meeting, so that we could gather public comment on those. If there's no substantive changes, is the board okay with we preceded those?
Anybody else?
That's good.
Sounds good to me.
Okay. Then the last, the board-approved PHP assessors, monitors, and group facilitators. The board staff would like to request that the board approve this list that's been provided. We've gathered it from various other agencies to provide additional options for both the doctors that are.
Did you get us another list too?
I gave them some additional names.
Okay, good.
Yeah, so this is a very comprehensive list used by medical boards.
I'm glad to use it because then we got somebody other than suture.
That'd be great.
Okay. Okay.
Some other options for both the licensees as well as the board.
I didn't say that.
She did a dance.
So, if the board would like to make a motion to adopt that acceptable list.
I make a motion to adopt that list. Can I have a second?
Second.
All in favor, signify by saying aye.
Aye.
All opposed, same sign. Okay.
That moves us to tab 11, the executive director's report. Provided the director dismissals in April, the board dismissed 6 cases through the executive director's dismissal. I also want to let the board know I've changed and provided a little bit more information on the pending complaints, so the board can actually see we have total pending cases, so 174. We have 39 cases waiting initial investigation, 58 cases that are open and in the investigative phase, 32 cases open for either the investigative or consultant review, 13 cases ready for the 3 reviewer process, and those will be sent out next month for the 3 reviewers. Then we have 13 cases pending case review and investigative hearing. Those are set for the June agenda. You have 15 cases that you dealt with today specifically, and then there are 4 cases that were on the committee review, and so those will be taken care of today. So,
how are we doing with our applications?
That is another area that we are addressing. As of April 15th, and this was provided on Wednesday, we've approved 44 applications and gotten those taken care of. So far, we've received 335 in fiscal year 19. The average day per application is 94, so I'll expect to see that to drop here in the next couple of months. And something I would like to point out is staff has been processing postgraduate training. We usually get about 500 of those between May and June. As of Friday, we had 0 renewals that were pending. Those had all been processed, and we only had 68 that were yes answers on the initial application or needed to be processed. So we're moving forward rather quickly on those, and so staff is doing a great job taking care of those.
Wow. Good job, guys.
So that's the licensing. I just wanted to highlight some of the budget for you. As of this month, 88% of the fiscal year has lapsed. Our fund balance was about $2.1 million. We have received 96% of our estimated revenue. We've paid out 89% of our appropriation, and so we should finish right on budget this year.
Perfect.
Okay.
Good job.
That is the report that I have for the board. If they have any questions,
Anything else?
if I do have the legislative update, if you wanted to know specifically about any of the bills, the ones I wanted to highlight were.
Just tell us the highlights.
Yep. Highlights, I'll be real quick. SB 1086, which was temporary licensure. I know it doesn't directly affect the board, but that was passed and signed by the governor's office as a governor's initiative. 2569, universal licensing recognition, was signed. That will be effective 90 days after session. The other one that I wanted to highlight for you is 2519, PAs and physician relationships. That has gone up for 4 PAs per doctor, is now 6. So you could.
Crazy.
That's nuts.
That's nuts. We just had a doctor here that wasn't supervisor.
Couldn't even do one.
Yeah.
No, we're going to do 6.
Well, not him.
So, and then the last one is 2068, clinical nurse specialists. This was allowing clinical nurse specialists to be able to prescribe and expanding that scope. It directed the nursing board to work in consultation with our board as well as the medical board on establishing rules and prescribing limitations.
I don't like that PA thing, man.
So
they're going to do it. So we're done.
So
that has been passed or has not been passed?
That has been passed, signed, and is effective in 90 days.
Wow.
How many CRNAs can a doctor supervise? Do you know?
I don't think they're autonomous.
To who?
I think the
CRNA? No, that's an
Or am I
not
thinking
a CRNA.
I think they have to be overseen by an
I'm
anesthesiologist.
almost positive you're
I
correct,
just don't
but
know how
nursing
many
practitioners
you
do
can
not. Different license.
Right.
That's a question to ask about. Does he have any? Who's supervising the CRNAs?
Yeah.
That case we had earlier today.
Yeah. Mine isn't.
Well, no, same with ours. We supervise.
Yeah. Okay.
That is all I have for the board.
Can I entertain a motion for adjournment?
So moved.
So moved. Second. All in favor, signify by saying aye.
Aye.